is better, so we will go a little fact heavy, and whatever I feel can be tested, I'll include it here itself. Have tried to make it, one stop shop where everything possibly can be covered. A lot of concepts also which we will cover mainly in, trauma approach, breast approach. So we'll go both concept and fact heavy. So this is one of the very high, strong subjects that, you can make through this video. So let's start how we've divided so many topics that we have to do. I'll start off with general surgery, then we'll go to trauma, then we'll do thyroid and breast, and then we'll cover a few small topics like, wound healing, bariatric surgery. Then we do the big ones: vascular surgery, urology, gastro and hepatobiliary towards the last with transplant. So that's going to be the flow of this talk. I've arranged it in order of yield, means smaller topic, higher yield in the beginning, and then big ones like GI, which a lot of it has radio overlap, towards the latter half. So let's start off. The first thing we are doing are all the things miscellaneous about general surgery. The first thing I'm going to talk about is a summary of all the nerve injuries. Like if you remember orthopedics also, I started off with a similar slide where we compile all the places and the nerve injuries because very commonly asked topic. So let's start with this high slide. What is the nerve that's injured most commonly when you have axillary clearance during breast surgery? So whenever you're doing axillary clearance, the most common nerve injured is intercostobrachial trunk, all right? And this corresponds to T2. All right, so with this, we can actually correspond and learn the dermatomes of the abdomen right here, right now. So you can see axilla T2. How many axilla do we have? 2. How many nipples does one have? Unless you're Chandler, 2. So 2 2s are 4. So T4, level of nipples. Here we are talking about dermatomes. We are not talking about the vertebral level. So that is also important. Xiphoid has X, 6 has X. So T6, xiphoid. Umbilicus is round in most of us. So umbilicus 1 and 0. So T10. But here they confuse you and they ask you what is the vertebral level of umbilicus. So that's not T10. If you cut through the umbilicus, which vertebra will you cut? So that becomes L3. So the vertebral level, L3. And then you have T12 inguinal ligament. Quick recap: axilla T2, xiphoid 6, umbilicus 10, nipples 2 2s are 4, inguinal ligament T12. Right, so this is about the dermatomes of the abdomen. Right, going to thyroid surgery now. So thyroid surgery, there are 2 possible nerves. First of all, understand the concept. So at the superior pole, as the name suggests, we will have the superior laryngeal nerve. This has 2 branches, external, internal. Which one? Only external laryngeal nerve. All right. Internal laryngeal nerve cannot get injured in thyroid surgeries because this is what runs in the piriform fossa, right? So if they ask you where can ILN get injured, piriform. So that's one. If they ask all nerves can be injured except ILN. Then at the inferior pole, we have the recurrent laryngeal nerve. And that is why there's a question, how closely do you ligate the vessels with respect to the thyroid? So both the superior and inferior thyroid vessels are ligated close. The reason for that, so superior thyroid artery is the farthest near the capsule. So it's best to ligate it near the capsule so that the nerve is not injured, because superiorly it does lie closer. So that's what you remember. We ligate it close to avoid injury. Simple. Then inferiorly we ligate it again close to the thyroid capsule, and the reason for that is this inferior thyroid artery also supplies the parathyroid. It also supplies the thymus. So if I ligate it away, the other organs will undergo ischemia. So that is why both the superior thyroid vessels and inferior thyroid vessels are ligated close to the capsule, right? So the reason for that is different for both. Inferiorly, I want to avoid ischemia to other organs. Superiorly, I want to avoid injury to SLN. So that's the relevant anatomy and the concept so that you don't have to memorize. Now, if I ask you out of these two, which is more commonly injured? So it's SLN. So this is most commonly injured more than recurrent laryngeal nerve. There are various sites where RLN can get injured, but we'll talk about that when we go to thyroid, right? So right now we have learned a few things itself about thyroid surgery. Superior laryngeal nerve, ELN, RLN, inferiorly, ELN becomes the most common nerve that is injured. Any other nerve that can get injured? Yes, even ansa cervicalis can get injured if you ligate, very superiorly. So theoretically, yes, it can get injured. All right, so they can ask you an all except kind of question. So that's why I'm giving you three, which can be injured. Then let's talk about parotid surgery. Very, very important. So parotid surgery, three nerves can get injured. They'll describe one scenario each. Deviation of angle of mandible. Very important. This is marginal mandibular nerve. What is this a branch of? It's not mandibular. It's seventh nerve. All right, so it's a branch of seventh. Remember, we have learned it in facial nerve anatomy. 10 zebras bit my cat. So what was my? It was marginal mandibular. So this is seventh, key branch, marginal mandibular, deviation of angle of mandible. Anesthesia at angle. What is the supply of the face? Sensory supply. Everything is trigeminal. The only exception is the shaving angle, and that is supplied by the great auricular nerve, GAN. And this great auricular nerve is C2, C3. All right. Now let's do few more points about this. One is shaving angle, the only part of face not supplied by trigeminal. First point. Second point, the great auricular nerve in the neck runs very superficially and it runs with this vein, that's external jugular vein. So they can ask you a labeling image. Remember in leprosy, we have seen one thickening of GAN. It's a superficial nerve, right? So that's GAN. Then it also, you can see how it's going into the ear. So this is what supplies the lobule of ear as well. As the name suggests, it's supplying a lot of ear. So lobule as well. So these are a few questions about great auricular. What all? Shaving angle, C2, C3, runs with EJV, supplies lobule. All right, thickened in leprosy. So many questions. Then phrase. What is phrase syndrome? First of all, so phrase syndrome is gustatory sweating. So this is where when one is salivating, they'll have sweating. Why is this happening? So gustation is what is a cholinergic process, or I can say parasympathetic process. But sweating is a sympathetic process which is mediated through cholinergic. That's a different thing. So it's the only sympathetic cholinergic function. But basically what happens is, because of injury to this particular nerve, there is mixing of the sympathetic parasympathetic fibers, and anytime there's salivation, there's sweating and flushing of the cheek. Which nerve am I talking about? Yes, auriculotemporal. Remember, this is the postganglionic nerve of the otic ganglion. Do you remember from ANAT? You have the ninth cranial nerve, otic ganglion, auriculotemporal, that supplies the parotid, right? So this auriculotemporal nerve is injured. So these are three questions from parotid. Submandibular surgery. Now here we have to be careful. If I just ask you submandibular surgery, you can say, ma'am, marginal mandibular nerve is overall the most common nerve injured in submandibular. But if I ask you that I am operating on the duct, close relation with Wharton's duct. So Wharton's duct is the duct that most commonly, first of all, gets the stones. So stones in the salivary gland are most common in submandibular because here the secretions are the most mucinous. The secretions are very thick, so they can undergo stasis and form stones. Okay, so Wharton duct, if that duct is being mentioned, the nerve in close relation is lingual nerve, right? So you have to be careful. General question पूछ रहे हैं, marginal mandibular, duct पूछ रहे हैं, stones पूछ रहे हैं, we go to lingual nerve, right? Then another nerve which is also in relation to submandibular gland is hypoglossal nerve. So again, there could be a possible question. All nerves can be injured except, so I'm telling you three: marginal mandibular, lingual, and hypoglossal, right? Nothing else. Then hernia. So in hernia surgery, various one-liners. So again, I'm giving you the presentation, you guess the nerve, and then I'll tell you the one-liner. If they say that following hernia surgery, there is loss of sensation over the lateral thigh. What is this? This is lateral cutaneous nerve of thigh, also called as lateral femoral cutaneous nerve. Okay, this happens to be the most common nerve that is injured in lap hernia. Lursae lap, lursae lateral femoral cutaneous nerve. So lap hernia we will study when we reach hernia. If and when we reach hernia, we will talk about a triangle of pain. All right. So in that triangle of pain, this nerve is injured. So lap. Remember meralgia paresthetica, Mick Roberts, same nerve. So many questions again from lateral cutaneous nerve of thigh. Loss of sensation over suprapubic region. Can I say suprapubic is just below umbilicus? Umbilicus in terms of literature, we say gastric. So this is hypogastric. So what is this? This is iliohypogastric nerve. All right. So this is hypogastric sensation. Here you have two one-liners. This is the most common nerve injured in mesh entrapment. H for H. Mesh entrapment. What nerve gets entrapped? Iliohypogastric. Second, this is the most common nerve injured in Rutherford Morrison incision. This is the incision that we are going to give for appendix, right? Or for any urological procedure. It's a lateral incision. So that's iliohypogastric. All right. Then loss of sensation over root of penis. So this is inguinal area. So this is ilioinguinal nerve. This happens to be the most common nerve injured in open hernia surgery. So you know vowels stick together, I. So look at I, most common nerve injured in open hernia surgery. Okay. And then if they say loss of cremasteric reflex. So what is this? This is the genitofemoral nerve. This is the reflex whose afferent and efferent are both genitofemoral nerve. And what is this root? This is L1, L2. Yeah, so this is L1, L2 reflex, genitofemoral. So the genital branch is what causes the sensation, the afferent, and the femoral branch of genitofemoral is the efferent. So same nerve carrying afferent and efferent. Then thymus. So there's only one nerve coursing through the mediastinum. So that's the one that has to get injured. That's phrenic nerve. Then this is an Ames PYQ. Rectal cancer surgery. While ligating the inferior mesenteric artery, they had asked which nerve gets injured. So that is where you have the superior hypogastric plexus. Okay. So superior hypogastric plexus. Now focus on SIR. So for SIR, this is what supplies the sympathetic fibers. Okay. On the other hand, possible, while you are doing pelvic dissection, let's say there's an let's say there is an open prostatectomy. So pelvic dissection, possible, these are parasympathetic fibers which are called as nervi erigentis. Okay. So while you are injuring sympathetic, parasympathetic, what will happen? For this, you remember a mnemonic, point and shoot. So P is parasympathetic, point. Point means erection. So loss of erection, this leads to impotence. Okay. So this is parasympathetic, point, impotence, whereas sympathetic is what is responsible for shoot. Shoot meaning ejaculation. So this is what leads to retrograde ejaculation. All right. So this is how you will remember the deficit, point and shoot, S and P. Yeah. So this is everywhere you can see a SIR here, and this is everywhere you can see a PER here. So this way you will not mix up the two. All right. So these are the summary of all the nerve injuries. You expect at least one question, from this page. Next, we talk about sutures. All right. So first of all, we divide the sutures into absorbable, non-absorbable. Now, how does a suture get absorbed? So the mechanism was asked. So naturally absorbable sutures are what are absorbed by means of enzymatic degradation. Because they are causing enzymatic degradation, this is the one which has maximum tissue reaction. Okay, so this is I9 November 25 question. On the other hand, synthetic sutures gets absorbed by hydrolysis. Okay, so that's done. Let's talk about the only natural absorbable suture, which is catgut. Now I've tried to color code it. So this is brown in color. Yeah. So we'll look at the highlighted part in a bit and what is its significance. But first, let's focus on catgut. The suture color is brown to copper color. Okay. Now catgut is not derived from cat's gut. It is derived from sheep gut. I don't know why they did not call it sheep gut. So this is what is sheep's ileum's submucosa. All right, and that happens to be the strongest layer. So that is why this is the submucosa, which has been sterilized by isopropyl alcohol. And who discovered it? Obviously, a hunter. Yeah, so there's a guy called Hunter who discovered this from the sheep's ileum and made this into a suture and sterilized it using isopropyl alcohol. Okay, then what do we need to remember? So catgut, it gets absorbed in around 60 days. But if you add copper to it, chromic catgut, this is what increases the life to around 90 days, and this is what we use for tubal ligation, right? So whenever you are doing a tubectomy, we have learned that we use the modified Pomeroy's method. So in order to suture this, we will use a chromic catgut according to the Government of India guidelines, right? So this is about catgut. Then let's talk about synthetic absorbable sutures. So here we have monocryl. Monocryl is polygicaparon. You need to remember both of these names. So monocryl is what we use for subcuticular sutures. This is white in color. Now I didn't use white because it won't come out well in the print. So for logistic reasons, I couldn't color code it. But this is a white suture and you could actually understand it if you knew this is subcuticular sutures. Alright, then you have PDS. PDS, as the name suggests, PD, polydiaxonone. So PDS is PGS. PGS matlab pancreaticojejunostomy. Where do we do something like that? Whipples. So that's how I have remembered PDS is PJS. Okay, so Whipples. Another place where we use this P for port site closure, right? So in laparoscopic surgery, when you want to suture and close the port site where you put the ports, we will use PDS as PJS. All right, then we have vicryl. You can see how wonderful it's violet. So this is violet in color. So you will remember violet. So vicryl, violet tubes. That's what I want to remember. Vicryl, say violet. Violet ka T tells you T for tubes. So this is what we'll use for suturing various tubes. Tubes means either I want to suture ureter, bowel, fallopian tube, anything which is a tubal structure. Vicryl. Okay. Then Dexon. Dexon, nothing much. This just has maximum risk of infection. That's all you want to remember. Okay. Then that finishes off absorbable sutures. Non-absorbable sutures, there's only one natural one, silk. Silk, as the color coding says, is black in color. Alright, and this is what is used to secure drains onto the skin. Anything that you put like ICD or any post-op drain will use a silk suture, non-absorbable. Synthetic non-absorbable ones, nylon gets you a lot of questions. So nylon is used for many miscellaneous things, for suturing nerves, for tendons. It's used for cataract surgery, which is a repeat question. And another one which is a repeat question is for neurosurgery and microsurgery. So that is where we use nylon. So two questions from nylon. Cataract and neurosurgery. Then you have proline. See the color coding, it is blue in color, right? So proline or polypropylene is blue in color. This is something which is very high tensile strength, okay? So we use this material, not this suture, for mesh also. So you can remember it on this line only, that this is something we use for making meshes of hernia. So that's one. So because this is so strong suture, where should I use it? Do you agree I would use it for vascular anastomosis? Yeah. Do you think I should use it for rectus sheath? Yes. So this is where we utilize the high tensile strength for vascular and rectus sheath anastomosis. These two, nothing much. They are just the classes you can remember. It's non-absorbable synthetic, Novafil, polyester, right? Now, look at the macro level. 1, 2, 3, 4, 5, 6. The 6 sutures which are all highlighted yellow. What does that mean? So, the 1 sutures which are highlighted in yellow are the ones which are monofilamentous. So, that can also be asked. In fact, I think this has been asked in NEET 25 exam. So, the monofilamentous sutures are highlighted, whereas the others are polyfilament. Alright. Now, what is the advantage of being polyfilament? Very logical. Anything which is polyfilamentous will be stronger. Yeah, but the problem is because you have multiple filaments which are going, there are various crevices which happen, and because of those crevices there is a higher risk of infection in polyfilamentous sutures. All right, so this is all about sutures, very factual, but very high. In the last 2-3 exams, the questions are directly coming from these. Now we talk about suturing techniques. Okay, so look at the images and tell me the type of suture. So this is where one is doing a continuous suturing and there's only one knot towards the end. So this is continuous suturing. Then you can see how at the end of every suture bite there's a knot. So this is what is showing you interrupted. This is simple interrupted suturing technique. Then look at this. This is where there are no knots that you can see. So what is this technique? This is the subcuticular technique, and that is why this is very good cosmetically. So this is what is preferred for cosmesis. And what were we using here? Monogrel. Very good. Then you can see these two. So these two are mattress sutures. Now what you can see here is this is parallel. When you see a parallel mattress, this is horizontal mattress, and when you see perpendicular, this is vertical. So pehle parallel, then perpendicular, then alphabetical order. That's how you can remember. Horizontal, vertical. Okay, so this is horizontal mattress and this is vertical mattress. Vertical mattress sutures gives you the best eversion of margins. All right, the margins of the suture bite you've taken are going to be outwards, everted margins, and this is what we prefer for skin sutures. Okay, but never for bowel. When you are suturing bowel, you don't want everted margins, you want inversion. Okay, so that's why this is not preferred for bowel, is what we need to remember. Eversion. Then one more one liner with horizontal mattresses. This has the least cut through. Okay, whatever that means, the surgeons will know. So this is what has the least cut through, is what we need to remember here. So these are the techniques and a few one-liners. Now I said we're going to give a knot. So let's look at 5 types of knots. This is a question which has been asked very recently. Surgeon's knot was asked. So surgeon's knot is the easiest because you can see there are 4 on one side, 2 on the other. So the moment you see 4, 4, you know a surgeon has to be behind this. So this is surgeon's knot. Okay. Then when you have 2 folds each, now you have to see what's happening to these things. Are they coming close to one another and going, or are they going away from one another? So once it goes away from one another, if granny will slip, she may go away from us. So this is where the sutures are going away and granny was slipping. So this is granny's knot and it has higher chances of getting slipped. So that's how you'll remember that this is not granny, this is square or reef knot. So you can call granny as pseudo square or pseudo reef, doesn't matter, call her granny only. Okay, so granny slips away. All right, then there are 2 extra ones where you don't see this kind of a thing, you are seeing horizontally. Okay, so when you see only one thing which is crossing over, not two things, only one thing, this is what is called as half. Aadha hi hai, so half hitch. Whereas this is weird, this is crossed half hitch. Okay, so just like keep these figures in mind. If you see 4 on one side, surgeon, 2 on both sides, granny or non-granny, one only, half hitch or crossed half hitch. Okay. Then we forgot one technique. What is this technique of suturing? Where you do a suture round and then you close it like this. Remember, you have these purses that can be closed through a string. So this is your purse string suture. Now, purse string suture used in 3 places. One, we use it for cervical incompetence. Okay, so can you imagine if the cervix is incompetent, I can close it using the suture. All right, then I can use it for herniatomy. Yeah, so if I am opening the hernial sac, I can close it using these sutures, and then I use it for rectal prolapse. Let's finish rectal prolapse surgery right here, right now. So this is an image. Imagine this rectum is prolapsing out. You push it back and I close the rectum. Does it make sense? So this is called as the perineal approach, whereas you can pull it up through abdominal approach. Do you want to remember these names? Absolutely not. You will say this is tad bit too easy. What do we mean by tad? Thiersch, Altemurs, Delorme's. Okay, so this is tad bit too easy. Don't even remember the full forms. Nobody will remember. You will just say tad bit too easy is perineal. Everything else which is not tad, you don't remember, is abdominal. Right? So this is done. Now, whenever you're taking a suture, let's say this is the length. If this is the length x, itna, how much will I have to take suture? It has to be 4 times. So that is called as Jenkins rule, that you will have to take 4 times the length because you'll have to go down and come up and all, right? So 4 times. Then the angle of entry of suture needle PYQ is what is 90 degree. So you will take a 90 degree bite. Okay. Same angle you can remember is the angle for intramuscular injection. All right. On the other hand, Veery's needle is going to be put at 45 degrees, and that's the angle of subcutaneous injection as well. So that's also done. Intradermal, because you have to remain flat within the dermis, the angle is going to be 10 to 15 degrees. So 90, 45, 10 to 15. All right. So this is about angles. Now let's talk Veery's needle. Before we go to Veery's needle, we will first finish off suturing. Okay, so what are the things needed for suturing? This was a very old AIMS question, can return, pretty basic. So they're just checking, have you ever sutured a wound, right? So what are the things you will need? Imagine you have to suture something. What will you need? You'll need a suture. Please don't stop there. Okay, so I'll need a suture, but I will hold that. So this is what is going to be my needle holding forceps, where I hold the needle of the suture which is attached to the suture. I will need this tissue holding forceps. I will need scissors, and I will need to give a stab maybe using a blade. So let's study each of these in detail. Now, these are all the blades which are available. They can ask you. So the blade which is attached to this Bard Parker handle. So this is the BP handle on which you attach the blade. What is the job of suture blade number 10? So this is the first one that I am studying. So first kya cut karenge? Skin and muscle. So this is what is used for incising the skin and muscle. Then look at 11. This has been asked. So 11, I is for eye, incision and drainage. So this is what is used for incision and drainage. And this is also used for vascular incisions. All right. So this is incision and drainage. 12 has this curved edge to it, and that tells you that this is what is used for removing sutures. So number 12, removal of sutures because of its curved end. 15 has a small blade, so this is what is used for precise cuts, small cuts like plastic surgery, minor OT procedures, ganglion cyst removal, etc. We'll use blade number 15. And 22 you can see has a huge length to it, looks like 10 but bigger. So this is what is used for abdominal incisions, right? So abdominal incisions, we will use number 22. All right, so they can ask you these numbers. What is this? This is your needle holding forceps, and they ask you that where do you hold this needle? So first of all, look at this. So this is your suture and this is the needle. This end is called as the swaged end, and this is the pointed end. So you can just remember, people who have swag, okay, do not really pinch you. Okay, in Hindi you can say जिसका swag होता है वो चुभते नहीं है, right? So you can remember, this is the pointed end, chubega. This is what will hurt, but this is the swaged end. All right, how do you hold it? You hold it away, right? You don't want this needle to hurt you. So that's what you remember, that you will hold it 2/3 from the pointed end, 1/3 from the swaged end. That can be asked. Then you have this tissue holding forceps, which could be toothed or non-toothed, and this is called as Adson's tissue holding forceps, the most basic ones. All right, and then we have two scissors. Chota naam, small name, small scissor, Mayo. The longer one, medicine bomb. So you can see medicine bomb, longer name, more slender one, Mayo, shorter one. So shorter name, shorter scissor. So these are all the things we need for suture. Now let's discuss all about laparoscopy and a few advances from laparoscopy surgery. So we start off from Veery's needle. What is the one thing you know about Veery's needle? We insert it at 45 degrees from the skin. Okay, now when you put a Veery's needle, you are essentially trying to create pneumoperitoneum. You are trying to insufflate the peritoneum, right? So that technique is called as a closed technique. Okay, so that's one thing. The site where you put the Veery's needle. So what are the different sites where we put? The most common site that is preferred is the umbilicus, around the umbilicus, because it heals without leaving a scar. It merges with the umbilicus. The other points which we can use are Palmer's point. In fact, Bailey Love writes that Palmer's point is being the preferred point for most surgeons nowadays. So either umbilicus or Palmer's points are preferred. Usually it's umbilicus, Palmer's point is preferred, or alternate points like Jane's point are preferred if you have past history of any surgery. So if there is past history of surgery, we are dealing with adhesions, then umbilicus may not be a safe area, like you can see in this image. So now let's discuss. This has never been asked so far, so this is give party to ma'am question. What is Palmer's point and what is Jane point? There is this Lee Yuang point also, but why will we listen to him? We will listen to our Jane, right? So this is Jane and this is Palmer's. So Palmer's point is important. What is the location? So you can see this is in the mid-clavicular line and it is 3 centimeter below the left costal margin. So I'm going to write it here that this is 3 centimeter below left costal margin. So that is Palmer's point. Okay. Then what is Jane point? So Jane point, for that you come 2.5 centimeter medial to anterior superior iliac spine and come to the level of umbilicus. So it is at the level of umbilicus, just basically lateral to it. How do we measure that point? You palpate ASIS, go 2.5 centimeter medial, come to the level of umbilicus. Alright, so these are 2 points, factual questions. Then there is another technique, open technique, where you directly puncture using the trocar, and that's called Hassan's technique. Okay, so that's done. Now, let's go back to Viris. So, I'm puncturing with the Viris needle. They will ask you, how do I confirm that you have reached the intraperitoneal location? Alright, so for that, there are 3 things that you can do. First, you will try and push some saline, okay? The saline should be free flowing. So, the saline should go inside with a free flow. That's one that you know you have reached. Second, you try and aspirate, from the needle. You should have air bubbles which come out, because if the same fluid comes out that you injected, that would mean that you are in a closed cavity. So that is why the same fluid should not come out. It should just be some air bubbles which come out. And the third technique that can be asked is hanging drop method. So using hanging drop method, in the hub of the needle, you're going to place a drop of water and you basically pull the abdominal wall. So because of the negative intraperitoneal pressure, that air bubble will get sucked inside. So these are the 3 methods we can use to confirm the intraperitoneal position. Now I'll show you one video here. So look at this. So this is where we are inserting the Viris needle. Okay, so we are puncturing the Viris needle inside. While puncturing, there should be 2 points of resistance. The 2 points of resistance would be, one when you puncture the rectus, and second would be peritoneum. So 2 resistance and you are inside. Okay, so now you are removing and you are attaching, you are removing the stillet and you are attaching basically a syringe. Okay, you can remove the Alice forceps at this point, which was holding the muscles here. So you've inserted the syringe and now we try and inject the saline. Okay, so when you inject the saline, there is going to be a free flow of the saline. Yeah, so you can see that. Now you are aspirating, and can you see how there are just air bubbles coming out? So that again confirms you are in the peritoneal space. Okay, and you do not really, you are not in a closed cavity. This is the hanging drop method. This can be asked. So we've put the hanging drop, it's there, and when you lift the abdomen, you can see how it went inside because of negative pressure. Yeah, so that is what we have to remember here. Alright, so now you've confirmed you are in the peritoneum. What is the gas you're going to inject? CO2. So CO2 is preferred because it is soluble, right? So this is a soluble gas, non-combustible. The only place you may want to avoid it is in COPD, because the patient anyways has, risk of hypercapnia. So you can avoid and use other gases like N2O, air, helium, right? So other gases can be preferred. The ideal pressure that you can use here is important. This is 12 to 15 mm, right? You never go above 20, but ideal, if it's asked, it's 12 to 15, and the ideal volume is less than 2 liters. So around 2 liters. You can remember the number 2, 12 and 2 liters. And the rate at which you inject is 1 liter per minute. So that's the usual rate at which you inject it. So 2 liter of CO2 is injected. Now, while you are insufflating, CO2 and creating pneumoperitoneum, what may happen is the patient may show a transient bradycardia, or there could be a transient heart block, and that is called as the J reflex. This is a PYQ, and that is because of peritoneal stretch. Okay, so that's the J reflex. Then this has been a question which has been repeated twice in INICT. So they have asked both azimuth angle and manipulation angle. So these are the angles between different instruments that you put. Okay, so this is your main telescope or the camera through which you are seeing, and this is your working instrument. So azimuth angle is between the telescope and the working instruments, whereas manipulation is between two working instruments, right? So that's the angle of manipulation. So both of these are working instruments, whereas elevation angle is the angle between the working instrument and the horizontal, right? The horizontal plane. So that's how much elevated it is. So manipulation, you are manipulating two instruments. Azimuth angle between the camera and the working instrument, and horizontal and working instrument elevation. Okay, so these are the different angles. Now let's talk about a few advances. Can you tell me what is happening here? So this is the surgeon who's doing something, whereas these ports, robotic ports, are actually performing the surgery. So this is what is a Da Vinci. This is one of the trade names. So Da Vinci robotic surgery. You may get a question on what are the advantages. On the other hand, this is what is a single incision laparoscopic surgery. So we have given a 2 to 3 centimeter incision at the umbilicus, and through that only all of the instruments are going. So this is relatively bigger incision at the umbilicus, but then there are no other port sites, right? So the advantage here obviously is going to be faster recovery. There is going to be no scar here, only one umbilicus scar. But the problem here is the risk of incisional hernia is higher because you're giving a bigger incision. Okay, so that is single incision lap surgery. That's one advance. Da Vinci robotic surgery, the advantage obviously is what the robotic arm offers are the weaknesses of humans, right? So this is better precision, tremor reduction. But one of the disadvantages here obviously is you cannot touch and feel, loss of tactile feedback. Right. So now there's a concept of degree of freedom, right? So this is the number of movements which are allowed. So in laparoscopic surgery, this is a limitation where only 4 degrees of freedom are allowed in terms of the movements which are possible. But robotic surgery has a feature called endo wrist, and because of that, the wrist movements which are in a robotic arm are very similar to a human being, and that is why this is a major strength of robotic surgery, and it gives you 7 degrees of freedom. Now this is a new concept which has not been asked so far, so remains a potential question. Then let's talk about the instruments. So you can be asked to recognize one of these. So forceps and retractors. Let's go. So this is the one which is your Kelly's hemostatic forceps. This is what you must have heard. Arteries दे दो, artery तो artery नहीं देना, artery forceps देना है, right? So this is Kelly's hemostatic artery forceps. Okay, so you can see there is a lock. Every forceps will have a lock except 2, which we will get to. And you can see these transverse striations. Whenever the striations are transverse, these are traumatic, right? So that is why this is used for hemostasis. It can block the vessel. Then you can see this is right angled. Again, everything will have transverse. So this is your mixters. This was asked in AIMS around 2 years back. So this is mixters right angled forceps. Okay, so this is mixters forceps. Then you can see a set of tooth here, one tooth each. What is this here? So this is what is Cocker's forceps. So this is something which can also be used for ARM, yeah, in OBGYN, artificial rupture of membrane. It will help cut the membranes, right? So that's Cocker's. Multiple set of teeth. Do you know a girl called Alice? Even if you don't, you can imagine Alice has multiple teeth. Yeah, so Alice, multiple teeth. So that's Alice's forceps. And this one, triangular one, is green Armitage forceps. Both of these are used in LSCS. Okay, so these are both used in LSCS. So that has also been asked, the instruments used in LSES. So these two forceps are used. Then look at this. This looks like something can hold a tube in it. So this is what is Babcock's forceps. Just have we used violet tubes. Remember, vicryl, violet tubes. So this is the forceps counterpart of that suture. So this is Babcock's forceps holding tubal structures such as fallopian tube, ureter, bile duct, etc. This one here, do not mix it with Babcock's, right? So this is Rampley sponge holding forceps. I'm sure all of you have held this for cleaning, draping. That's all we get. So this is Rampley sponge holding forceps where you clean and drape using the sponges. Then you can see this one. This is where you can see the striations are not transverse, they are vertical. Yeah, so that makes this atraumatic, and this is why we use it to hold bowel. You don't want to block the bowel, isn't it? So this is the intestinal clamp, and because it has longitudinal striations, it's atraumatic. All right, so that's done. Then look at this. These are the two forceps which do not have a lock. So that's the first thing you see. All right, ki lock nahi hai. Then see the shape. If it is closed like this is what is ovum forceps. Not used in surgery, used in OBGYN. You know, this is used for your dilatation and evacuation, for removing retained products of conception in MTP. So this is ovum forceps, whereas this one which is open, right, which has a hole here, this is Desjardins CBD forceps. Okay, so this is used for removing CBD stones. So Desjardins CBD stone, meaning choledocholithotomy forceps. Don't remember the big name. We are removing CBD stones. And lastly, this is your towel clip. Yeah, so why would they ask this? Just remember, it's Mayo's towel clip. They would be stupid to ask that. So these are all the forceps. Then the retractors. So retractors, look at the shape. So this is Z. So with Z, you will remember Zernez retractor. C is silent. Look at this. Here you can imagine one line and make it a D. So this is a Devers retractor. Then you can see one L shaped here. So L is Lagenbach's retractor. Make the L mota. Mota means Morris's retractor. So everywhere I'm giving you a trick so that you don't forget. Now make it curved. So this is Doyen's retractor, and I'm pretty sure all of you must have held this Doyen's retractor in your life during LSCS while baby comes out. So this is what is used again in LSCS to retract the bladder while we remove the baby, while you take out the baby. And this is what is the value of intern. Intern can be replaced by adding 3 parts. So this makes it 1, 2, 3, 4 parts. So you will remember Balfour's retractor. And this is what is a self-retaining Doyen's that can be used in LSCS. So this is self-retaining, no need of intern. Alright, so these are your retractors here. Then look at this one. This is Joel's self-retaining thyroid retractor. You can see how this can retract the strap muscles. Very old question they asked, how many will you need? So obviously you need to retract on both sides. So you'll need 2 Joel's retractors per thyroid surgery. Then we are looking at 3 mastoid retractors. They've been asked as a match the following question. So first of all, see them at a macro view. There are 4 teeth-like things here. There are 3 things here, and one of them is solid here. So first of all, the solid one is Perkins mastoid retractor. Okay. Then where you see 4, this is Mollison. And this is Janssen. Now I'll tell you the most amazing trick ever. So Mollison, 4 and 4. Janssen, 3 and 3. So that's how you can understand how many teeth they are, so that you can easily match without even knowing. So all 3 of these are mastoid retractors. Alright, so this is what we need to remember here. Okay, so now we are looking at a few bags and drains. Okay, so this is a simple abdominal drainage kit, right? So any, abscess you are draining or post-op you are draining, you'll connect it to a bag. So this is a simple bag, abdominal drainage bag. Then when you see this line, that's the hallmark, right? So it's like any other bag, but when you see this line, this is what is your chest drainage bag. And why do we need this line? So this is what is for your water seal. Okay, what is the advantage of this water seal? So whenever you place an intercostal drainage tube, it's going in the pleura, right? So here the problem is I do not want the air to go back inside while I want to drain air or fluids out of it. So this is why we put this ICD. Imagine this is the ICD. I put it underwater. I put water till this point and my tube should reach here. Okay, so what happens because of that is during expiration, whatever has to, come out will come out through the pleura, and during inspiration, you will not have air going back inside. You will just see the water column moving. So because of this, the water column will rise because of negative intrathoracic pressure, but because it's underwater, you will not see the air going back inside. So that is what you are trying to do here. So because of the oscillating water column, you know that basically everything is normal. So during expiration, you can see it's coming out. During inspiration, the water seal just rises up. So that oscillation is normal. But just one thing, if you see too much oscillation persisting, the pneumothorax is not resolving, that would indicate that there's a persistent air leak, and persistent air leak in trauma, always suspect a bronchopleural fistula. If that has happened, then the air, it's constantly going to go into the pleural surface. This can also follow, biopsy. Let's say you did a bronchoscopy and you made an injury and there's a fistula. So bronchopleural fistula, the pneumothorax never goes away. It keeps on draining. Yeah, so that's one hint here. So that's about water level, water seal. Then these are two closed drainage bags. This was asked just last year in INICT. So this is what is your Romovac suction drain, whereas this is Jackson Pratt suction drain. And the common thing about both of these is these are closed suction devices. All right, so this is where what you do is you're gonna press this, right? So you press these corrugations or you press this bulb here, and that creates a negative pressure, and that creates suction for the drainages to come out. So these are post-op drains. This is frequently used for abdominal surgeries, your Jackson Pratt, whereas Romovac is used for, thyroid, breast surgeries. That's where we are gonna use it. Look at this. So this is what looks like a pigtail, but there is a pigtail on both sides. So this is what is a DJ stent, double J stent. So this is a DJ stent that is used for ureteric stenting. So this is nothing but a ureteric stent. So you can see this X-ray. This has been asked. This is a DJ stent. You can see the two J's. So this is used to stent ureters following surgeries, right? So wherever you've done a ureteric surgery, in OBGYN surgeries for suspected ureteric leaks, you can put this DJ stent. And they had asked what route do you insert it from? So it is inserted via the bladder. So this is inserted through a cysto-urethroscopy. All right, so that is DJ stent. Then look at this, only one pigtail, right? So this is a pigtail catheter, which is the catheter that you put for any abscess or collection, right? Any intra-abdominal abscess or collection, we put this pigtail catheter. We use the Seldinger technique to put any of these catheters. So what is Seldinger technique? See, imagine this is the skin. All right, I use this puncture needle. Every puncture needle has a stillet inside it. Okay, so I've punctured the skin and I've put my, so imagine this is my needle and I've punctured the skin. Now I take out the stillet. So do you agree, now I have a cylindrical passage? So now I take out the stillet and through that I insert a wire, a thin wire. Okay, so now a thin wire has gone inside the collection. All right, let's say this is the abscess. So now I've placed a wire. Now I take out the rest of the needle through that. So now I have not lost my access because the wire is inside. And now over this wire, I thread my pigtail catheter. So यहाँ पे wire है, उसके ऊपर से we will put our pigtail. So can you now understand that this is the pigtail? I straighten it and I put it over the wire and I take out the wire and my pigtail goes inside and it folds. Because it has folded inside the abscess, now it doesn't come out. Somebody pulls on it, doesn't come out because it's secured here. So that is what is Seldinger's technique. Needle dala, wire ke upar catheter. Okay, so this is pigtail. Then if I want to put this catheter, this is where you can see a flower at the end. This is Malacot's catheter. Yeah, so Malacot's is what is used also for SPCs, suprapubic cystostomy, and this is also used for thick abscesses, bigger chronic abscess. Pigtail is not able to drain, put a big one, Malacot's catheter. And this is your T tube, right? It's also called as Course T tube. So the coarse T tube is what is used for CBD surgeries, right? So if you've done any CBD exploration, right, you can put this. So how this works is you can see the T. So imagine this is the skin and this is the CBD. This is the intrahepatic radical. So you put this horizontal part here and you take it out through the skin. So essentially you can just put contrast here later on and you can see if it's draining inside, right? So you can see if the CBD is patent or not. So this is for the post-op drainage also, and you can see the patency of CBD through outside also. So this is what is the T tube, that you are seeing. So these are the different drains. Then we look at the hemostatic devices. So this is what is called as a monopolar cautery. So this monopolar cautery you can see has two dots, blue and yellow. So blue is glue. Glue matlab this is used for coagulation, whereas this yellow one is what is used for cutting. So this is for cutting, whereas this is for coagulation. So monopolar cautery. Now the problem with monopolar cautery is the current goes inside. Now it passes through the patient and I have to put a grounding pad on the thigh through which the current is completed. The problem with that is because of that I cannot use a fluid that can conduct electricity. So that is why the only fluid I can use here which is available readily is distilled water. Means I cannot use ringer lactate or normal saline which are electrolyte rich. So I can use distilled water. If not available, I can also use glycine, but glycine obviously not very readily available. So that's monopolar cautery. On the other hand, this bipolar cautery is where the current is completed within the cautery itself. So there is no grounding pad which is needed and I can use electrolyte rich fluid like ringer lactate or normal saline. Okay. Then there are these devices which are used again for vascular sealing. So we have ligashore. So if you have bleeding and you want a cautery, so this is what is used for a vascular seal. As the name suggests, ligate, ligashore. So vascular seal it creates and the energy that passes through it is pressure as well as radio frequency waves. So it uses radio frequency waves as well as pressure to seal the vessels. Then you have this harmonic. It again same purpose, but now it uses oscillations. Okay, so this has multiple harmonic oscillations. You know how harmonic waves are these. So it uses these oscillations, and thunderbeat uses both. Yeah, so it uses radio frequency waves as well, and it uses these oscillations as well. All right, so that is what is thunderbeat. This is kusa. Kusa you must have heard, during neurosurgery, gallbladder surgeries. So this is a cavitatory ultrasonic surgical aspirator. So again, just like harmonic, this also uses ultrasonic sound waves which cavitate. So this is also something which is used for tissue dissection. So we can create these tissue planes without causing much bleeding. So it keeps on creating these planes, bloodless planes. So this is kusa. Then you can see two staplers. From the image itself, you can understand this is a linear stapler. What are some uses of a linear stapler? One is Zenkers, right? So in Zenkers diverticulum, you may use to staple Zenkers, whereas this is a circular stapler. Where can we use this? For hemorrhoids, right? So this is for hemorrhoids, currently the treatment of choice. So these are a few hemostatic devices. Then let's talk about the surgical safety checklist. So a lot is going on, but I've highlighted, the most important things here. So this is what has been given by WHO. Okay. First thing that you need to know are what are the three phases. Then we go inside them. Okay. So we have sign in, time out, sign out. There's no time in. Time in, nothing, So there's no word like time in. So you have sign in, time out, sign out. Okay, so SNS separated by T. That's first thing. What is sign in? This is before induction of anesthesia. So this is where only the nurse and the anesthetist may be present in the surgery. The surgeon has still not come. Then this is where now everybody is there in the OT before the surgery begins, before skin incision. So this is where nursing team, anesthetist and the surgeon, everybody is there. And this is before patient leaves the operating room. Again, here everybody is there. So this is after the surgery is complete. Okay? So sign in. What is the main priority? That patient, now you'll ask the patient, what is your name? What is the site procedure? You confirm you've not gotten the wrong guy inside. Yeah. Written consent. So I've written it in red. It's important. The site is marked, anesthesia safety checklist, pulse ox, पेशेंट एलर्जी है, डिफिकल्ट एयरवे, मोर देन 500 ml ब्लड लॉस का रिस्क है, all of these things. So you can think of it like everything relevant to nursing and anesthesia team. Before skin incision, you confirm all members have introduced themselves. Okay. Surgeon, anesthetist, and nurse now confirm patient side procedure. This is important. Any anticipated critical events, and now they just confirm that they diya tha antibiotic. So you remember we give an antibiotic prophylaxis. Usually that's cefazolin injection that's given 30 to 60 minutes prior to incision. So 30 to 60 minutes prior to incision, this is what is given. So right now you're just confirming that you have given or not, and whether essential imaging is there which has been displayed or not. Before the patient leaves, you will confirm, what procedure was eventually done, and this is important. You do the sponge count, instrument count, you see that the specimen is labeled. Those two are crucial things. Any equipment issue, if it happened, will have to be noted so that it can be rectified. All right. So apart from that, any other recovery issues. So whatever is important, I have highlighted. So let's do a quick quiz. Where is written consent? First one, sign in. Where do we confirm if antibiotic has been given? Second one. What is second one? Timeout. Everybody has introduced one another. Timeout. Sponge count is what is sign out. All right, so this is what we need to remember. Then you have 4 OT zones. The first one is the protective area where you have reception, waiting and everything. This is not sterile. Then you have zone 2. This is the clean area. This is what is your pre-op recovery, which is pre-op and post-op, right? So this is clean area. Then you have sterile area. So this is what is operating room anesthesia. This is where you sterilize yourself, wear the OT clothes, and only then you are allowed inside. So this is clean, this is sterile, and fourth is dirty, disposal area. So this is the waiting area. Clean area where you will change, pre-op and recovery happens. Sterile area is only inside the OT, and disposal area. So this can also be asked. On similar lines, this is also an update, can be asked. ERAS protocol, enhanced recovery after surgery. So these are a few components that we can do as a part of the ERAS protocol. So in pre-op, what are the things? Here we are avoiding extra fasting for the patient. So no prolonged fasting. Previously we would say 8 hours for solids. That's now 6 hours. For clear liquids, 2 hours. Okay, this is under ERAS. If they ask you just a general question, say 8 hours. Okay, but if they mention according to ERAS, then 6 hours. Carbohydrate loading. This is where you will give a glucose drink. Let's say you mix Glucon-D in water and you give it. This is given one night prior to the surgery, and this is also given 2 hours prior to surgery. Okay, so that also helps in the recovery, doesn't allow hypoglycemia to happen, and no bowel prep unless you have a GI surgery happening. Intraoperatively, minimal access is always preferred, like laparoscopy. Maintenance fluids are given. Maintain temperature, meaning avoid hypothermia. This is important. You will give at least 2 classes of drugs for post-op nausea, vomiting, right? Because this is what is the most common cause of readmission. That's also one-liner we have done in anesthesia. So the 2 classes usually are either ondansetron. Ondansetron is your 5-HT3 inhibitor, and you can use steroids. So the 2 classes preferred are ondansetron and steroids, and you give long-acting LA like bupivacaine or epidural analgesia is preferred. Post-op, early feeding start kar do. early ambulation start kar do so that you can prevent deep vein thrombosis. Discontinue IV fluids, this is important. Don't give unnecessary IV fluids. Encourage oral natural multimodal analgesia. Try to avoid opioids. Okay, so take care of pain of the patient but use opioid sparing wherever possible. Early catheter removal, so isme post op is the most important, right? So these are a few points they can ask you, all are true except kind of a question. Okay, so avoid IV fluids, early ambulation, don't give heparin unnecessarily, right? So all of these pointers you can take care of. Then let's talk about causes of post-op fever. So here we will remember this day wise. Okay, so there's a mnemonic: wonder drugs. Imagine you did a lot of drugs, after that you would want to go out for a walk. Yeah, you would also want to drink some water. So you are telling your friend, I'm going out to catch some air with some water and I'm walking. You are so high that you will fall and you will have a wound. So wonder drug, wind, water, walking, fell down, wound. So that's the sequence. So wonder drugs, basically this is something that happens immediately post-op or anytime, are drug reactions based on what was used, or malignant hypothermia because of the anesthetic agents. So that's the cause of fever, either intra-op or immediately post-op. Then if it happens 1 to 3 days, wind, what was wind? It is atelectasis. So collapse is what is the cause of fever on day 1. So that can be asked as a one-liner. How to avoid that? Incentive spirometry. So you must have seen patients, either pre-op setting, early post-op, they do this inspirations. You ask them to take such a deep breath that all of these 3 balls should be upper, they should come up. So that, it incentivizes, it gamifies the whole process of taking deep breaths to prevent basal atelectasis. Early mobilization, antibiotics. Early mobilization will ensure patient is not constantly supine and the bases of the lung won't collapse. 3 and 4, overall the most common cause of post-op fever happens to be UTI. If you don't use prolonged Foley's, this can be prevented. Day 4, day 5, DVT. This has also been asked as a one-liner, that what is the most effective technique to prevent post-op deep vein thrombosis. So obviously pharmacotherapy is the most effective, right? But doesn't mean we will use in every patient. We will encourage early mobilization and compression stockings, and this is also something that can be used. This is an intermittent pneumatic compression device. So this is also something that will ensure that the muscles are, the calves are moving and pumping blood, preventing DVT. So you can remember IPC, intermittent prevent intermittent pneumatic compression stockings. Do not mix this with this. This has numbers on it. Plus, this is only on the calves. This is throughout the body. This is what is a must. Military anti-shock garment. Okay, so this is military anti-shock. There's no T. I've just remembered it for mast. So military anti-shock garment. Okay, so this is what is used in, as the name suggests, this is used in the field setting, for shock. So if somebody in shock, we are, packing the entire body so that the venous return can increase in refractory shock. So anti-shock garment used in field settings. Day 7, now you have surgical site infections. So this can be prevented by dressing changes, giving pre-op antibiotics. So now let's talk about surgical site infections and the various scoring methods. So the definition of surgical site infection is any infection happening at the surgical site within 30 days of surgery or within 1 year of implant. If an implant is placed, then it becomes 1 year. If it is no implant, within 30 days. Okay, then there are 2 scoring systems that we need to know. The first one is the asepsis score. It's an acronym, right? So just first of all use logic. What will happen when you have an infection? Red हो जाएगा, erythema. If it is left unhealed, पहले serous discharge होगा, then you will have purulent discharge, and then there will be separation. Yeah, so serous, erythema, purulent, separation. This is logic. Then you have A for additional treatment. Any infection that requires giving antibiotics, requires incision and drainage, that gets a score. I has been tested. It's isolation of bacteria from the pus that's coming out. It is not in duration. Yeah, so that is what the question was. They had given in duration, which also sounds kind of correct. Yeah, so it's isolation. And any stay in hospital over 14 days. You can also correlate this with grievous hurt. So according to now the BNS, grievous hurt definition is any bodily pain for over 15 days is grievous hurt. So you can remember 2 weeks for both. What is Southampton scoring? So Southampton score is also very similar. See, normal healing with mild bruising or erythema. That's okay. The 2 is the only thing. So you'll remember erythema plus other signs of inflammation 2. Okay, so that's how you can remember. Then I have serous discharge, purulent discharge, tissue breakdown. So everything else is logical except for 2. Then we have 2 one-liners, burst abdomen. So burst abdomen usually happens around day 6 post-op, where the wound just dehisces, the surgical site opens up. The pathognomic sign is a salmon-colored serosanguinous discharge from the wound closure site. Okay, so salmon color, very important. Now the salmon color somehow medicine holds very closely. Normally in day-to-day life, have you ever said your salmon colored dress is too good? No. But somehow in medicine, they love salmon color. So one is burst abdomen. Then do you remember in otosclerosis, we had learned salmon colored active otosclerosis give sodium fluoride. Then you remember Congo red in amyloid, salmon colored staining. So 3 places, salmon. The management of burst abdomen is going to put this Bogota bag. All right, so you can put a Bogota bag and close. So that's just you are closing it for the time being. If you do not have a Bogota bag, you can cut a Euro bag and use it. So essentially, you are just closing the wound for the time being to prevent any secondary infection inside till you can close it again. Then intra-abdominal abscess, the most common site in supine position is the hepatorenal or the Morrison's pouch, because that is the most dependent area. But overall, most common in patients who are not supine, it's the pelvis. Yeah, because pelvis is the most dependent site in ambulatory patients. The investigation of choice here is a CECT because you can delineate the abscess, and the treatment is going to be pigtail drainage, right? You drain the abscess out. All right, so this is all about surgical site infections. Now let's talk about how to prevent these infections. So the most effective technique, yeah, this is also a very old dame's question. Most effective technique to prevent surgical site infection is actually you washing your hands. Yeah, the doctor washing their hands. So obviously it makes sense that they're going to ask you a question on what are the correct steps to wash your hands. Because if you don't know that, do you think it matters if you know the degrees of freedom in robotic surgery? It doesn't, right? So this is something which is non-negotiable. So there are these 11 points. Let's see. It's very basic actually. So wet your hands with water, apply enough soap. Now see what are you doing. Palm is the first thing. Then right palm over left dorsum and vice versa. So now we are cleaning the dorsum. Then fingers interlaced. Then back of the fingers. So पहले palm दोनों surface करा, फिर finger दोनों surface करा. Then thumb कर लिया, right? So then you are doing the thumb of both sides. Then rotational rubbing of clasped fingers. Then rinsing hand with water, dry hands. Use towel to turn off the facet, and now your hands are cleaned. Okay, so essentially you have cleaned the 2 surfaces of palm, you have cleaned the 2 surfaces of the fingers, thumbs and wrist surfaces, right? So rotational rubbing with clasped fingers. Okay, so like not that great, but you can remember these steps. Apart from that, you can also remember one question, that where will you not use alcohol rub? So always we can use an alcohol rub except one, when your hands are visibly soiled. So when you can see that your hands, have blood on it or anything other than blood which has soiled your hands, you will want to clean with soap and water and not an alcohol rub. Okay, so that is also an old question. Then we talk about very, very important, the 4 types of surgeries and their examples. So if you learn the concept, you don't have to memorize the examples here. So you ask yourself a few questions. Is there gross purulence you are entering, like operating an abscess? Has there been a perforation or penetrating injury more than 4 hours, or a wound has been open for more than 4 hours? So if the answer is yes, meaning you're operating abscess, perforation, or gangrene, this is class 4 or dirty surgery. Iska answer is no. So then, are you taking an emergency entrance into GI, GU, respi where there are organisms? Are you going into an inflammation? Or is there a major break in sterile technique? So either you are doing an acute cholecystectomy, yeah, or you have a non-sterile debris, an intern came and touched the gallbladder with their bare hands. So that's debris. Yeah. So all of this is class 3. In addition, this was asked in NEET 2 years back. Open cardiac massage. So open cardiac massage is the last resort, right? Where you are opening up the patient and you are doing a cardiac massage. It can't be planned that today 6 p.m. I'll open you up, do open cardiac. No, it has to be emergent, right? So this is what is class 3. If you are not doing an emergent, like for example, a planned entry, elective cholecystectomy, delayed cholecystectomy that we call as interval cholecystectomy or appendicectomy, that is what is class 2. Clean contaminated, for example, hysterectomy, lobectomy, LSCS, right? All of these are planned entrances. So this is where the inflammation has now subsided. So this is class 2. 2 has 2 C's, whereas C is 3. And if you are not entering any GI, GU respi, then it is clean, class 1. Mastectomy, hernia, thyroid, TKR, CABG are the examples. Alright, so now let's do the risk of surgical site infections in different surgeries. Why this classification? Because the risk of infections keep changing. So you can remember less than 2%, 2 to 10%, 10 to 20%, more than 20%. Yeah, that is why we give prophylactic antibiotic. So if you give cefazolin 30 to 60 minutes prior, now look at the risk. So less than 2%. This remains less than 2. This now you remember the table of 3. 3%, 6%, 9%. So these decrease significantly. Can you see? So that is why we use prophylactic antibiotics. But do you agree? The risk in clean remains the same. It was anyways low to begin with. So that is why here there is no need to give prophylactic antibiotic. Okay, because the risk is the same anyways. So why are you giving a risk of anaphylaxis because of that antibiotic, right? So this is where we do not give. So this is what we need to remember here. But just one small but here is that if you are putting an implant in a clean surgery, for example TKR, THR, then you can give that antibiotic, like very specific, precise, but just for your knowledge. Okay, so this is about the numbers. So remember, less than 2, 2 to 10, 10 to 20, more than 20, less than 2, 3, 6, 9. So now we talk about sepsis. Okay, so first of all, you have to remember that all of this that I'm teaching you right now is the old classification. SIRS, sepsis, severe sepsis, septic shock. First, let's do that because sometimes they do ask you that. SIRS is systemic inflammatory response syndrome. For this, you will remember a mnemonic white THR. You know, when you put an implant, total hip replacement, it'll be white on x-ray. Remember in ortho we have seen metal is white. Yeah, so white THR is the explanation of the mnemonic. What is white THR? White blood cells, temperature, heart rate, respiratory rate. You may or may not want to remember these values. It's okay if you don't. So white THR. So SIRS is when you have these markers. Kya tha? WBC, temperature, heart rate, respiratory rate. So what is unique here is BP is not a part, right? So here we are not talking about shock at all. So this is SIRS. If you prove that this SIRS is because of an infection, that is called sepsis. If you can prove that there is organ dysfunction, that is severe sepsis. And what do you think is septic shock? This is where one has gone into shock, and this is a shock that requires IV fluids plus minus vasopressors. All right, so any shock that requires the need of IV fluids or vasopressors is what is septic shock. So SIRS is white THR, Sepsis is saying it's because of an infection. Severe sepsis, organs are failing. Septic shock, you've gone into a shock where you need either IV fluid support or vasopressor support. Now we have the new staging. Now we don't use these terms. Now it's simple. It's either sepsis or it's septic shock. So what is sepsis? Now we use a SOFA score. We don't use SIRS criteria. Sequential organ failure assessment. So any SOFA score more than equal to 2 is defined as sepsis. And septic shock is any shock that, as we discussed above, requires IV fluids and or vasopressors in order to maintain the mean arterial pressure above 65 or your lactate more than 2. So these are the two parameters which are the end point, or the measures of systemic perfusion. We'll also write it as a one-liner. So here, septic shock, we are using two things. Any shock that requires IV fluids and vasopressors to maintain the pressure above 65 or to maintain the lactate above 2. Okay, so this is about the criteria. What we are seeing here now is the quick SOFA score. So quick SOFA score, not the same as SOFA score. SOFA score is very, very elaborate. We can't remember that. Quick SOFA is a bedside assessment. So this is a quicker bedside assessment of, the organ failure. So this is quick SOFA score. Here you can remember GARBA. What is GARBA? So this is where we are checking three parameters. One, GCS, any GCS less than 15. R, respiratory rate more than 22. Two people do GARBA, 2 to 22. And BP, systolic BP less than 100. Yeah, so 100 even number you can remember. So GCS not perfect, less than 15. RR more than 22, BP less than 100. So this is what is your quick SOFA score. Now because two people do GARBA, through that same logic you will remember the same three parameters are also used in RTS, that is revised trauma score. So we use the same three parameters for revised trauma score. Now that you are remembering this, let's just remember what is TRIS. So this is trauma injury severity score. That includes RTS, it includes mechanism of injury, it includes age of patient, and it includes a separate score, that is injury severity score, which gives a number to every injury. This can be remembered through IRMA. Okay, what is IRMA? Injury severity score, RTS, mechanism, age. All right, so we have remembered through quick SOFA RTS, through RTS TRIS. Okay, so these are few trauma scores. Now we use the sepsis 6 guidelines here. So this is where they tell that these are the 6 things which need to be done within 1 hour of diagnosing sepsis. And you can remember this as give 3, take 3. Means what? So this is what are the 3 things. Now use logic. Somebody is in septic shock. What do you want to give them? Do you want to give them IV fluids? Do you want to give them antibiotics? Do you want to give them oxygen? What 3 things would you want to take? Okay, I want to see their urine output, isn't it? So I will measure the clinical perfusion. I will measure tissue perfusion through lactate, and I will take their blood culture. So oxygen, IV antibiotics, fluid. You give, take blood culture, lactate, urine output. Okay, according to the same surviving 6 guidelines, what are the targets for perfusion? So these numbers become important. So for CVP, we want to maintain a CVP of 8 to 12 mmHg, central venous pressure. Can I say this is a surrogate marker of right atrial pressure? Yeah, so this is what tells us about the preload. What is the fluid status of the body? Mean arterial pressure tells us about the mean blood pressure. So this should be more than 65 mm, as we have discussed. Mean venous oxygen should be more than 70%. That tells you if the oxygenation is happening or not. And the urine output, should be more than 0.5 ml per kg per hour in an adult. Whereas in a child, you double this, becomes more than 1. Okay. So these are the targets that we need to follow here. On similar lines, now let's just study shock right here, right now. So what are the different types of shock? So let's understand the concept. You can never ever memorize this table. Okay. So as the name suggests, cardiogenic shock, the heart is not working. Yeah. So that's the problem. Now understand one thing. There are two players here. Whatever heart is pumping out and whatever vascular resistance is there. So when one falls, the other one can compensate. Yeah. So because cardiac output is low, SVR will increase as a response. What about CVP? Because the heart cannot pump out the blood, do you agree the pressure will increase in the jugular? Yes. So CVP increases. So use logic. Hypovolemic shock, the body is losing blood. So cardiac output decreases because there is no fluid. CVP will be low because there is no fluid. Can I say that CVP is the best indicator overall to estimate how much fluid deficit I have? Lower the fluid status, lower will be the CVP, lower will be the preload. So that becomes CVP. Yeah. SVR का क्या होगा? SVR will increase as a response. Then obstructive shock. Obstructive shock means one, tension pneumothorax or cardiac tamponade. This is where the heart is getting pushed from all corners and it can't pump out the blood. Net effect being can't pump out. So can I say it behaves the same way as cardiogenic? SVR will increase and CVP will also increase because heart can't pump out. So it will backflow. Yeah. Distributive shock is a septic shock. This is where the problem is here, that the vascular resistance is lost because of release of inflammatory mediators. Because there is no afterload, what happens? This is the type where cardiac output increases, and this is why this is called as a hyperdynamic shock. Because heart is pumping more, CVP falls. Yeah. So can I say this is the shock where the heart is actually pumping more blood? So this is the shock where even though patient is in shock, I will see warm extremities because there is no vasoconstriction, there's vasodilation happening. Yeah, there is no vasoconstriction in terms of vascular resistance increasing, and because heart is pumping so much blood, you will see that the mean venous oxygen is more than 70, more than what is required. So this is what is septic shock, hyperdynamic phase or distributive shock. Neurogenic. Neurogenic का example है spinal shock. All sympathetic parasympathetic tone is lost. So this is where the vascular pooling happens. The vessels are pooling blood. Because of this, everything falls. SVR has fallen. The blood is sequestered in vessels. So cardiac output falls. CVP falls. सब कुछ low. So let's do a quick recap. सब कुछ low मतलब neurogenic. Hyperdynamic matlab distributive. Two shocks where JVP was raised. One is cardiogenic, one is obstructive. That's it. Anything else? Hypovolemic. So just pick out on these one things and you will know the answer. Then there are a few indices that we use. So shock index is heart rate upon systolic BP. Modified is heart rate upon mean arterial pressure, and rope is heart rate over pulse pressure. So the numerator remains the same. And can I say because BP is in the denominator, the indices will increase. So any shock or modified shock index more than 0.9 is bad because that means the BP is low. So that is what is a marker of a critical shock. So this is rope, heart rate upon pulse pressure. Yeah, this more than 3 is bad prognosis. Then let's talk about few more parameters. The best clinical indicator for adequacy of resuscitation, as we discussed, urine output. Best lab parameter, as we discussed, is the lactate, because if I do not have oxygen, the pyruvate does not go to Krebs cycle. Pyruvate becomes lactate, isn't it? So this is a marker of tissue perfusion, and the other way of expressing lactate is base deficit. Can I say higher the lactate or higher the base deficit, lower is the tissue perfusion. Best marker of systemic perfusion, if they ask you. So can I say one I can do is lactate, that tells me about tissue, and the second one is MVO2, mean venous oxygen. So together both of them tell us about systemic perfusion. Then let's have a look at this table. This is from Bailey and Love, where they've given what are the criteria for monitoring in shock patients. So we have minimum monitoring, additional monitoring. So minimum includes ECG, pulse ox, Non-invasive BP, urine output. So they can ask all are minimum except. Just note that base deficit is additional. CVP, invasive BP, cardiac output, all are additional. Even CVP is additional. That's the only one they can twist and ask. Then, response to any trauma or stressor like shock. We have two phases, okay? So we have ebb and flow. The very initial part, transient ebb phase happens. But after that, you go in a catabolic state. So this is what courses over two periods. One is acute, second is chronic, and this is where you have the basal metabolic rate increases and the body goes into catabolic pathway. So you can see how all of my catabolic hormones increase: cortisol, catecholamines, glucagon, growth hormone, ACTH. Everything very logical. All of our counter regulatory hormones. IL-1, 6, 8, out of which IL-6 is most important, are the inflammatory markers. Over a period of months, or days following the trauma, now our anabolic hormones start to decrease. So what are our anabolic hormones? Insulin. Even though IGF-1 mediates response via growth hormone, it's insulin-like. Testosterone, T3. So all of these three, four decrease. And this is the most important one. Thyroxine decreases. Do you remember this? So this is the one where we have done sick euthyroid syndrome. Do you remember this? So any patient who has a stressor, what happens? The T4, rather than getting converted to T3, gets converted to RT3, so that body's metabolic response, actually can decline. So this is a counter regulatory hormone where the body is actually trying to slow down any breakdown. So T3 is the only catabolic hormone we can say, or the hormone that reduces BMR decreasing. Every other anabolic one decreases. Okay, so you want to remember this. Not been asked so far, but I just feel that this is really important. So now we talk about trauma. This is something which is very, very scoring, and you can only get these questions correct if your concepts are clear. Okay, so this is where a lot more conceptual understanding than facts like we did so far in general surgery. So now let's start off with the triaging system. Now this is something which I've created using Bailey and Love. It at some points does not seem very, very correct, but because that's the reference textbook on the basis of which we get questions, we'll have to take this to the T and follow it. So this is the reference of this is Bailey and Love, right? So that's what I want to say at the outset. So this is how we triage. So red is immediate or immediately life-threatening injuries. First, I'll tell you what these colors are, okay? So you obviously know red, yellow, green and black, but you need to know these terms also. So red is what is immediate. In both of these words, you will see immediate, immediately life-threatening. So you want to treat these patients ASAP. Yeah. Yellow. So yellow is what has been actually called delayed, which is a little, contradictory in your mind. You may not be able to guess that this is delayed. You would think green must be delayed. So yellow is delayed or urgent, and the timeline they give is you should treat it at least within 6 hours. So urgent is good, but somehow they've also called it delayed. ठीक है? Then you have green, which is minimal or non-urgent. So now that makes sense, that minimal or non-urgent, and these are your walking wounded patients. So mainly fractures and trauma. And dead are unsalvageable. Very, very severe injury. No point of putting your time on these rather than red. So that is what are these dead or unsalvageable patients. So unsalvageable, what does it include? Severe brain damage, very extensive burns, major disruption of chest or abdominal wall structure. So these are what are unsalvageable. Red mein kya hai? Very severe facial trauma. So this only you may not be able to guess. Severe facial trauma. Tension pneumothorax you'll guess. Profuse external bleeding you'll guess. Hemothorax you'll guess. Flail chest, little important. Major bleed guess kar lenge. Extradural hematoma you may not be able to guess. So I'm just putting a tick where I want you to revise. Facial trauma, flail chest, EDH. Yellow triage. Compound fracture you will guess. Degloving injuries, alright. Ruptured viscus is a little, contradictory in practice also. If somebody has pneumoperitoneum, you would put them in red. But somehow Bailey Love has called it yellow, so we have to follow. So this is a major one. You'll have to, remember that this is yellow. Pelvic fractures, spinal injuries. Simple fracture, sprain, laceration is green, and that is easy to remember. Alright, so the only ones that have put a tick mark, you would want to revise it. Now let's talk about what we do with trauma patients. So the first thing is a primary survey. The aim of primary survey is to identify what is killing the patient. Okay, so that includes A, B, C, D, E. We do this in the order of A, B, C, D, and the order is decided by what kills a patient first. Meaning, if somebody has an airway injury, they're gonna die the earliest. Okay, so here I want to tell you two things. Overall, what is the most common cause of death in trauma patients? It's head injury. But what kills immediately is airway. That is why I first treat airway, breathing, circulation, disability, exposure. So that is why the sequence is ABCD, not CAB or DAB or anything like that. So that's the concept. So that's what I do in primary survey. I can use 3 adjuncts, radiological adjuncts. This is an AIMS PYQ, chest X-ray, pelvic X-ray, EFAST. Okay, so these are 3 radiological investigations which can come in primary survey, not CT scan. So that's the fourth option always. So CT, you will have to transfer the patient for a CT. So that's always a secondary survey where you want to identify other injuries. So chest X-ray, pelvic X-ray, EFAST. Resuscitation and primary survey go hand in hand. It's not like first you will do ABCD, then you will resuscitate. You find A is a problem, resuscitate. You find B is a problem, resuscitate. Yeah, so that's how it goes. In secondary survey, you also find out an ample questionnaire. That's an acronym. So what does that stand for? So what does this stand for? So A is any allergy that the patient has. M is any medications that the patient may be on. P is any past medical history, and it can also mean pregnancy, whether pregnancy is there or not. L is when the patient took the last meal, and that becomes relevant for risk of aspiration. And E is events leading up to trauma. So this is where we talk about what led to the trauma. So events leading to trauma. Okay, so that's ample. Let's revise: allergy, medications, past history or pregnancy, last meal, events. Okay. Then we have definitive care. So this is the order. They can ask you as match the following: primary survey, identify what's killing; resuscitation, treat that; secondary, what are other injuries; and then definitive plan. So now we talk about primary survey and resuscitation. So the first thing that you do, so it is ABCDE, but the first thing that you actually do is C-spine stabilization. So always remember, before airway, before you intubate or decide definitive treatment, first immobilize the spine. C-spine stabilization is the very first thing that you will do, followed by airway. Okay, so we'll talk about that. B is breathing with ventilation. This is where you find out anything that can lead to a defect in breathing, any chest trauma particularly. C is circulation, hypovolemic shock and its management. D is disability, where you deal with head injury. E is exposure. This is where you look out for any other injury in the body, but during this time you have to manage environmental control, right? Avoid hypothermia. If you're in a field setting, right, let's say one is a paramedic. Before they do ABCD, there we have C, ABCD, and C is not C-spine, that also you'll do, but here C is first control any exsanguinating bleed. Let's say there's a patient who is bleeding out, there's a spotter. If you've seen Friends, you can vividly recall what I'm saying. Have you seen the scene of Phoebe where she has an arterial spotter? So if you are a paramedic, first stop that, right? Compress. So control exsanguinating bleed, then look at ABCD. Yeah, but if somebody is just having a bruise, please don't start dressing that first. First ABCD. Okay, so this is in the field setting, right? So now let's talk about everything one after the other. The first thing is airway. Let's say you've stabilized the C-spine, you've put a Philadelphia hard collar. Now, who are the patients who are going to need airway support? Very, very important. So, what are the indications? So, any patient who is unable to speak, unable to talk is a sign that, his airway may be damaged, right? So, he is gasping for breath. There is subcutaneous emphysema because of a probable airway
injury, or very, very important, there are no signs of airway injury, but his GCS is less than equal to 8. Severe head injury, they will become unconscious and they lose control of their airway. So you first deal with airway, and this is what has been asked most times. Okay, so they give you a patient who's unresponsive, they'll use words like patient is unresponsive, patient has become obtunded. So in all of these cases, first I have to deal with airway, yeah, severe head injury. So this is where we deal with airway. Now, a basic airway method that is not a definitive airway but a first line thing that can be done are these two methods. So look at this, what are we doing here? So this is head tilt, chin lift. So this is where you're just clearing out the superficial airway. Head tilt, chin lift. And this is jaw thrust. Out of these two, can you tell me which is the one we can do for C-spine injury? So just try and do it yourself. Do head tilt, chin lift. The first thing that you did was you moved your C-spine. So this is what you can't do if there is a C-spine injury. Yeah, whereas jaw thrust is pulling the jaw. The spine stays still. You can do it. Yeah, so this can be done if there is a suspected C-spine injury. So that's one. Now, what we need to remember is what is my definitive airway of choice. So definitive airway of choice is always going to be intubation, right? So either you do orotracheal or nasotracheal, doesn't matter, but it's ET, endotracheal intubation is what is the airway of choice. All right. Where can I not do airway? Where there is a suspected maxillary injury. So where there is a suspected facial-maxillary injury, severe facial injury, how am I supposed to put an ET tube? Yeah, so in that cases, what do? I will have to do FONA. What is FONA? Front of neck access. Directly I'll have to take access through the neck. So that is where the first FONA that you can do immediately is a needle cricothyroidotomy. It takes 2 to 3 minutes to do this. So needle cricothyroidotomy, right? You pierce the cricothyroid membrane, and this is something which can sustain for around 30 to 60 minutes. This was asked in NEET 25 that it can last for 48 hours. No, it can support the patient for 30 to 60, but the definitive FONA has to be put in 30 to 60 minutes, and that is a tracheostomy. Yeah, so FONA, first is needle followed by tracheostomy. All right, so this is only something you will do if the patient has maxillofacial injury. Otherwise, you go ahead with intubation. All right, so this is all about airway. Now we talk about chest trauma. All right, so now we are going on to breathing. Airway is done, breathing. So here we have to consider various DDs of chest trauma, and then we manage it accordingly. So what are the things that can cause a disruption in breathing? This is where the patient will be dyspneic, the patient's saturation will not be maintained. So there we use various clinical findings to determine. It could either be pneumothorax, hemothorax, consolidation or contusion in the lung, or cardiac tamponade, and two other causes which we will get at. So let's compare these four first. Let's talk about pneumothorax. So you know pneumothorax is air in the pleural space. Yeah, tension pneumothorax is a pneumothorax which also has shock. So what is the kind of shock? We just saw it's an obstructive shock. The pneumothorax compresses the mediastinal vessels, does not allow the blood to come back to the heart. Obstructive shock, and that's why the JVP is raised. Anything in the pleura is going to shift the mediastinum to opposite side, contralateral shift. And the breath sounds and fremitus. This is a very helpful thing that both of them go together. So vocal fremitus, breath sounds decrease in pneumothorax. On percussion, we will feel a hyper resonant note because there's a lot of air which is accumulating here, right? What to do? So when a patient is in tension in pneumothorax, first thing you have to do is put in a needle. So we will put a needle thoracostomy followed by ICD because the patient is in tension pneumothorax. When I say tension pneumothorax, I say that the patient is in shock, patient is unstable. But if the patient is stable, I can directly put an ICD. Alright, so here the management of pneumothorax will be determined by the vitals of the patient. Which out of these four X-rays is pneumothorax? So pneumo means air, is black. So can you see how there is a hyperlucent lung field? contralateral mediastinal shift. So this is pneumothorax. I can't say tension pneumothorax on the X-ray, remember that. That's only a clinical diagnosis if the patient is unstable. What about massive hemothorax? Hemothorax is where the patient is bleeding out into the thorax, yeah? So this is where the shock is actually hypovolemic shock. Patient is bleeding into his thorax. JVP will be low because hypovolemia ho raha hai. Tracheal shift again contralateral. Breath sounds fremitus decrease because there's fluid in the pleura, and upon percussion we will feel a dull note because now it's fluid. So I can differentiate these by percussion as well. The management for hemothorax is only ICD, no role of needle. Imagine putting a needle, the blood is coming out. Tip, tip, tip. The patient will die because of this needle, right? So we want a fast release of blood, put an ICD. Very, very important. This is a question which has not been asked so far. Party question. What is the indication of a thoracotomy? So open thoracotomy would be indicated if you put an ICD and the blood is coming out at a very fast rate. What is that? Either you are having 1.5 liters in 1 hour or 200 cc per hour in 2 to 4 hours. 1.5 liter 1, 200 2. Yeah. So this is what is massive hemothorax. Which of these X-rays shows us hemothorax? Can you see this meniscus sign? So this is hemo. You may also see a white out lung. Complete lung may be white because fluid is white. Yeah. So this is hemothorax. Any pleural effusion in trauma is called hemothorax. All right. That's done. Then consolidation. We have done this in radiology. What is consolidation? This is where you are going to have fluid, right, in the alveoli. If I have blood in the alveoli, alveolar injury, I call it contusion. Yeah. So in contusion, the patient usually does not develop any shock. The JVP is completely normal. There is no midline shift. Breath sounds and fremitus are increased here. This is also important from medicine point of view. Fremitus is going to be increased in consolidation. Percussion, you may see, a dull note isolated towards that lobe. Management. Here, you don't have to put anything. You will just do conservative management and you will give ventilation or oxygen if needed, right? So by ventilation, I mean oxygen, either free flow or positive pressure if needed, if the saturation falls, and the hallmark is any PaO2 less than 60 mm is a sign of hypoxia where you should give positive pressure ventilation. Now, look at these X-rays again. So can you see how there is an opacity within the left lobe? So in the left lower zone, you can see left lower lobe contusion or consolidation, no mediastinal shift. Then cardiac tamponade. So this is where there is fluid around the heart, not allowing the heart to pump out the blood. So what kind of a shock is this? This is also obstructive shock. What have we learnt about obstructive shock? JVP is high. No tracheal shift here. Breath sounds fremitus completely normal. Percussion. Now percussion of the lungs will be normal, but can I get something called as Ewart sign? What is Ewart sign? So Ewart sign is a dull percussion area in the interscapular region which corresponds to the heart, right? So fluid around the heart. So that is Ewart sign. How do you manage? Now this is very important. According to Bailey Love, they say that there is no role of pericardiocentesis in traumatic tamponade. What you have to do is a surgical pericardiocentesis, which is essentially a thoracotomy. So what you have to do here is an immediate thoracotomy, which can either be from the subxiphoid window or an anterolateral approach, but you have to directly open up the patient. If there is a medicine patient with tamponade or effusion, you will do pericardiocentesis. I'll tell you a very easy way to remember. Why did a surgeon take up surgery? Because they wanted to open patients. Why did a medicine guy take up medicine? They didn't want to open patients. Yeah, so medicine में है pericardiocentesis, surgery का case है thoracotomy. Yeah, so there is no role of pericardiocentesis in cardiac tamponade because of trauma. Very, very important. Which X-ray? Can you see how there is fluid around the heart? So this is what we call as water bottle or leather bottle appearance. Okay, so this is all about the chest trauma and how we deal with it. Such an important table, right, which brings together a lot of stuff. Let's see two more x-rays. This I had shown you in radio as well, where there's an air fluid level of stomach which is in the thorax. So why stomach in the thorax? So this is where you suspect a diaphragm injury, which is more common on the left side. Yeah, so this is the stomach herniating into the thorax. Don't put ICD. It's stomach which has come. It's not hydropneumothorax. Okay, so ICD is not to be put, and that's a PYQ. And few more points about diaphragm injury. You can do a CECT to diagnose it, but overall the investigation of choice is going to be a diagnostic laparoscopy more than CECT. So depending on the options you can answer. CT can also sometimes miss these injuries, right, when they are not very obvious. So then you will choose accordingly. So radiological पूछ रहे हैं, CT overall पूछ रहे हैं, laparoscopy. There is also something called as a Bergquist triad, very like non-specific triad, where you have rib fracture, you have diaphragm injury, and you may have associated pelvic fracture or spine fracture. So they're just saying कि काफी severe polytrauma है. That's it. So this is diaphragm injury. Look at this X-ray. Can you see how there are multiple fracture fragments? In fact, look at this. This is where you can see two sets of fractures in two consecutive ribs. So when you have two or more ribs having two or more fractures each, this is flail chest. Why this is important is now this segment right here becomes a segment which moves paradoxically. During inspiration, if rest of the ribs are coming out, this will go in. So this is a PYQ. This is what leads to paradoxical respiration. All right. Now, what do you want to do for these? Again, the management of flail chest is going to be conservative. You just give the patient pain relief because this is very painful, analgesia. Only if, again, PaO2 is less than 60, we would want to give positive pressure ventilation, right? So this is what is important here for all the things chest trauma. Now, let's talk about where and how do we put the needle, the ICD and stuff around it. The needle thoracostomy that I was only doing for tension pneumothorax. So what is the needle? We use a wide bore needle that's 14 gauge. Don't mix this with cannula color, okay? This is needle. So it has a different color coding. 14 gauge pink needle is pretty wide. So that's the one that we use. And you put it at 5th intercostal space, mid-axillary line in an adult, 2nd intercostal space, mid-clavicular line in a child. This is the same position where we also put an ICD. Okay, so let's discuss ICD. 5th intercostal space, mid-axillary line, and the triangle is triangle of safety. What is the boundary? So you remember lady between two majors, how we used to say that. So behind I have latissimus dorsi, आगे I have P major, and below we have the 5th intercostal space. Now, when I talk about 5th intercostal space, yeah, let's say this is 5th intercostal space, ABC, where will we put it? So, for this, you will remember that my intercostal neurovascular bundle courses inferiorly through a rib. So, that is why we have to go along the superior aspect of the inferior rib always. So, don't memorize this, use a concept. Ki intercostal bundle niche, I don't want to injure that. So, I'll have to go along the border C. And that also explains why, you know, in coarctation of aorta, we have inferior rib notching because the intercostal arteries undergo hypertrophy. They are pulsating. So that is why this will be in the inferior ribs. So this is inferior rib notching, coarctation of aorta. Alright, so this is triangle of safety for ICD. Another question, what are the structures which are pierced during ICD? That can also be asked. So for this, you will remember first two are easy, skin and subcutaneous fat. Everybody will answer that. You can also remember the two layers of fascia. So superficial and deep fascia come in next. Then we have the muscles. So far we are all doing S's, right? So that's how you can remember. The next muscle or the first muscle is your serratus anterior. Then you have your intercostal muscles, 3 layers, right? So the 3 intercostal muscle layers that you will rupture or penetrate, and then you reach the endothoracic fascia, and then parietal pleura. and that's it. Don't pierce the visceral pleura, you'll enter the lungs. So we stay at the parietal pleura. So skin, subcutaneous, fascia, वो हो गया, serratus, फिर intercostal, फिर endothoracic fascia or parietal pleura. So that is what are the structures pierced. Okay, one more thing that I can show you here. What if there is an open pneumothorax? So open pneumothorax means there is a big wound which is communicating with the outside, communicating with the pleura. This is where you use this three-sided taping method. Okay, so what you do is you use an occlusion device, but you tape it only on three sides and keep one side open. What that does is during inspiration, so this is during inspiration, you are not allowing the air to enter, it goes back. But during expiration, now this air can exit from this one side which is open. Yeah, so this is to enable that from happening, that the pneumothorax air can leave itself. So this is what is, a probable question that may be asked. So this is all about, our chest trauma. Let's try and do this question. Apply your concepts. Male stabbed in the chest, BP is low, pulse is high, respiration 30. So patient is in dyspnea and shock. Severe distress. Breath sounds only on left, absent on right. So that tells me it's a breathing issue, not an airway issue. Heart sounds normal, neck veins distended. So that tells me, okay, it must be tension pneumothorax. So a lot of you would be excited, mark needle and come back. But what do they say? Patient becomes obtunded during examination. Obtunded. Ma'am had warned this. Obtunded, non-responsive. पहले क्या secure करना है? First, I have to secure his airway before I go to breathing, even though the diagnosis is tension pneumothorax. So how do I secure his airway? I have two options, intubation or cricothyroid. Clearly, I don't have to resuscitate. So do I do a cricothyroidotomy? Is the patient having any maxillofacial injury? Why are you doing a FONA? Do the definitive airway. Endotracheal intubation. So this is how you have to approach these questions. You can't memorize stuff. You will have to apply, and every line can change your answer here, right? So that's something which is very, very important. So now we talk about hypovolemic shock. So this is what is the classification. This is an ATLS classification for dividing the types of hypovolemic shock. So now, unless mentioned otherwise, the shock in trauma because of bleeding is hypovolemia, right? So what are the common sites that you have to rule out when you have a lot of hypovolemia? So there's a common saying called one on the floor and four more. So one on the floor means that there's external bleeding from the visible wounds outside, right? So that's something which is external bleeding. Then you have four more. So what are four sites of internal bleeding, which we suspect when you have hypovolemia? So one is going to be bleeding into the thorax like hemothorax. One is bleeding into the abdomen, which is hemoperitoneum. Always rule out a pelvic fracture and long bones like femur. So these are the four sites where bleeding can result in hypovolemia. Now have a look at this staging. So this is determined on the degree of blood loss. So class 1 is less than 15%, and that translates to absolute volume of less than 750 ml. This is 15 to 30, so that becomes 750 to 1500 ml blood loss. 31 to 40% is 1500 to 2000 ml of blood loss, and more than 40% is more than 2000 ml of blood loss, right? Class 1 is just equivalent to donating a unit of blood. Have you ever seen somebody donate a unit of blood and go into shock? Then they should not have donated, right? So everything should remain normal, and there's no need to give any IV fluids after donating blood, obviously. So this is class 1, managed conservatively. Class 2 is where the heart rate increases, pulse pressure decreases. All right, so you know what is pulse pressure? You know, right? Systolic minus diastolic. So this is the one that decreases and heart rate increases while BP remains constant. So this is where you may need to give IV fluids and or blood products. Then you have BP going down. Everything in fact now starts to go down in class 3. Class 4 also everything starts to go down. So it's difficult to distinguish 3 and 4. So basically the only question that can come from here is identifying class 2, where they give you that heart rate is increased but BP is normal. Yeah, so this is where in 3 and 4 we may need to give blood transfusion, and we can differentiate them on the basis of base deficit. Remember, this is a marker of tissue perfusion. So you can see how directly it correlates with the degree of blood loss. Yeah, so that's what we need to remember here. How do we manage these patients? So the minimum cannula in every patient who has a hypovolemic shock is an 18 gauge cannula. Remember, 18 is green signal, so green cannula. Every patient will get 1 liter fluid bolus of any isotonic crystalloids. So this is something which is very, very important. Isotonic crystalloids, you can give NS or RL, either one, 1 liter fluid bolus, and yeah, so 1 liter. Once you have done this, after this you don't give more fluid. After this, what you give is blood transfusion. So that is called as damage control resuscitation, where after giving 1 liter of fluid bolus, if one does not respond, now you start blood transfusion. You give 1:1:1 ratio of packed RBC, FFP, and platelet. All products you give, you monitor their TEG or ROTEM. Remember this? TEG is thromboelastography and ROTEM is rotational thromboelastometry, and these tell you about the parameters, the coagulation parameters, and depending on that you can correct the FFP and platelet along with blood transfusion. Yeah, because if you remember, the most common cause of death in massive transfusion is dilutional coagulopathy. So you prevent that if you're giving massive transfusion, and you keep monitoring and give FFP and platelet whenever needed. So that's damage control resuscitation. Don't mix it with damage control surgery. We will come to it. Before that, CRASH 2 trial was done, which showed a role of tranexamic acid. What does tranexamic acid do? If you remember, TPA, yeah, tissue plasminogen activator, it inhibits this. So that is how it causes thrombosis. It prevents the clot from breaking down, right? So it increases thrombosis, or we can say it decreases bleeding. We also give this in menorrhagia, so same context, yeah. So we give 1 gram tranexamic acid over 10 minutes, and this is given within the first 3 hours of trauma. So 1 gram over 10 minutes within the first 3 hours of trauma. This is given in any patient who's in shock. So the criteria is any patient whose systolic BP is less than 90 or whose heart rate is more than or equal to 110. So you can remember a mean number 100. So less than 90, more than 110. So this is about tranexamic acid. Now we talk about what is damage control surgery. Now this is given to patients, or this is done in patients who are stuck in this trauma triad of death. What is trauma triad of death? You can remember MCH. Now there's an MCH course in trauma. So MCH, metabolic acidosis. What is defined as metabolic acidosis? Any pH less than equal to 7.2. Hypothermia. What is the criteria for hypothermia? Less than 35 degrees Celsius, and coagulopathy. So this is trauma triad of death. The numbers are important to be remembered. You can remember them as 2 plus 3 equals 5, 5 plus 2 equals 7. Yeah, so even if you forget, you look at options, you'll remember. Okay, so this is the first thing, you select these patients. So some people also write these as 5 stages, where stage 1 is patient selection. All right, now what do you do with these patients? So now here, the trauma is going to kill them lesser than their crisis here. So they need correction of the trauma triad more than they need, correction of the injury per se. So that is why the first thing we do is just do a primary surgery, where you can just, do hemostasis, drain if there is any contamination, put a temporary closure and come back out. So here you are just doing primary hemostasis and contamination control, any debridement or gross bleeding control which needs to be done. Here I want to tell you 4 P's which are done for liver surgery. Okay, one I'm sure you remember is the Pringle's maneuver. We have learned this in ANAT, right, where we go to the foramen of Winslow and we block the hepatoduodenal ligament which contains the portal triad. So we can do Pringle maneuver. You can do push. Push means compression, right? Compression of the site where you have bleeding. You can do plugging, that is using SB tube. Remember in varices, I think I'll teach you now. In surgery in varices, Seng's taken Blakemore tube. So you can plug the vessels and you can pack with gauze pieces. So theoretical question, 4 P's include all except kind of a question can come from here. Okay, so we've done that. Now you will go for resuscitation and ICU care. So this is where we take out the patient from the trauma triad of death. Once the patient is out for 24 to 48 hours, now you can do the definitive surgery, whatever repair, resection, anastomosis needs to be done, and you put a definitive abdominal closure. So they can ask you sequential arrangement, they can ask you trauma triad of death. Now we look at organ-wise trauma, abdominal trauma, then we'll look at bladder and GU trauma, head trauma, neck trauma, everything organ-wise. So in abdominal trauma, what we have to first do are these one-liners. So what is the most common organ injured in blunt trauma abdomen? Spleen, both in children and adults. In penetrating, it's liver more than stomach. In gunshot, it is actually the small intestine. So that is why in gunshot injury, there is higher risk of bowel injury. These two signs very, very important. Let's say there is a perisplenic hematoma. Okay. So let's say there is diaphragm irritation on the left side because of that. Because the diaphragm is actually supplied by C3, C4, C5, the referred pain comes to the shoulder. So this is where a perisplenic hematoma gets referred to the left shoulder and the patient complains of left shoulder pain. So this is where you need to remember that if there's abdominal trauma and there's shoulder pain, please don't do an X-ray of the shoulder. Evaluate perisplenic region using EFAST, right? So that's a clinically important sign. Do not look for shoulder injury there. It's a referred pain. So that's one. Balance sign is you will see an area of dullness on percussion. If you percuss in the left upper quadrant, you will feel an area of dullness, and that is what is the balance sign. Okay, so you feel dullness on percussion, and that indicates that the clot there is getting thrombosed. Okay, so that's the site of bleeding which has been going on for a while. So balance sign, curse sign. Now we talk about EFAST. EFAST is the investigation that we do for looking at bleeding into the abdomen and thorax. Okay, so E for extended, not extra. F is focused or fast. It is focused. A is assessment or abdomen. It's assessment. S is sonography in trauma. Not much to play around there. So extended focused assessment using sonography in trauma. So we are saying I'm going to use focused points, right? So what are the points we focus on? So the first one that we do is subxiphoid. So this is where we look around the heart for pericardial effusion. Yeah. So this is what we had seen as a GIF in radio. Remember echo video where you'll see blood around the heart, anechoic fluid around the heart. Do you remember how fluid appears? Kala pani. Fluid appears black on ultrasound. So everywhere I am trying to look for black fluid. After this, I look at the abdomen for hemoperitoneum. First is between liver and kidney. That's hepatorenal or Morrison's pouch. Then I try to look between spleen and kidney, splenorenal pouch, and then we look in the pelvis just behind the bladder. So these are the 4 sites for hemoperitoneum. This was fast. When I said extended fast, this was an old AIMS question that when you say extended EFAST, what do you mean? I mean thorax. Now I evaluate thorax as well in EFAST. So I check for pneumothorax. If you remember, we had done this. You check for sliding motion. You check whether there is seashore sign, barcode sign. So do you remember Goa kab jayenge? Normal time. So seashore is normal. Sliding is normal. Alright. So I check for pneumothorax. Hemothorax, plural space mein anechoic fluid. So see this. If I tell you I'm looking at the hepatorenal pouch. So this is liver kidney. But I don't care for that. This is what you have to see. Whenever you see there is kala pani, black fluid in between, this is what is hemoperitoneum. And what do I classify this as? I'm going to say this as EFAST positive. Yeah, so that is what we do, and EFAST is not something that only radiologists can do. Any trauma personnel can do EFAST. Now, because I am looking at specific points only, the sensitivity is much lower than a routine ultrasound. Okay, so that is why you can detect any fluid more than 100 ml. So any sensitivity more than 100 ml hemoperitoneum, which is clinically significant, can be detected. What are the limitations? Do you remember something that air is the enemy of ultrasound? So that is why pneumoperitoneum can be missed, and that is very important because bowel injury or mesenteric injury, both of them are going to lead to pneumoperitoneum, and that is something that can be missed on EFAST. Okay, so this is something where we do not see bowel injury or pneumo. We can also miss RP hematoma, that's a PYQ. So retroperitoneum cannot be visualized on EFAST. And very important, you may also miss injuries if the patient has subcutaneous emphysema. So, agar air subcutaneous fat mein hai, it will not allow the sound waves to go through and you will not see anything in the abdomen. Yeah, so these are a few limitations of EFAST. Now, if you are in a remote setting where EFAST is not available, then comes the role of DPL, diagnostic peritoneal lavage. Remember, this is not at all relevant in today's time and age. We are just studying this for the sake of coverage, that let's say anything that can be asked, we should know. So, diagnostic peritoneal lavage is only done if EFAST is not available. Here what you are doing is you are putting a needle into the abdomen and you are taking an aspirate. If you can aspirate frank blood, that's proof that there's hemoperitoneum. If not, you put 1 liter of saline in the abdomen and aspirate and run through various tests. If these are there, it means that the patient is likely having hemoperitoneum. So positive DPL is the invasive counterpart of positive EFAST. Yeah. So what are these? We check for RBCs 10 raised to 5, 5 से ही 500 WBCs, amylase, bacteria because bowel perf बोल सकते हो, bile again you can say bowel perf, or food particles bowel perf. So you can actually detect perforation or hemoperitoneum using diagnostic peritoneal lavage. Not done anymore. Please don't mark it unless they say ultrasound not available, very remote setting, right? Only then you will mark it. Now look at this. What can you see here? There is a marking of seat belt. Yeah. So what are the injury spectrums associated with seat belt injury? Imagine one is wearing a seat belt and there is impact. What happens? So first of all, can I say that the abdomen is very tightly bound? Yeah. So what we can see here is, imagine this is the seat belt and this is the belt. Yeah. So one is very tightly bound. Because of that, now there is this impact. I fall forward, I fall backward. So my thoracolumbar spine somehow undergoes a lot of movement, and that results in opening up of the vertebrae. That results in shearing of the mesentery. So two very typical injuries that happen with seat belt. One is mesenteric injuries can happen. Yeah, mesenteric tears or shearing can happen. Second, chance fractures. In ortho, we have discussed this. Complete opening up of the vertebra. 3-column fracture can happen. And if they ask you one more, pancreatic injuries may also happen. Yeah, but these two are the typical injuries with seat belt association. Let's do the protocol. So blunt trauma abdomen, we first look at the vitals of the patient. Doesn't matter. Whatever be the vitals, any patient with blunt trauma, for example, road traffic accident, I am going to do EFAST. So my first investigation for any patient, whether stable or unstable, is EFAST. What am I trying to see with EFAST? Whether the patient is bleeding into the abdomen or not. Yeah. So let's say the patient is stable. I did the EFAST and EFAST was negative. No bleeding. Patient be stable hai. What do you want to do? Just observe the patient. But if the patient is stable and EFAST is positive, yeah, means patient is doing well, but he is bleeding into his abdomen. What do you want to do? I want to see where is the injury. So that is where now I do a CECT. So CECT of the abdomen is performed to see where the patient is bleeding. Alright, so can I say CECT is the investigation of choice to localize any injury? Yeah, we localize and we grade injuries in the abdomen. What is the grade of injury? Where is the injury? So, EFAST positive, I do a CECT. Alright, so this is what is important. Initial EFAST, best CECT. Now let's go to our sick patients, unstable. I've tried everything. I've given IV fluids, I've given patients blood transfusion, but the patient is a non-responder, not responding. What do? We don't have a choice. You will have to explore. Patient is bleeding quite severely. So you would be like, ma'am, then why did you even do the EFAST? So I did the EFAST because if it was positive, I get an insight that alright, that must be a severe injury of some solid organ. But if EFAST is negative, yet he is unstable, means where should the injury be? Could be retroperitoneum. Yeah, so that gives us an insight as well that okay, it must not be in his peritoneum. So here even a negative EFAST is helping us. Yeah, so that's what is important, that EFAST I will do in every patient who has blunt trauma abdomen, whether stable or unstable. Is this clear? Now I look at penetrating trauma. Here things are different because here the chances of bowel injury are more. Bowel injury matlab the reliance on EFAST now decreases because EFAST is going to miss bowel injury. So that is why here my approach is slightly different. I have made out certain criterias. If any of this is positive, all I have to directly do is take the patient to OT. Bowel injury is very likely. Don't waste your time doing EFAST. Yeah. So this is where I don't do EFAST in every patient. Stable patients, you can do EFAST. You can follow any protocol you want. But here I will take straight to OT. So what are these patient groups? Any unstable patient, any patient with gunshot, because we saw gunshot, my most common was bowel injury. Peritoneal breach. Now, this is where you had a question similar to this. They showed a stab wound in a patient and they said, what will you do next? OT, CCT, EFAST, further exploration. The answer is further exploration. Why? Because when there is a stab wound, I am actually trying to look whether peritoneal breach has happened. If there is peritoneal breach, that would suggest that underlying bowel has been injured. But if there's no peritoneal breach only in this stab wound, if I can see through, digital exploration that yahan pe to peritoneum intact hai, bowel injury is unlikely. So that is why my next step is digital exploration, and I dissect across the planes to see whether the peritoneum is breached or not. Agar breach hai, if there is a breach, I take to OT. If not, I manage as stable patient. Understood? So my next step is further exploration. But if they give you an image like this, there's a knife which is already inside. Do you take out the knife and then explore? No, because there is a tamponade defect which has been created by the knife which is inside. Don't remove it right now. Remove it in the OT. So this patient directly goes to OT. Please don't do digital exploration here. Bleeding via orifice is again an obvious sign that bowel injury is there. And lastly, if I give you an image like this, are you going to answer further exploration here? No, you can already see the bowel coming out. Yeah, so why do you want to now explore? You can already see bowel outside. So if you have obvious evisceration or impaled object, directly OT. Yeah, so this is something about penetrating trauma that we need to remember. All right. So now we talk about the retroperitoneal zone. So there are 4 zones in the RP. The first one is the central vascular structure where you have aorta, IVC. Any injury in the zone 1 we always explore. So the rule here is exploration. This is a PYQ as well, right? So you always explore because major vessels are likely to be injured here. If you want to see on the left side, that is if you want to see the aorta, you do the left medial visceral rotation. Matlab, whatever organs are there on the left side, aorta is on the left side, pehle unko we will move them aside. So I will move the left sided structures sideways. Okay, so L and M go together. So that is called as Mattox maneuver. whereas on the right side is Cocker's and Cattle-Brash maneuver for right medial visceral rotation. Zone 2 are the two lateral zones. So this is where we will always observe unless there is an expanding hematoma. Only when there is an expanding hematoma in the kidney, then we will have to explore. Otherwise, observation is the rule. Zone 3 is this near the pelvis. Again, you observe and you do fixation and pelvic compression. Sometimes a bed sheet can also be used as a binder if you don't have a specific binder. And zone 4 is the hidden zone behind the liver, retrohepatic zone. So there also the rule is observation. So only zone 1 the rule is exploration. Alright, so these are the 4 zones. On similar lines, I want to talk about abdominal compartment syndrome. Abdominal compartment syndrome is defined as intra-abdominal pressure more than 20 mm Hg plus organ dysfunction. The organ dysfunction that happens, so basically imagine there's too much blood in the abdomen. It's a closed cavity, so it again acts like a compartment syndrome. So that may result in the kidneys receiving less blood, so the GFR decreases, hence the urine output decreases. It can also decrease the cardiac output. Why? Because the preload is getting decreased. Essentially, the IVC gets compressed, and because the cardiac output goes down, every organ suffers, right? So that is why what we use to measure or to diagnose it is the intravesicular pressure. We measure the bladder pressure. If the bladder pressure is high, so this is where when I say this pressure, it's the intra-bladder pressure which increases. So that is what we measure. And anuria is a specific sign, zero urine output, that is one of the signs which is an obvious indication of decompression. Right? So this is about abdominal compartment syndrome. It's never been asked so far. So just know these 2-3 points. Now we talk about something that is tricky for a lot of students, that is genitourinary trauma. So this is where we talk about kidney, bladder and urethral trauma. So when we talk about renal trauma, I have to see patient who is stable or unstable. If the patient is stable, I am going to do CT urography, or you can also write it as a CECT. See, what is CT urography? I am doing a simple contrast enhanced CT where I inject contrast into the blood vessels, IV contrast. Now if I wait for around 15 minutes, just like IVP, I injected contrast, waited for 15 minutes, the collecting system starts to have contrast. So this is what is a delayed phase. I wait for around 15 minutes and take a CT, and that will opacify the pelvis, the ureter and the bladder. So this is what helps me know ureteric leakage. Alright, so this is the investigation of choice because I also want to diagnose ureteric injuries. Okay. But if the patient is unstable, I don't have time to do CT scan, So how can I check if there is renal injury or ureteric injury intraoperatively? I can do something that is called as single shot IVU. Same thing, I inject contrast, I wait for 15 minutes. Instead of taking a CT, I take an X-ray. So I take an X-ray after 15 minutes, and if the contrast is leaking out on the X-ray, means there is a ureteric injury. So that's what I am doing here. Bladder injury. Bladder injury, I do a CT cystography. As the name suggests, what is CT cystography? So this is where I take a Foley's catheter, okay, and I put around 300 ml of contrast. Just how we were doing MCU, if you remember. But I don't ask patient to micturate here. Here I just put contrast in the bladder and then do a CT scan. So what will I see? Look at this image. If the patient is normal, the white contrast will stay inside the bladder. But if it leaks outside, I know there is bladder injury. So that is what I am doing in CT cystography. I am just putting some contrast into the bladder. So we'll come to it. Investigation of choice for urethral injury, RGU, retrograde urethrophy. I can't put a Foley's here. So all I do is I put contrast into the urethra directly and see if it leaks. Alright, so the first step is to know these investigations. CT urography, single shot IVU, CT cystography, RGU. Clear? Now we talk about bladder trauma first. So look at these two patterns of leakages and tell me what is looking like extraperitoneal rupture. So look at this. This is where the contrast is leaking out in front of the bladder. इसको बोलते हैं pre-vesicular space of Retzius. In this also you can see how it is just around the bladder. So whenever the contrast stays around the bladder, this is called as EPBR, which is extraperitoneal bladder rupture. The contrast has not entered the peritoneum. But when I see something like this, remember contrast idhar udhar ja raha hai. Idhar udhar means here and there. So this is where the contrast is going throughout the bowel, interbowel space. Here also you can see how contrast is going adjacent to the bowel. So this is where now the bladder rupture has happened intraperitoneally. So this is intraperitoneal bladder rupture. Obviously what seems more severe, intra, right? Because this is what is going to cause peritonitis. So this is more severe, and that is why the management of this is immediate surgery to correct it. But EPBR is more common. You know how less severe things are more common? Same here. So more common hai, and the management here is you just wait and watch. So conservative management, the leak will heal on its own. Just keep draining it through a Foley's, keep that Foley's in situ, the leak will seal itself, right? So this is about bladder rupture. You get these images. Now let's talk about kidney trauma. So kidney is the only AST grading that I want you to remember. There is a separate AST, American Association of Surgeons in Trauma grading for every organ, liver, spleen, pancreas, kidney. Even if you do, you're going to forget, right? So you may want to see that. I'll put a question on that. But at least kidney I want you to remember. So grade 1, subcapsular hematoma. Grade 2, less than 1 laceration or a perirenal hematoma. Grade 3, more than 1 centimeter laceration but not involving collecting system, or any bleeding, but the bleeding is within the perirenal fascia. What all happened? Subcapsular hematoma, less than 1 laceration and perirenal. More than 1 and perirenal with active vascular injury. Now we talk about grade 4. So grade 4 laceration is the one that involves collecting system. So this is why we were doing a delayed CT urography. Can you see this white contrast? So that is leaking out. So this is what is going to form a urinoma. So this is where the urine will collect and form a collection because it's leaking. The management of urinoma is conservative. Okay, so only when on conservative management we see that it is not resolving, it's persistent. Yeah, so that is where now you will have to do a stenting. You will put a DJ stent. Okay, so the management of urinoma is conservative, but if it doesn't decrease in size or it's increasing, I will have to put a DJ stent. If this becomes infected, all right, there is signs of infection, patient is going into sepsis, then I will have to drain it, because at this point it's become like an abscess. Yeah, so this is where you will put a pigtail drainage. Okay, so this is about a urinoma. Now let's talk about other grade 4. So there is vascular injury, segmental infarct, bleeding beyond perirenal fascia. Grade 5, shattered kidney or complete devascularization, infarct, right? So shattered or infarct, 5. So even if you don't remember everything, just 1 point. Collecting system injury is grade 4 injury. So that's what we have to remember here. Just as a general outline of how we manage, solid organ injury is very similar. Anytime I have any vascular injury. So for any vascular injury, what they will write in, the description is the patient either has an aneurysm. Now that's not a true aneurysm. This is what we call a pseudo aneurysm when it happens because of trauma. So when I say there is a pseudo aneurysm, or they may write active extravasation of contrast, the blood is leaking out. This is where the treatment of choice is not surgery, it is DSA. We are going to do angioembolization. We go in through the femoral artery into the artery that's bleeding and we put coils around it. So that is what we do. Unless there is grade 4 or 5 injury, I will not operate. So this is where the surgeon will operate. Any grade 1 to 3 injury, it is just conservative. So you just have to decide whether you are going to operate or you're going to do angioembolization, and the only indication of this is any vascular injury, right? So this is at a broad level how you manage, liver, spleen, kidney, any injury like that. Now we talk about urethral trauma. So when we are talking about urethral trauma, first of all, how the patient is going to present. The patient will come to you with blood at meatus, external urethral meatus, and the patient will say, doctor, I cannot pass urine, inability to void. Whereas in renal and bladder trauma, there will be no blood at meatus. So this is the hallmark. So in bladder injury, the patient may say, I can't void, or they may be hematuria, but blood at meatus seals the deal. Uska matlab hai urethral injury. Yeah. So in bladder trauma, you may see pelvic fractures, pelvic tenderness, hematuria, inability to void. No blood at meatus. In renal trauma, all you will see is hematuria, right? So this is how clinically you get a suspicion of what's going on. All right. Now we have anterior urethra, we have posterior urethra. The risk factors for anterior urethral rupture is going to be what we call as straddle injury. Straddle injury means you were walking and you suddenly fell into a manhole, perineum first. तो उसको बोलते हैं straddle injury. Posterior urethra associated with pelvic fractures, P for P. So this is pelvic fracture. The most common site of urethral injury is the bulbomembranous junction. If they ask you to choose one, bulbar urethra. So bulbomembranous junction. So you can also see the history. Agar likha hai straddle, go for bulbar. Agar likha hai pelvic, go for membranous. Yeah. So if it is right at the junction, you can look at the risk factor and decide. Okay. Now, this is the history. Blood at meatus, there is no ability to void urine, and they ask you, what are you gonna do next? So the next step is RGU. We do a retrograde urethrophy. So what do you do in that? This is what is a normal RGU. I put contrast directly into the external urethral meatus, and if it can go into the bladder means the urethra is completely normal. Let's look at the different parts of the urethra here. So this is the penile urethra, the straight part going through the penile shaft. The moment you see it's taking a turn, yeah, you have to follow it right from the turn till it tapers. This is what is bulbar urethra. So bulbar urethra till it tapers, and this is the junction that I am talking about where the injury happens. BM junction, bulbomembranous junction, because this entire thing is the posterior urethra. You can't really distinguish into membranous prostatic. So this entire thing is posterior urethra, and this is the urinary bladder. So if it goes inside, it is normal. Now look at this patient. So this is the patient, let's say Ramesh, who has fallen down straddle injury. Ramesh cannot void urine and he has blood at meatus. We did his RGU. Is Ramesh normal? Let me rephrase. Is Ramesh's urethra normal? We don't know about Ramesh, right? So this is where you can see this is penile. Penile part is normal. Where I see that the bulb was supposed to take a bend, what can you see? You can see extravasation, isn't it? So can I say that Ramesh has bulbar urethral injury? Yes, indeed. So this is bulbar urethral rupture. Alright, so now Ramesh is asking, doctor, I don't care about the urethral rupture. I have one problem. I have a lot of urinary pressure. Please do something. So what do? You have to find one alternate pathway for Ramesh to pass urine. What is the next step? We do a suprapubic cystostomy. So once our RGU shows us an injury, I have to find a pathway. I directly puncture the bladder, put a Malakot's catheter that can drain out the urine. Suprapubic cystostomy. But let's say Ramesh says, doctor, I don't have any pressure. I palpate, but I cannot. So urinary bladder not even palpable. Can I directly do an SPC? Not really. What will you have to do? You will have to wait for some time for the bladder to distend. Ask him to drink some water. Wait. When the bladder is palpable, do SPC. Yeah, so this is one repeat question. So if the bladder is not palpable, you wait and watch and then you do SPC. So the patient will be discharged on SPC and we will call him eventually after 4 to 6 weeks. Repeat his RGU and it will look something like this. What has happened to the rupture? You can see how penile urethra theek hai. Bulbar, look at the bulbar tapering. Where the tapering is before that, can you see the narrowing? So now this has that leakage. फिर से बोल रही हूँ, that leakage has now converted into a stricture. So this is where now what can we do? We can resect this part out and do a urethroplasty. So that is why we waited for a few weeks until that extravasation can now become a narrow site of stricture, and then we can do a delayed urethroplasty. Okay, so this delayed urethroplasty is what can be done using a buccal mucosa graft, that is also a PYQ. So buccal mucosa graft. Are you understanding how to approach the site of stricture? So always look out for this tapering. Yeah, agar ye bird beak tapering nahi dikh raha, it is bulbar stricture. Alright, so that is about the approach to urethral trauma. Let's just integrate some amount of anatomy to this. Now, bulbar and penile urethra, which is anterior urethra, is in the superficial perineal pouch. Okay, so whenever there is a rupture in any of the superficial perineal pouch, it can communicate with the rest of the pouch. Yeah, so look at this. So this is where the superficial perineal pouch communicates. It communicates with the scrotum, the dartos fascia, communicates around the penile shaft, that's the bucks fascia, and communicates with the anterior abdominal fascia, that is Karpa's fascia. So all of these fascia actually communicate with one another. So the urine can actually extravasate anywhere. So this is such a nice image where you can see wherever the yellow color is going, that's the route it can go. But if there was a membranous urethral rupture, it will only remain in deep perineal pouch. It has no real communication. So membranous urethral rupture remains in the deep perineal pouch. Look at this. 14-year-old boy comes to the ED after a straddle injury, bulbar urethral rupture. Where will the urine go? So as we discussed, it will go into the scrotum. Yeah, not go to thigh, not ischiorectal, not deep perineal. Who will go to deep perineal and then stay there? Membranous urethral rupture. Yeah, so this is what is about urethral trauma. So now let's talk about head trauma. Super important, like one question 100% every exam. Alright, so what we have done in radiology is whenever there is an acute hematoma, it's going to be white, hyperdense on a CT. So that is why, because it is white, I'm just going to do a non-contrast CT scan. So look at these images. Two things I have to compare here, EDH and SDH. First of all, whenever you have a history of a trivial trauma like an alcoholic falling, granny slipping, yeah, so trivial trauma, boxers, what can happen? Look at this hematoma. Can you see how it looks like a crescent? Yeah, so this is what is a moon or a crescent. This is a subdural hematoma. Can you see it is hyperdense? So this is acute SDH, hyperdense. This is trivial trauma. So it happens because of venous injury. Trivial trauma milega. And why is it crescent? So this is the approximate locations of where the sutures run on a cross section. So now can you see how it's crossing the sutures? But it will stop at the midline. It cannot go beyond the midline. Okay, so everything can only cross one thing. Now contrast this with this hematoma right here. Looks like a idli. So, and it's hyperdense. So, this is what is an acute extradural hematoma. This is where we will have a severe road traffic accident. This is an arterial bleed. This was venous injury. This is artery. And which artery is most common? Yeah, it is middle meningeal artery, anterior division. And where does this run? It runs below the pterion. So, if there is a pterional impact, there's going to be EDH because of middle meningeal artery injury. This is what is limited by the sutures. The reason is the dura is attached to the sutures. So, uske bahar ka bleeding, the bleeding outside it is going to be limited. Yeah. So, this is what is going to not be able to cross the sutures, but it can cross the midline. Means I can have an EDH that looks like this. Alright. So, this is about EDH versus SDH. Now, before I go on to other images, look at this CT itself. What is this white thing? So this is what is a bleed within the brain parenchyma, and this is what is called as contusion. Hemorrhagic contusion. Just how we saw pulmonary contusion, this is a brain contusion. And can you see how the locations are? They are diagonally opposite to one another, and that is because of counter coup mechanism. So whenever I have impact on one side, it is going to cross over to the other side. Counter coup mechanism. Alright, so this is about EDH versus SDH at a macro level. And one more point, whenever I say contusion, that's bleeding. Do not mix it with another term, that is concussion. What is concussion? Concussion is where NCCT is going to be normal. There is a minor neurological deficit, but the NCCT is normal, means it's a very mild brain injury which has happened. The patient may complain of some headache, but the CT is completely normal. So it's a very mild brain injury. So don't mix the two. So just remember, contusion correlated with lung and head. So you don't mix the two. Okay. Now look at this image. Can you see how there is a hematoma, but now it's not white? So how do I diagnose this? First of all, right versus left. You all know this is left side. So I can say that this is left chronic SDH. Perfect. Look at this image now. Again, it is limited by the sutures. So can I say this is EDH? But now what are you seeing? You can see there are some areas which are white and some areas which are dark. Means acute bhi hai and chronic bhi hai. Means it's been going on for a while, and this is a sign which is called as swirl sign, and this is a poor prognosis because that tells us that the bleeding has been going on for a while. Yeah, so this is what we call as the swirl sign, and this is what is an indication of decompression. Now what you first of all need to remember, and this was asked in November INI, is the surgery that we do now, whenever there is a mass effect, is going to be a decompressive craniectomy. Okay, this is what is followed nowadays. Nobody does a borehole anymore. So unless they write that, the patient is in a very remote setting, there is no neurosurgical setup, you can do a borehole, but a neurosurgeon will not do a borehole. If he has an OT to himself, he's going to do a decompressive craniectomy. Yeah, so that is something which is very, very important. Do not give mannitol. Okay, so no role of mannitol in hemorrhage because it decreases the intracranial pressure for sure, but that's for cerebral edema. When you have a hematoma and you decrease the brain volume, that only gives more space for the hematoma to expand. So that is why do not give mannitol. Right. So now what are the indications of decompression? One is swirl sign. Second, you are having a midline shift more than 5 mm. What do I mean by that? So look at this. Look at this CT. Can you see this is the midline, this is the fox cerebri, and look at how this septum pellucidum has shifted. It should be at the midline, but it's shifted. So if this distance is more than 5 mm, that's an indication of decompression of this hematoma. Yeah. Apart from that, any EDH whose diameter is more than 1.5 centimeter or volume more than 30 cc. So 1.5 and 3, you can remember, or there is herniation. Okay, so what are the different kinds of brain herniation is what we learn next. So look at this. This is what is the first herniation, that is subfalcine herniation, which was nothing but the midline shift. The brain shifts below the fox cerebri. Alright, so that is the type 1, that is subfalcine herniation. Then, so that is the most common herniation. The most severe one is what I am about to teach you now, which is transtentorial herniation. So let's say there is this mass, the tentorium cerebelli, which is this fold, right? That is where now my brain is herniating down. So this is descending transtentorial herniation. The brain is going down. What happens now is, imagine this is the transtentorium, in middle is the midbrain. Yeah, so this is the midbrain part. What happens is now the brain is coming and compressing on the midbrain. Let's see this. So let's say this is the midbrain. Normally I had the tentorium till here, but somehow now the brain has herniated on this side. So that's further pushing on this brain. The nerve that gets compressed is the third cranial nerve because it's coming out from here. So can I say that ipsilateral third cranial nerve is going to get compressed? This is the third cranial nerve. So the first thing that gets compressed is ipsilateral third cranial nerve, and that is what is called as Hutchinson's pupil. Can you see one ipsilateral dilated pupil, which could also be down and out? So third cranial nerve compression means meiosis will be lost and down and out movement will happen. So that is Hutchinson's pupil. So a lot of times they ask, which side will you do burr hole? So you will do burr hole in the side where the pupil is dilated. So it is ipsilateral to dilated pupil because that's the side where the hematoma is, because that is the side where the compression has happened for the third cranial nerve. Alright, but if they say there is no localizing sign, no localizing sign to say which side, dono ही dilated hai ya nothing is dilated, then left side. Okay, so ipsilateral to dilated pupil, if nothing, left side burr hole. So that's one thing. What other things can get compressed? Now, as it gets compressed further, it is the opposite side corticospinal tract which gets compressed, okay, against this tentorium. So now, here I have corticospinal tracts which are getting compressed, can I say, in the contralateral side. So there should be contralateral hemiplegia, but no, the corticospinal tracts are then going to decussate in the pyramids. So that is why when this crus commune gets compressed, which contains the corticospinal tract, I am actually going to get ipsilateral hemiplegia, and that is what is Kernohan's notch. So opposite side corticospinal, 2 times crossing means ipsilateral. If you're not understanding this part, I'll repeat one more time. Corticospinal of the opposite side, that's further gonna cross. So that is why ipsilateral hemiplegia, Kernohan's notch, false localizing sign. So what happens in transtentorial herniation? Kernohan notch, third cranial nerve compression of the same side, hemiplegia of the same side, and there can be diurete hemorrhages, which are pons mein bleeding, pontine hemorrhages. So these are three things which happen because of transtentorial herniation. Alright, so any sign of, any of these mass effects or herniation, we have to do decompressive craniectomy. Now let's talk about next, very important. So again, there's a history of road traffic accident, and what are we seeing? We are seeing a star of death appearance. What am I talking about? Acute subarachnoid hemorrhage, SAH. Here, the most common cause is trauma, but it can happen because of aneurysm rupture. The most common site of aneurysm that ruptures is the ACA-ACOM junction. Now here, something very important. Trauma, overall most common cause. In spontaneous SH, which is aneurysmal rupture, the history that would be mentioned is the worst headache of life. The patient will say, everything was okay. Suddenly, I had a headache which increased. So that is what we describe as a thunderclap headache. So thunderclap headache, worst headache of the life. You may have signs of meningeal inflammation also, right? Because this bleeding can irritate the meninges. So there can be signs like meningitis minus the fever. So there will be no fever which can differentiate this from meningitis. Okay, so that's the clinical history. So you did an NCCT. The moment you have this history, I do this CT and I see bleeding. So now how do I confirm the aneurysm? So the investigation of choice is CT angiography. I have to give contrast and that will show me the aneurysm. Once I've seen that, now I go ahead and do a DSA, digital subtraction angiography. Look at this. This is where I go inside the carotid, put contrast, and this gola, this has been asked many a times. This round thing is the aneurysm, and can you see this is IC dividing into two terminal branch. This one coursing along the corpus callosum is the ACA branch, and this one is the MCA branch. So this is what is an ACA aneurysm. Okay, so I've done the DSA, I have seen the aneurysm. What next? We are already inside the vessel. Should I not treat it here itself? Absolutely. So imagine this is the aneurysm. You are already here. I can put coils inside the aneurysm. What happens because of coiling is there will be stasis of blood here, it will induce a foreign body reaction, and this aneurysm undergoes thrombosis, and that is where now this aneurysm is out of the circulation. So the treatment of choice which is done currently is endovascular coiling. You have done the DSA already, now you do coiling. So that's why DSA becomes diagnostic as well as therapeutic, and this is the treatment of choice. The other alternative is that the surgeon can now put a clip from outside. When would we prefer clipping over coiling? That would be preferred if it has a very wide neck. Could you see how I made the neck narrow here? If the neck was wider, what would happen? If I try to put these coils, the coils would embolize distally and cause a stroke. So that is why if one has a very wide necked aneurysm, I can't really put a coil. So that is why for wide neck aneurysm, I will do clipping, and that's why we have to do CT angio before doing DSA, because I have to characterize how the aneurysm is. I can't directly take for DSA. Yeah, so this is clipping versus coiling. Coiling is preferred unless mentioned otherwise. One complication of SAH is vasospasm. So can you see how this is where I have the circle of Willis? Yeah. So because so much bleeding is happening, these vessels undergo vasospasm and patient can actually have, diffuse stroke. So that is what I have to prevent again. So this is where I give nimodipine to the patient. Nimodipine, dipines, DHPs are vasodilators, and we can also do a triple H technique. Triple H is basically giving more fluid to the patient such that the vessels don't undergo narrowing, they're always distended. So it is essentially hypervolemia, and Usiko they have made into two H's. So hypervolemia, hemodilution, and hypertension. So essentially you are giving more fluid so that the vessel doesn't undergo collapse. Yeah, so this is all about SAH. Now we talk about this condition, very, very important. So here they'll give you history that patient had a very severe accident. The GCS also is very low, but the patient's CT is completely normal or shows small petechiae. So this is because there is no bleeding. There is axons which are getting sheared. So this happens because of shearing of the axons. So all of these points that you are seeing as these small black dots are all the sites where there are these micro bleeds where axons have gotten injured. So that's why it may be missed on CT, because these are the small spots of bleeding which are becoming more apparent on MRI. So this is MRI, and the sequence is susceptibility weighted imaging, where you can see these small foci which represent microbleed. We have Adams staging for this. What am I talking about, by the way? This is DAI, diffuse axonal injury. So for every head trauma, NCCT suffices. This is the only condition where the investigation of choice is MR. Adams staging for 3 stages. Stage 1 is where you have these bleeds at the gray matter, white matter junction. Adams stage 2 where it happens in the corpus callosum, and stage 3 where it goes to the brainstem. As it goes from 1 to 3, the prognosis becomes worse. Okay. Upon histopath imaging, you will see that there is empty neuronal appearance called as retraction balls, and management is conservative. What do you do with axons which are broken? You can't suture them. Yeah, so you do nothing, wait and watch. All right, so this is diffuse axonal injury. What is happening here? Kala air, and can you see how this looks like a volcano? So this is what is called as a Mount Fuji sign. Okay, so this is Mount Fuji sign, and this was asked in AIIMS as a one-liner. This indicates tension pneumocephalus. Air has come inside the brain. So that is why the history is important. How did air come inside the brain? So this is because either there was a sinus fracture which communicated, or there was an open fracture which brought the air from outside. And this mountain-like appearance is because the air is putting pressure on the brain. This is the peaking of the frontal lobe because of that air. So this is Mount Fuji sign. Now look at the next one. What is the definition of penetrating neck trauma? So penetrating neck trauma is when I have platysma breach. That's the only one that we are worried about. So once the platysma is breached, now we divide the neck trauma into 3 zones. So you can see the color coding here. So remember 2 landmarks. One is cricoid and second is angle of mandible. Yeah, so the zone 1 is from the sternum till the cricoid, or you can remember below the cricoid. Zone 2 is between cricoid to mandible, and zone 3 is above the mandible. Yeah, so zone 1, 2 and 3. Anything they ask, say zone 2. So if they ask you what is most common, zone 2. If they say what is most surgically accessible, zone 2. Yeah, so that is why any zone 2 trauma, we will directly operate because it is accessible. So which patient group needs to be operated? Either any zone 2 or any signs where some critical organ of the neck is injured. What are the critical organs? Trachea. So if I have airway compromise or subcutaneous emphysema, carotid artery. So if I have hematoma, active bleeding or shock, or spinal cord, neurological deficit. Yeah, that could also again represent carotid injury. So neurological deficit. So this is what I have to look for indications of surgery. One more question here, which zone has maximum mortality? So that is again zone 1, right, where the mortality is maximum. Alright, so this is what we need to remember as far as head and neck trauma is concerned. 2 more points about indications. So these are the NICE guidelines. Now there are multiple guidelines, more or less everything is the same. Right, so different names. So you have NICE guidelines that I'm writing here because that's what is given in Bailey and Love. You have Canadian head CT rule, Nexus rule, but more or less everything say the same thing. So when should I do an NCCT of the head? You should do it immediately within 1 hour if GCS is less than 13 or it is less than 15 at 2 hours. Any neurological deficit, suspected skull fracture, this is important. At least 2 episodes of vomiting should be there. So that's what they ask. 1 episode nahi chalega. At least 2, not just 1. Any seizure, within 8 hours, do it if age is more, coagulopathy suspected, dangerous mechanism or retrograde amnesia. So don't really sit and memorize. I think this is the most important one. They usually give 1 episode of vomiting, not enough. 2 hona chahiye. 2 should be there. Then you have Nexus guidelines for CT of the C-spine. Yeah, for both of these, the investigation of choice is non-contrast CT. So CT spine is not required if no midline tenderness, no focal neurological deficit, normal GCS, no intoxication, no other injury where you may ignore the C-spine. So if all of these are a no, don't do it. If any of it is a yes, image. Right? So this is about the indications, never been asked really, just for coverage. So this you can just read it once, you'll be able to answer. In addition, we also see this 45-degree movement. If the patient can move the head side to side, again, that is one of the signs that they do not have a spine injury. You ask them to move 45-degree in both directions. So nexus plus 45-degree sideway movement is what we use in AIMS to decide whether CT should be done or not. So now we talk about vascular injury. Alright, first of all, aortic injury. The most common site where aortic injury will happen is at the isthmus, because that is the site, between the mobile and the immobile part. The pericardium reaches up till the isthmus, which is ligamentum arteriosum, which is just lateral to the left subclavian artery. So these are the 3 branches. This is the place where you have isthmus. So yahan tak the pericardium reaches, and after that it's free. So this is the junction where you have injury. The investigation of choice obviously is CT angiography. And the initial management is always esmolol, because you want to decrease the blood pressure and at least keep the mean arterial pressure to 70. So you give esmolol, which is a beta blocker, in order to decrease the blood pressure. And the definitive management is EVAR, endovascular aortic repair, where you will put a graft This is where we use a stent graft, a covered graft at the site of injury. Alright, so that is what is the treatment for aortic injuries as a general rule. One of the X-ray signs is mediastinal widening. So any mediastinum which is more than 8 centimeter. You can also see how the left side hemothorax is white. That's because you may also have a left-sided hemothorax. Alright, so this is when you suspect an aortic injury, mediastinal widening, patient is in shock, right? Sometimes the patient can also have BP which is raised. Alright, so this is about aortic injury. Then we talk about this image. So this image was asked in NEET 23 or 24. So this is where you can see a CT angiography, and this is the ascending aorta, descending aorta. So we are just at the level of arch of aorta where you can see an outpouching. So this is actually an aneurysm just at the location of arch. Can you see this? So this is an arch aorta aneurysm. So this was asked as an image. So any outpouching is aneurysm. So on this note, let's just talk about aneurysms everywhere. So the most common vessel to undergo an aneurysm overall is circle of Willis, right? We just talked about it, Berry aneurysm. So circle of Willis, Berry aneurysm, ACA, ACOM junction is what is the most common site. Most common extracranial or overall mycotic. Mycotic is not fungal, it's a misnomer. So this is where staph aureus or bacterial infections cause these. So this is where it happens in the abdominal aorta. In abdominal aorta, this is usually below the renal artery origin. So this is the infrarenal aorta. So this is what it looks like. So these are the renal arteries. So abdominal aorta below the origin of renal arteries. Peripheral, popliteal. So popliteal artery aneurysms also common. Investigation of choice, any vascular injury. Always remember CT angiogram is what you will do. Management again would be EVAR, endovascular aortic repair. Again, all we have to do is place a stent graft. If I place a covered stent graft here, do you agree? This will not allow the blood to go beyond this stent. The blood will flow through this and the rest of the aneurysm undergoes thrombosis. So that is what we do here. Now, not every aneurysm needs to be managed. So, any patient who is asymptomatic and who is stable, I can do conservative management. Okay, so I can just wait and watch. I will have to operate if surgery is done if the aneurysm reaches a size which makes it more prone to get ruptured. So, any aneurysm more than 5.5 centimeter. Because in Marfan's the risk of rupture is higher, the threshold is 4.5. And here I am talking about asymptomatic patient. Any point of time patient is symptomatic, unstable, you have to operate. Okay, so that's the size. Anything which shows evidence of rapid increase in size. So rapid increase in size is defined by two things. Either it is growing by 6 mm in 6 months, or it is growing by 1 centimeter in 1 year. 6 and 6, 1 and 1. Yeah, so then we have to operate that. One more thing about One more thing about a complication of EVAR is, let's say you've done the EVAR and after a few months you see that again the aneurysm is filling up with contrast. The cause is called as endo leak. And the most common type of endo leak is type 2 leak. What that means is there is some branch vessel which escaped, right? So there was one branch vessel which was supplying the aneurysm which escaped and that is filling. So that branch you skipped covering it in the stent, right? So that is why it is filling up. So that leak is called type 2. You'll just remember a branch is supplying it. Alright, so that's one complication. Now let's have a look at how aneurysms look like on ultrasound. So for this you have to think of normal color Doppler rules. What were our normal color Doppler K rules? Our color Doppler rules were anything which flows towards the probe is red. Imagine this is the probe. Anything which is going away from the probe will be blue. So that's how vessels look, either red or blue. Now look at what is happening in an aneurysm. Yeah, the blood is going round. So can I say for this part the blood is coming towards the probe And for this part, blood is going away from the probe. So this is the only place where I will see red and blue together like this. Do you get that? So this is what is called as the yin and yang sign. And this is what indicates that the blood is flowing round, and the only place you see this is an aneurysm. All right. Now look at this. What can you see? Remember the plane of SAM. We've done this in radio. So this is SVC. This is ascending aorta. This is main pulmonary artery. This is descending aorta. You can also see the trachea is dividing. So plane kya hai? Plane of SAM, vertebral level T5. I'm cutting at T5. Doesn't matter. What is the vessel that's abnormal? That's very clear, isn't it? Can you see how the ascending aorta is divided into the two parts? This is aortic dissection. Now, the risk factor for aortic dissection is hypertension. Correlate that with aneurysm. The risk factor for abdominal aortic aneurysm, A for A, is atherosclerosis. Okay, so that's atherosclerosis most common, but for dissection it's hypertension. Less common than hypertension, but connective tissue disorders like Marfan's, Ehlers-Danlos, syphilis will also be other risk factors for dissection and aneurysm for that matter. So now, what happens because of uncontrolled hypertension? So you know the vessel wall has intima media adventitia. Imagine there's a tear in the intima. Because of that tear, now the blood is flowing into the wall and creating a new lumen. So that is what we are seeing here. I'm seeing a bigger false lumen and a smaller true lumen, and this is actually the intimal flap separating the two. So this is what is the true lumen. So always remember, I'm putting the contrast in true lumen. So true lumen will be brighter, whereas false lumen may be larger, but it will be darker. So the only feature you can see is what is whiter. That's the true lumen. Doesn't matter, but just, if they ask you. So this is about dissection. We have a Stanford and a DeBakey classification for dissection. DeBakey divided into 3. Ascending plus descending is 1, only ascending is 2, only descending is 3. Stanford kept it simple. A for A. If ascending is involved, with or without descending, it's A. Only descending, B. The importance is Stanford. Yeah, that if ascending is involved, I will have to do surgery. But first step, beta blocker, control the BP. But what is the treatment of choice? I will have to operate because this may go down into the heart, cause aortic regurgitation, cause cardiac tamponade. But if it is B, only descending, I can just do medical management only. No need to do surgery. Only esmolol will suffice. So this is about dissection. How do we diagnose? Like everything else, investigation of choice, CT, angiography. But if the patient is unstable, I can do a transesophageal echocardiogram. I will go through the esophagus so I can see the descending as well as ascending aorta. So that is what I can do for an unstable patient. So this is all about dissection, aneurysm and aortic injury. Now we look at 2 trauma scores. First, let's finish the smaller one, MES. So MES is mangled extremity severity scores. So this is for risk of amputation. Any score more than equal to 7 increases the risk of amputation. You will remember just one thing, ELISA. The 4 parameters are energy of the trauma, limb ischemia ke signs, shock and age. So remember, ELISA, you will not forget this. GCS. You should know GCS by this point. If you don't, please memorize it right now. Let's learn together. E. What are the total E marks that we have? 4. So if your eyes are spontaneously open right now, E4. If your eyes can only open when I shout, come on, get up, speed se khul rahi hai, 3. Only when you have pressure, only when somebody hits you, pushes you, you are opening your eyes, 2. 1, still you are not opening your eyes. Okay, so that is E. V total is 5. Right now I am oriented. If I keep on talking, I'll get confused at some point. 3 is where I'm only speaking words. 2, so tired, only sounds. 1, nothing. M6, if I tell you, come on everybody clap, and you clap, you are obeying commands, you are M6. If you can't obey commands and I touch you and you're like, ma'am, why are you touching my right arm? So that's localizing pain. So that's M5. 4 is I give a painful stimulus like a sternal blow and you react. So that is withdrawing to pain, M4. 3 and 2 are posturing. So 3 is decorticate posturing, where the upper limb is flexed, lower extremity is extended, whereas 2 is decerebrate, where both are extended. So decorticate, decerebrate, one is nothing. So various points I have to now elaborate beyond GCS. So we've memorized GCS. Let's repeat. Spontaneous, speech, pressure, none. Oriented, confused, words, sounds, none. Obeys commands, localizes, withdraws, decorticate, decerebrate, none. So now let's write all the relevant points here. The first point I need to teach you, brain death. For us to fulfill a criteria of brain death, the GCS has to be 3. Means you cannot have posturing. Yeah, so GCS of 3 is what is needed. So first learning point, decorticate, decerebrate means you are not brain dead. So that's the first thing. What if the patient is intubated? That is called, there we cannot assess speech output. So there you will write VNT, non-testable. Alright. Now let's understand the concept of decorticate and decerebrate. Let's learn where these lesions are. In decorticate, the lesion is happening above the midbrain. So what that means is, because this is above the midbrain, the rubrospinal tract here is active. Yeah, so because of that, there is flexion of the upper limbs. All right, but in decerebrate, now this is below the level of midbrain. Because this is below the level of midbrain, now rubrospinal tract here does not work. So the only tract which is active is vestibulospinal tract. So vestibulospinal tract is unopposed. So because this is unopposed, this is what leads to extension of all extremities. Alright, so this is what leads to flexion of upper limb, whereas this is what leads to extension of upper limbs. Alright, so rubrospinal and the level are a little important. Alright, so now can I make that statement that for GCS, the maximum score is 15 and minimum score is 3. But now when I ask you GCSP, what is the maximum GCSP? What is minimum GCSP? So you'll ask, ma'am, what is GCSP? So that is where I take into account the light reflex. So if both the light reflexes are absent, -2. One is absent, -1. Both are present, 0. So can I say maximum still remains 15? Nothing was subtracted, but minimum becomes 1. That both the pupils will also unreactive. Yeah. So this is about the 2 scores. Then we talk about burns. Alright, so when we talk about burns, first of all, I need to learn the classification and then the management. So look at the classification now. So first degree is only epidermis. This is where, let's say you touch a hot pan, right? What will happen? Your skin will turn red. So this is erythema, blanching is intact, and you have mild to moderate pain. Sensations are all there. Nothing to do. Please don't cry. All you have to do is keep it open. Don't do dressing. Nothing much. Alright, second degree. This is important to distinguish into superficial and deep. So superficial dermis, deep dermis. Again, in superficial, you will have erythema. Now, the hallmark of second degree superficial is blisters. Yeah, still you have blanching which is present. The sensation is intact, and this is the most painful one, because after this point, the nerve endings are also getting damaged. So, this is the one which has maximum pain. Yeah. Second degree deep will have white and dry. The blanching decreases because vessels are injured, sensation decreases, pain decreases. And third degree is where it reaches the fat, white, charred, leathery, no blanching, no vessels, anesthetic, no painful. So this is where all the nerves are actually damaged. You can see painless. So painful, extremely painful, less painful, painless. That's the buzzword that you want to remember. Okay, management. Second degree superficial, now you can do a dressing. So it usually heals in a few weeks. You can use a paraffin dressing. So you can remember PA for pain, PA for paraffin. The only advantage of paraffin is it does not stick like the gauze, right? So that is why paraffin dressing helps. Then if it is deep, I want a better dressing which promotes, water retention, moisture retention. So we use hydrocolloid or collagen dressings. They prevent the ischemic desiccation. So this is where there is also a risk of scarring and contracture, and we will have to do excision and grafting. Third degree, obviously everything is destroyed, it will not heal. You will have to do excision and grafting. And also very important PYQ from 2024 is you will have to do escherotomy if there is a circumferential burn. So they had shown a body similar to this, and these are escherotomies. So whenever you have any circumferential burn, for example, it's in the torso means thorax and abdomen, arms, right, any closed circumferential burns, you will have to give these incisions to prevent compartment syndrome. This is super important. Any signs of airway injury in burns, which could be any burns around the face, blistering in the mouth, hoarseness of voice, stridor, or singeing of hair. This is the one that they give, that the hair seemed burnt. Super important. You are gonna do elective intubation. You will not wait for the saturation to drop. One of the options here will tell you that wait till saturation, observe saturation closely. No, you will do elective intubation, because after that point, if you don't intubate right now, the patient may develop so much laryngeal edema that intubation will be difficult, and directly you'll have to do a FONA, needle cricothyroidotomy. So while you can, if you see any of these buzzwords, intubation is the next step. All right. If there is already a lot of laryngeal edema, or they say that intubation is difficult, then you go for needle cricothyroidotomy, same concept as airway that we have learnt. All right. Now let's talk about a few one-liners from burns. So most common cause of death in burns, it is asphyxia more than neurogenic shock. All right. So that's why elective intubation does help. Okay. Early, it is hypovolemic shock. That is why the mainstay of burns we will learn are IV fluids. So hypovolemia, and overall it is sepsis. And the organism that causes it is Pseudomonas most commonly. We've also talked about this in micro, right? So now it's all about how much body surface area is burnt, and that's what we use to calculate the fluid. So we use a rule of 9, all right? So this is called as Wallace's rule of 9. But what is most accurate? So there are these charts that we have called as Lund and Browder charts, which are most accurate. So now let's learn rule of 9. You don't have to calculate using these charts because you can't carry them in the exam and you can't memorize them for sure. So we calculate using rule of 9. So let's see. First, draw your own Wallace. Imagine this is Wallace. Okay. So thorax is 9 plus 9, anterior posterior. Abdomen is 9 plus 9, anterior posterior. Lower limbs 9 plus 9, anterior posterior. So 4 times I've written 9 plus 9. The upper limb and face just gets 9 and the perineum gets 1. So this is how we measure the body surface area in an adult. In a child, now this decreases. So here I am talking about a child less than 14 years. Okay. So in a child, what happens is their legs are smaller, but their head is bigger. So everything else remains same. 9 plus 9, 9 plus 9, 9 and 9. So I give 18% to the head and I take the other 9. So I take basically, फिर से बोल रही हूँ. So I have to account for 9 missing things. So this is 7 plus 7, 14. Yeah, and I remove the perineum 1%. Okay, so this is how we have to remember the percentage in children and adults. So this is where they'll ask you questions like this, calculate. So they'll give different permutation combination and you have to calculate. A lot of these, will be wrong because you interpret wrongly. That's the major source of mistake. Not that you don't know rule of 9, You don't know what examiner is asking. Torso, for example, many students won't know what torso means. So torso is thorax and abdomen. So interior bol rahe hain, so can I say 9 plus 9? Yeah. Upper right arm. Now what does that mean? So if I say total is 9, can I just assume upper bol rahe hain? Let me take 4.5. All right, I take a leap of faith. Right thigh. So they have not talked about this being a child, so I assume it to be an adult. So right thigh. Agar pura limb is 18, if I just take thigh, that to pura, I can just take 9, half of that. So 9 threes are 27, 27 plus 4.5 becomes 31.5. So this is how you have to, just do permutation, combination and answer. So this is about rule of 9. Now, how do we give the fluids? So first of all, what fluids to give? The fluid of choice in adults is ringer lactate. In children, you also add 5% dextrose because their glucose stores are lower. The time, whatever fluid you get, half of it is going to be given over 8 hours, other half over 16 hours since time of burn. Okay, so you have to calculate this fluid amount and give it over 24 hours, half of it over 8, half of it over 16. How much to give? So for adults, we do 2 ml into kg into percentage body surface area. So you calculate the weight and percentage burnt areas multiplied by 2. Imagine the volume came out to be 5 liters. So 2.5 liters I'll give in the first 8 hours from burn, other 2.5 over 16 hours. In children, I give more, so 3 ml into kg into percentage, and when there is electrical injury, I give 4 into percentage into body surface area, because electrical injury will have a higher risk of myoglobinuria, which can lead to acute tubular necrosis. So the only way to prevent tubular necrosis is give more fluid, right? So that's what I do. Initially, we used to follow Parkland, which followed 4, but that would create a lot of hypervolemia. So that is why now, if they don't mention, you will use ATLS. Okay, so only when they mention Parkland, batao, use 4, not used in practice. This is used in practice. Okay, then a few general concepts. If you have a patient who has a burn, do not cool it with ice. Don't use your genius brain that there is a burn, it's very hot, let me give something very cold. Net result 0. No. What happens with ice? So for that, there's also a concept. That is Jackson's theory of zones of burns. The center part is burnt already, coagulative necrosis. Any temperature of 60 to 100 degrees Celsius leads to necrosis. Beyond that is a zone of stasis, and then I have hyperemia. If you use ice, what's going to happen? There is going to be more vasoconstriction. Even this stasis zone becomes necrosed, right? So that is what you don't want to do. So that is why you cool at around room temperature water, which is 15 degrees Celsius water. And this can be done up to 1 hour, right? So after that, there's no point. Do this in the first 1 hour. And another general point, if the patient has blisters, which is like superficial second degree burn, do not burst those blisters, right? Then what material do we use for dressing? So both of these, in fact, all of these are going to fight against Pseudomonas. Yeah. So sulfur sulfadiazine is effective against Pseudomonas, but it cannot penetrate eschar. So the only problem is if there is an eschar, it cannot penetrate. Silver nitrate has a side effect. It leaves behind black discoloration. MA, mafenide acetate, has a side effect. It causes metabolic acidosis. And cerium, C is C, it improves the cell-mediated immunity. So this is expensive, but this is the only one which improves cell-mediated immunity, and this is useful for elderly patients. The last thing we have to study is frostbite. So the opposite of burns, frostbite. So this is the grading of frostbite if you have no cyanosis, no amputation needed. Grade 2 is cyanosis till the distal phalanx. Cyanosis up to metacarpophalangeal and proximal to it. So that is where the risk of amputation keeps increasing. So if it's proximal to a metacarpophalangeal, 100% risk of amputation. And what do we do? So this is where you have to do rapid deworming, and the ideal temperature, very controversial, but consensus, 40 degree. So rapid deworming at 40 degrees Celsius is to be done here. So this is what we need to remember from burns. So now we begin with thyroid. Now thyroid and breast, the next two set of topics, very small topics, but you almost always get at least one or two questions from these. So these are very, very high yield. So the first part, we're going to talk about a mix of thyroid path and surgery. So let's start with cancers. So what do you think is this list? So all of these are representative of, so let's see the questions. The most common one associated with radiotherapy as a risk factor, thyroglossal cyst and Hashimoto's thyroiditis. So we are talking about papillary thyroid cancer, right? So papillary, these are the risk factors. It's the most common, best prognosis. That's how it usually is. Whatever is most common will have best prognosis, with some exceptions, but this is, unless mentioned otherwise, remember it like this. Lymphatic metastasis, right? So it goes to lymph nodes. Associated with BRAF mutation, and this translocation T17. This has never really been asked, but BRAF mutation, very important. Can you tell me 7 cancers that we've studied with BRAF mutation? So let's see, 2-2K pairs we remember. 2 things with P. So remember papillary CA thyroid, pilocytic astrocytoma. Okay. Then Langerhans cell histiocytosis, hairy cell leukemia. Okay. So these two are 2 pairs. Then 2 things in the GI tract, adenoCA colon and GIST. Both are associated with BRAF. So these are 6, and the most important, melanoma. So these are the 7 things with BRAF, and we will discuss it at least 7 times. Okay. Then what is the cancer which is associated with iodine deficiency? Multinodular goiter, MNG is multinodular goiter and has hematogenous mets. So now we are talking about follicular CA thyroid, right? So we are now talking about follicular CA thyroid. It is associated with RAS gain of function, and this is the translocation. Again, extra edge, never been asked. Translocation 2-3. PAX8 translocation. So this is follicular. This is the one which has hematogenous met. So this is a PYQ from last year where they showed a lytic lesion in the skull and they had asked what would be the primary, papillary, follicular, medullary. So the answer is follicular. So you will remember it will have bony metastasis, it will have lung metastasis like cannonball lesions. In fact, the bony metastasis here in ortho we've studied could also be pulsatile because it's so vascular, right? So that's something which is important, has been asked. Then the most important for exam is this set. One associated with MEN2, RET mutation. So this is MTC, medullary thyroid cancer. What are the tumor markers? The most important is calcitonin. Important point. Does it lead to calcium phosphate changes? It does not. So, normally calcitonin works opposite of that of PTH. PTH increases calcium, whereas calcitonin decreases calcium. But in MTC, this calcitonin, even though it is raised, it's non-functional. It's just a tumor marker. So, remember here, I'm going to write this, that the calcium level are going to remain normal, right? So, calcitonin is a tumor marker. It's not a functional calcitonin that is produced here. CEA is also raised, important point. You may also have presence of serotonin. So a lot of times serotonin here can be raised, and rarely even ACTH can be raised. So the patient can have Cushing-like symptoms, patient can have diarrhea. So very unique sort of a presentation. Dense bodies are found on electron microscopy. This is a PYQ. Very important. It goes to central lymph nodes. So whenever MTC is the diagnosis, central lymph node dissection is always done. So that also tells us about the treatment here, that the treatment is always total thyroidectomy and we will always remove central lymph node. That is not true for papillary follicular. There the management will depend on the size of the cancer, risk factors. So if it is very well differentiated, we can also go along and do just hemithyroidectomy. But in MTC, we are always going to do total thyroidectomy. So I'm going to write here total thyroidectomy with always central lymph node. Whether we are doing radical neck dissection or modified radical neck dissection will depend on the fact if there are lymph nodes. If lymph nodes are there, we do radical neck dissection of that side. Otherwise, you are not going to dissect the side nodes, but central always done. So that's something about the treatment also. So have that concept in mind. And there is no role of radioiodine. Okay, so that's important, that there is no role of radioiodine in the treatment of MTC. It does have a role in treatment of papillary and follicular. If there is a recurrence or residual disease, I can use radioiodine, but not for MTC. So these are all very, very important questions. One rule, if you don't know, mark MTC. Okay, so that is how important it is. Worst prognosis is anaplastic cancer, happens in elderly patients. Then something important, where they'll give you a stony hard thyroid. Not just that, patient will also tell you, Dr. Saab, I have multiple tumors. I have orbital swelling, I have parotid swelling. Patient will also have pancreatitis, which I'll also talk about in the latter half of this video. We are talking about a disease spectrum called IgG4 related disease, and the thyroid involvement there is called as Riedel's thyroiditis. Okay, so Riedel's thyroiditis is actually IgG4 related disease. Where what is IgG4 related disease? That is where you have deposition of plasma cells that make IgG4 antibody, and you have fibrosis. So because of that fibrous inflammation, what you have is a lot of hardness that is felt and described as stony hard by the patient. Okay, and this is one of the things where we can do a thyroid biopsy. Otherwise, never do we do a thyroid biopsy. It's so vascular, the patient will bleed into his neck, his tracheal compression will happen, he'll die because of your biopsy. So never ever biopsy. What the only indication where you can actually biopsy is Riedel's thyroiditis, because it's so stony hard that the vascularity has kind of decreased because of the fibrosis. Okay, so the diagnosis can be made upon thyroid biopsy. So that's what I want to tell you here. GNAS mutation is, something where more and more thyroid hormone gets produced. It's a TSH. In endocrine, we have learned TSH acts through GS. So this is that GS, gain of function. So a lot of thyroid gets produced, and what do we call that? Toxic adenoma, right? So it makes a lot of thyroid because it's autonomous activation of GS receptor. That's how you can remember it. Then, important, there are two iodine related changes. So iodine can lead to hypo or hyperthyroidism. So if it is Wolf check off, thyroid off ho gaya hai, it means it is hypothyroid, which is happening because of iodine. Don't see the other one. Off hai means hypo. If it is not off, it is hyper. So these are the two effects that iodine can lead to in terms of hypo or hyperthyroidism. Then let's talk about thyroiditis right here, which is the thyroiditis which has anti-TPO antibodies. So it's an autoimmune thyroiditis, also called as stroma lymphomatosis, means it has trauma and it has lymphoid tissue. So we are talking about Hashimoto's thyroiditis, right? Autoimmune thyroiditis. So it's an autoimmune condition, Hashimoto thyroiditis. Important point being that this is where you have a risk factor of two malignancies. One we already did, papillary CA, and the other one, because it has lymphomatosis, it can also lead to lymphoma, right? So it's a risk factor for two malignancies, pap CA and lymphoma, right? So that's what is Hashimoto's. Then if you have thyroiditis which is painful, history of URTI is there. So pain se yaad rakho, vein. So this is de-Quervain vein. So you can remember vein is pain. All right. De-Quervain's granulomatous thyroiditis. All right. So that means in the histopath, I'm going to see these giant cells. I'm going to see the formation of granulomas. So this is an image which is showing de-Quervain's thyroiditis, painful thyroiditis. All right. Where you will see granulomas. On the other hand, the one which is silent thyroiditis, silent meaning painless. So opposite of de-Quervain, here you don't see granulomas, you see lymphocytes. So this is what is called as lymphocytic thyroiditis. All right. So these are the three kinds of thyroiditis, and all thyroiditis, how they behave. They'll initially have a hyperthyroid phase because the preformed hormone gets released. As soon as inflammation comes, all the preformed hormone is released. So there is a transient euthyroid state, right, where all of that extra stuff is gone. And then eventually now the thyroid is not working, right? So now it is eventually hypothyroid. So this is how any thyroiditis will behave. Initially transient hyperthyroid, and then eventually hypothyroid. Okay. Let's look at more path images which they love to ask. Both of these are like all-time favorite images. What is this? So this is what all of you must know. This is orphan Annie nucleus. Yes. So what is orphan Annie? It is a cartoon character jiski eyes were empty. So that's what it refers to, this empty looking appearance. Orphan Annie eye appearance. This is the hallmark of papillary CA thyroid. In addition, what else can you see? You can see that there are coffee bean nuclei. I mean, you can't see, but coffee bean nuclei is always there, okay? So this is coffee bean nuclei, orphananii. And what bodies can I see here? Sarcoma bodies, right? So sarcoma bodies can be seen here as well in papillary CA thyroid, okay? So this is about orphananii. Then we talk about this, super important. Can you see this pink amorphous material? That's what they'll describe, amorphous eosinophilic material. The moment you see this diffuse pinky stuff, what is it? This is amyloid. All right, so this is where you have amyloid stroma, and that amyloid is nothing but the tumor marker, amyloid of calcitonin, right? So whenever they describe that buzzword, eosinophilic amorphous extracellular material, vowels stick together, yeah? So amorphous extracellular material, they are talking about A for amyloidosis. And where do we have amyloid deposition? In medullary thyroid cancer, right? So this is MTC. Then there is one gross specimen of thyroid. It looks pretty black. So this black thyroid is what is an effect of which drug? Minocycline, right? Never been asked, just fun to know. So black thyroid, minocycline. All right, so these are all your one-liners as far as thyroid cancer path is concerned. Now let's go into the surgical aspect, which starts with clinical examination, and they love to ask you stuff which will tell them whether you attended your third year rotation or not. Now, irrespective of that, let's just do it now. All right, so what is this? This method is called Pizillo's method, where you are making this more prominent. The thyroid is more prominent. So Pizillo, prominent, Pizillo O. This is more useful in obese patients whose thyroid is not really prominent like thinner patients, okay? So everything is there in the name. Pizillo, P for prominent, O for obese, more useful in obese. Then look at these. It's as if these two hands are talking to one another, and this hand is saying, hey, la thyroid. So it's asking for thyroid. So what is this? La he's. Hey, la thyroid. Okay, so these are two hands. That's how you'll remember this picture. Then when you see the thumb, you know how C and T always go together, CT, right? CT scan. So CT, this is Kreil's method. So Kreil and thumb, palpating the dominant nodule. This is for finding the dominant nodule in a multinodular goiter using your thumbs. Then here, what are you trying to palpate? Carotid, isn't it? So you're trying to see whether the carotid has been encased or involved by the swelling or not. So when you are palpating the carotid artery, can I say it's a very important artery? So this is what is Berry's test, okay, where you are checking for carotid. On a similar line, I couldn't really find a good image, but if somebody is trying to press your neck, right, if somebody is trying to strangulate you, when it looks like that in the photo, you will think that we are trying to compress on the trachea to see whether the trachea, whether there is tracheal compression or tracheomalacia because of that swelling or not. And that is called as Cocker's test. So Cocker's test would just look like somebody strangulating, and I couldn't really find a good image of that. So maybe the examiner also won't. So Cocker's is airway assessment. All right. So we're trying to see for tracheal compression. Then this one is super important. Here, this person is raising his hand, and we see that his face has become all red. He's flushed. His upper chest wall veins will become prominent. This is Pemberton sign. And what does this represent? When he's raising his hand, basically what happens is the compression of the SVC gets even more exaggerated. So that is why whatever was the upper lobe venous drainage, that gets blocked into the SVC, because SVC is blocked. So this Pemberton sign as a general concept means that person's SVC is compressed. Okay. Now, in context of thyroid, how can SVC get compressed? If the thyroid is going down into the mediastinum, right? So in context of thyroid, this sign will be used to show you retrosternal goiter, that the goiter is now extending down into the mediastinum. Okay. But in context of CA lung, this would mean that CA lung is invading into the superior vena cava. So either ways they can ask you this, either CA lung, isme likha hoga elderly smoker, that's what they'll write. So elderly male smoker, and then they show you this, think of CA lung invading SVC. If they show you thyroid swelling and they show you this is SVC compression by retrosternal goiter. They can also show you an X-ray of that. Can you see this? Look at this. This is a swelling. Can you all appreciate in the upper mediastinum? And look at the trachea. The trachea is getting pushed by this mass lesion. So this is what is retrosternal goiter on an X-ray. So this is where you have a severe, risk of airway getting compressed. So you must always do a preoperative chest X-ray here or a CT scan to see what is it doing to the airway, right? So that's something which is very important for the anesthetist as well. So that was one of the questions, that pre-op X-ray must be done. So now you have seen it, you don't have to write that or memorize that. The second point, very, very important. Whenever I have a neck goiter extending down into the mediastinum, do I need to give a mediastinal incision? No. So that's very, very important, that only neck incision will suffice. Okay. You can just take out that goiter. It is easily pulled out through that neck incision itself. And the reason is it does not derive blood supply from mediastinal vessels. It derives its blood supply from the neck vessels only. So that is why I do not really have to give a mediastinal incision, because there is no vascularity there. It can be pulled up. So that has been tested many times. The only exception is when you would want to give a mediastinal incision is if it is a primary mediastinal goiter. What if somebody has an ectopic thyroid into the mediastinum, no neck swelling? So in that case, obviously it's getting vessels from the mediastinum. So when it's a primary mediastinal goiter without any neck swelling, then we will have to give mediastinal incision. That's kind of obvious. And when the second is that the size is too big, when it is bigger than the thoracic inlet, cannot pull it out completely, then obviously, so either, both are very, very logical exceptions. Either the size is very big or it's just arising from an ectopic thyroid in the mediastinum. Yeah, so just use common sense. But this concept, super important, that if it extends down into mediastinum, it's not getting vascularity from the mediastinum. Right. Then look at this one. You know anything on ultrasound which is black, kala pani, this is a cyst, yeah, and this is what is showing that this cyst must be moving on tongue deglutition. Thyroid swellings move with swallowing. The reason for that is it's attached to the pretracheal fascia. It's surrounded by pretracheal fascia. So it moves during deglutition. We'll write that in a bit. But why it moves during tongue protrusion? That must mean that it is along the tract of the thyroid descent. Thyroid descends from the base of the tongue. So that's called foramen cecum. So from that base of the tongue, it comes down. Right? So because it is moving with tongue protrusion, it must mean that it is on this descent. And what is this cyst now? Can you tell me? Yes, this is thyroglossal duct cyst. Yeah, so this is a thyroglossal cyst. Now, usually when I see a cyst, it's good news, right? There's no chance of malignancy. But here, there are two problems. One, this is a risk factor for which cancer? What did we study? Papillary thyroid cancer. Second, if I just remove the cyst to remove the cancer risk, it will recur. So it has very high chances of recurrence. So that is the reason why the management involves cyst trunk operation. I like to call this as cyst track operation. Remember this as cyst track means I want to remove the entire tract, because otherwise it will recur, right? So cyst trunk operation, remove the entire track of thyroid descent from foramen cecum till the thyroid. So that's important. And the most common location is just below the hyoid, infrahyoid. Okay, so that's also an important question. Then we go on to solitary thyroid nodule. So how do we approach a patient who has a thyroid nodule? Very, very important. Tell me what is the first thing you will do. And this was also asked in November INI 2025. The first thing you will do is a thyroid function test. So TSH plus minus T3, T4. So thyroid function test, essentially TSH. Okay. So here I am trying to see whether the patient is hyperthyroid or not hyperthyroid. Because if he is hyperthyroid, then my management will be different. So now I need to find out the cause of hyperthyroid. So TSH low matlab hyperthyroid. Yes. So when the patient as hyperthyroid, my next step is going to be, so this is what they will ask you, that TSH we did, it was low. What do you want to do now? So if the TSH is low, means thyroid is producing a lot of hormones, radio iodine uptake scan is what I'm going to do. Now, what do I use for this? I use iodine 123 radioisotope. All right. If this is not there, I can also use technetium 99M per technate. It's the same thing that we had used for Meckels, if you remember, in radiology, right? So this is what I am doing here, radioiodine scan. Look at the radioiodine scan studies. This is what is a normal study where both of the thyroid are taking up some amount of iodine, right? That's how a normal thyroid will use iodine to make thyroid hormone. Look at this one. This is where you can see that there is a spot, a nodule, which is not showing uptake. So this is what we call a cold spot. A cold spot is not a good news, because this means that this nodule is likely malignant. It has 20% risk of malignancy. Okay. This is with respect to 4% risk of malignancy in a hot nodule. So just to give you a reference, this is 4%, whereas cold spot has a higher risk. So that is why my next step would be to FNA this cold spot and rule out cancer. Okay, so that's cold spot for you. Look at this one. It looks like the thyroid is so angry, so much uptake compared to normal. This is because it's doing a lot of work. Graves' disease. It's taking up so much iodine because it's an overdrive. What is Graves' disease? You remember LATs, long-acting thyroid stimulant. There's a TSH receptor antibody and there's auto-activation of thyroid. So it's going on taking up the iodine. So it looks like it's angry. So this is Graves, increased diffuse uptake. What is this? Thyroid is showing middle finger. Thyroid is also showing middle finger. Why? Because this is pyramidal lobe. It's an accessory lobe. What do you do when somebody shows you middle finger? You ignore them. Even thyroid. So this is a normal variant. You have to do nothing. Ignore it. Then coming to hotspot. So when I see that one nodule is taking up more iodine than rest of it, this is what is a toxic adenoma, and this is what is producing the hyperthyroid symptoms of the patient, right? So this is hotspot toxic adenoma. When you have multiple such nodules, multi-toxic adenoma, this is what we call as Plummer's disease. Not Plummer's-Vinson's disease. What was that? That Plummer-Vinson was when we had an esophageal web resulting in dysphagia, there was glossitis, there was iron deficiency anemia. This is Plummer's disease. So, whenever you have a toxic adenoma or a Plummer's disease, you want to remove that part, right? So, you can do a hemithyroidectomy, or, depending on how many nodules, you may have to do a total or a near total thyroidectomy. Then this is interesting. This is where the patient actually has hyperthyroid. But when you see the radioiodine uptake study, there's no uptake. So who is making the thyroid? So here I have three possibilities. The first possibility when the uptake is decreased is thyroiditis. Remember, there was just a transient state where the preformed hormones were released. Thyroid actually was not working. So that is why the uptake is decreased. Second, there can be something called as struma override. So if there is an ovarian tumor which is making thyroid hormone, right, then the thyroid does not have to work. So this is what is seen in a mature teratoma producing thyroid hormone. Third is factitious. A lot of these supplements, off-label supplements for weight loss particularly, thyroid increases basal metabolic rate, so can lead to weight loss. So these weight loss supplements can contain thyroid hormone, and that can also result in the thyroid shutting down. Thyroid does not have to work because you're taking it as a supplement. So these are three causes where patient has hyper, but thyroid is not working. Yeah. So this is about radioiodine uptake scan. Now let's go to this particular scenario where we are saying that it's not hyperthyroid. It could be hypothyroid or it could be euthyroid. So the thyroid status is either hypothyroid or euthyroid. What is my next step? My next step is to do an ultrasound. Okay, so the radiological investigation of choice for a thyroid nodule is ultrasound. On ultrasound, we have this TIRADS grading. Soon we are going to study BIRADS. What is the full form of both of this? The first letter tells you organ. Okay. So here it's thyroid. What is IRADS? So thyroid or breast imaging, reporting and data system. It's very, very dull and very non-specific. Okay, so here it's thyroid, imaging, reporting and data system. So essentially what all of these RADs do is they give you an objective scale from 1 to 5, rather than me describing all features of that nodule and saying correlate clinically. Why don't I give a number and we have a proper scale where I am very transparent in terms of whether I think it's malignant or benign, and the surgeon understands precisely that, because surgeon is not going to understand there's a hypoechoic ill-defined nodule with punctate echogenic foci, right? They're going to be like, okay, but what is it? And then I write correlate clinically. So that was the lacuna, right? That nobody is really saying what it is. So here there is no subjectivity. It's all objective. It's a number that you give. Lower the number, lower the chance of malignancy. It ranges from 1 to 6 usually, where 6 is biopsy proven already. So 5 means malignant, 1 means normal, 2 means benign, 3, 4 means intermediate. That's the overall scale. I'll repeat: 1 normal, 2 benign, 3, 4 intermediate, 5 I'm very sure it's malignant. Yeah, so that's how it usually works in everything. TIRADS, BIRADS, we have LIRADS for liver, YRADS for bladder. So you use your logic. PIRADS for prostate. So everywhere we have this RADS now because it's working out, right? Good communication between radiologists and surgeons. All right, so this is TIRADS. TIRADS encompasses 5 things. You don't really have to memorize because I'll tell you the answer. It does not include Doppler. They can only ask you it includes all except, yeah, does not include Doppler. So what are the suspicious features? So instead of remembering the entire TIRADS, I've given you what matters. What are the features which are more likely to be malignant? Composition. If it's solid, cystic means good, na? So agar solid hai, it is bad. Echogenic. Anything which is hypoechoic, bad. Which shape is worse? If it is taller than wider. If it is growing horizontally, it's a benign thing. If one is eating too much growing horizontally, benign. It's just eating. But if one is growing taller, that means he has acromegaly or gigantism. That's not normal, right? So you remember, taller is always bad. So taller. Irregular, bad, self-explanatory. Punctate foci. Punctate foci represent microcalcifications. So that's bad, right? So this is how we give a score on TIRADS. You don't have to do that until you take up radiology. So you just need to know what are bad features. So let's say I gave a TIRADS which was 3, 4, 5. Yeah, means I'm not sure if it's benign. So what is the next step? My next step is FNSE. So any TIRADS where I say it's not normal or not benign, they are going to do FNSE. So I need TIRADS 3, 4, 5, particularly 4 and 5. They will have to do FNSE. What is FNSE versus biopsy? Fine needle aspiration cytology. I put a very thin needle in FNSE such that there's no bleeding and I just get cells. When I do biopsy, I get tissue, right? Tukda. In Hindi, we say tukda liya hai. So that is what is a piece. I have tissue. I can see invasion there. Here I just have cells. So the pathologist is going to look at the degree of atypia, pleomorphism, mitotic figures, all of these things in a cell to determine how malignant it is. Okay. So based on the FNSE, they have now given an updated Bethesda grading. So what I'm showing you is the updated one because they have changed this significantly. So that's why this is the 2023 version where these are the categories. First one, non-diagnostic. Kya karoge? I will have to repeat it, right? Preferably under ultrasound guidance now. Second is benign. Good. Nothing to do. Follow up the patient. 3 is a problem. Just like TIRADS, 3 is where nobody is sure. So 3 is atypia of undetermined significance. I don't know what to do, right? Then FN. This is the most important. This is follicular neoplasia. Now this is where I cannot distinguish whether it is follicular adenoma or carcinoma because all I am seeing are follicular cells. The only way I can distinguish is to see vascular or capsular invasion. I can't see that on cells. So I need tissue. I can't biopsy thyroid. So what can I do? So the smallest thing or the easiest thing I can do is remove half the thyroid. So what they will do is they will do hemithyroidectomy, Send the specimen to the pathologist. They will see whether there's adenoma or carcinoma. If it's adenoma, close the patient. If it's carcinoma, remove rest of it, right? So that is how they plan this. So this is a very, very important question, right? So I can ask you, what will you do if the FNA result is Thigh 4? Now beware, previously this was considered Thigh 3. So ideally they should not just give you Thigh 1, 2, 3, 4, 5, they should give you FN, right? So that's what they ideally should, but this is what I'm just telling you, that previously this was Thigh 3, now it's become Thigh 4, alright? So anyways, so this is what is follicular neoplasia, and the next step is going to be hemithyroidectomy. 5 is bad, suspicious for malignancy, and 6, they are very sure it's malignant. Yeah, so 5 and 6, you will treat it as cancer and go ahead and plan a thyroidectomy. Alright, so this is FNSC. Another independent, very old AIMS question can be repeated. What is adequacy of FNSC? So 6 and 10. 6 looks like G, if I make G capital. Yeah, so 6 groups, 10 cells per cluster. So remember 6G. हर एक group में 10 cells. So there should be like 6 groups with 10 cells each. That's what it means in a slide. That is an adequate FNSC. Okay, so this is all about thyroid nodule approach. Now we go to some features about thyroid surgery. So the biggest risk was recurrent laryngeal nerve. Remember the first slide of this video where we talked about two poles of thyroid, upper pole SLN का risk होता है, lower pole RLN का risk होता है. And how do we ligate the vessels? We ligate them close to the capsule, right? Upper pole close to the capsule so that I can prevent injury to ELN, which is a branch of SLN. Lower lobe pe I ligate close because I don't want to injure the other branches of inferior thyroid artery, which are going to supply the parathyroid and thymus. So that part I hope you remember. We have already done that, so I'm not going to write it again. Now, RLN injury. So the maximum risk of RLN injury is at the Berry's ligament. What is Berry's ligament? It is the thickening of the pretracheal fascia. Okay, so this is where you are going to have maximum injury. There are two triangles which tell you about the same. So there is Bear's triangle and there's triangle of concern where you have risk of RLN injury. So Bear's triangle is a triangle which has common carotid, inferior thyroid and RLN itself. It is a part of the boundary of triangle. So there also it can get injured. Triangle of concern is between Berry ligament, RLN and trachea. This is also a triangle where inferior thyroid artery can get injured. Alright. So these are just two triangles, never been asked, but they can ask you the boundaries. Okay. Another question which has been asked, that RLN can be injured at all except. So can I say what all have I learned? I have learned that RLN can be injured definitely at the Berry's ligament most commonly. It can get injured in the Bear's triangle. It can get injured at the inferior pole of thyroid. It cannot get injured during strap muscle dissection. That is what was asked. Why would it get injured during strap muscle? Is it that superficial? It is not. It runs in the tracheoesophageal groove, right? So that is what was a PYQ. Alright. Then let's do 3 relevant anatomy points which are very commonly confused. Thyroid upward extension is prevented by strap muscles. Downward extension into the mediastinum is prevented by Berry's ligament. Very important. Downward. Thyroid moves during deglutition because of pretracheal fascia that surrounds it. Okay, so these are 3 one-liners. Don't mix them up. Then let's talk about prognostic factors. So there are 2 indices that we have. One is called ages, one is called AMEs. Alright, so except for GNM, 3 things are common. I have put age in red because that's the most important prognostic factor for thyroid cancer. That's an important one-liner. For breast, we will learn its lymph node. For thyroid, it's age. Okay, so age. Then you have E. E is extrathyroidal extension and S is the size. So first 3 are common. In ages, G is grade. In AMEs, M is metastasis. Alright, so these are the 2 indices, and then there's one more indice which is called MESIS, out of which again M, A, I and S are the same as above. What is C? C is completeness of surgery. So this is a post-op score. How complete was the surgery? Whether you left behind residual disease or not. Right? So there are 3 indices. Again, very logical. Ages, Aim is masses. You'll be able to expand it looking at the options only. Trust me on that. Now, let's talk about the different types of thyroid surgery. So, what is hemithyroidectomy? Let's say this is thyroid. So, this is where you remove one lobe. Isthmus always goes. Okay, so isthmus is also gone. What is subtotal thyroidectomy? Subtotal thyroidectomy is where you just leave behind 4 grams of thyroid on each sides. Okay, some part left behind on both sides. That's subtotal. What is near total? Near total is where it is also called as Hartley Dunhill procedure, where 4 gram is only left behind on one side. This is something that you would do, for something like Graves' disease, where you want to leave behind little bit. 4 gram is enough to sustain. All right, so this is what is near total thyroidectomy. For thyroid cancers, we are mostly gonna be doing total thyroidectomy, right? As we discussed, except for well differentiated thyroid cancers, which are good prognosis, small, I can do hemi, but everywhere else, total thyroidectomy. Okay, so that we will solve as an MCQ and we'll learn that separately because it's not very high yield. Okay, so the general rule is we will do total thyroidectomy, all right, for thyroid cancers, except for well differentiated. So only for very well differentiated thyroid cancers, what we call as DTCs, differentiated thyroid cancers, which are smaller than 4 centimeter, the age of the patient is younger than 55 years. In these cases we can do, but the moment I see there is history of radiotherapy, there are familial associations, it is medullary thyroid cancer, I will do total thyroidectomy. So medullary thyroid, radiation, this was a PYQ, familial association. So any red flag, which is given in the question, just do total. So that's why I don't want you to remember this long list, not worth it. Okay. Then let's talk about thyroid surgery complications. One, we have done RLN injury. Okay. And we've done vocal cord palsy. So you'll understand this statement. What happens if there is bilateral recurrent laryngeal nerve injury? Let's go back to concepts. When there is bilateral recurrent laryngeal nerve injury, all laryngeal muscles are supplied by RLN except TAD, cricothyroid, right? Cricothyroid is tensor adductor. So the adductor is the only one which is spared. So the cords are going to be adducted. So this was a PYQ that following thyroid surgery, the anesthetist says he can't extubate. Means what? Intubate to ho gaya. We could intubate, but now because of vocal cord palsy, the cords are adducted. How am I supposed to remove the tube? So that is what was bilateral RLN injury. Very, very good question. Right? Then, what are these two signs that I'm showing you? So, post-operatively, 2 to 3 days later, you're tapping on the cheek of the patient. For some reason, you're doing that. So, this is what is called as Chvostek sign. The patient says that, doctor, what are you doing? I'm having perioral paresthesias. Chvostek sign. You measure his blood pressure. As you inflate the BP cuff above systolic blood pressure, you see this orientation. This is called as carpopedal spasm, or an obstetrician's hand, okay, because they deliver babies like that. So this is what is called as Troju sign. So both Troju sign and Chvostek signs indicate what? Hypocalcemia. Now what is the cause of hypocalcemia post thyroid surgery? Is it accidental removal of parathyroid? Not really. The more commoner cause is actually because of vascular injury. Which vessel did I tell you? ITA, inferior thyroid artery, supplies all 4 parathyroid, also supplies the thymus. So that is why if you don't ligate close to the capsule, what's going to happen? This will undergo vascular necrosis, parathyroid will undergo necrosis, and what are we going to have? Hypo-PTH. And that is why it's not immediate. It happens 2 to 3 days after thyroid surgery. If it was accidental removal of PTH, it would happen on table, right? So this is what is very, very important. It's actually the reason is vascular insult. Okay, so this is what is hypocalcemia following thyroid surgery. One more one-liner, most common cause of intraop thyroid storm is actually inadequate patient preparation. So this is inadequate patient preparation. So before thyroid surgery, we have to give thyroid suppressants like beta blockers, which will convert the peripheral conversion. I want to give steroids. I want to give PTU, which will block the synthesis as well. So this is what is going to ensure. We also want to give iodine, Lugol's iodine. So this is what will ensure that there is not much thyroid hormone in the thyroid, because as soon as you operate, the preformed hormone gets released. So if you don't do this, there will be intraoperative thyroid storm. All right. Now let's go to parathyroid. This is one question that they are just not getting bored of asking. It's been in every exam since I started teaching, literally. So this is what is SESTA-MIBI scan. Okay, so SESTA-MIBI scan is what is the investigation of choice for parathyroid adenoma. You know, parathyroid adenoma is the most common cause of primary hyperparathyroidism. Okay, so how do I detect it? So one is technetium 99M SESTA-MIBI scan, right, which is a two-dimensional scan. This is called a scintigraphy. I see a hot spot. I know that this is the parathyroid adenoma. Another option is, ma'am, give me a CT also in addition, and I can localize it three-dimensionally. So what do you think is better? This one, right, where I'm giving you a CT as well. So this is what is called a SPECT, single photon. These are the two letters. We have learned this in radio as well. Single photon emission computed tomography. So this is just a CT scan with that scintigraphy. So if they ask you what is better, obviously a CT scan together is better, right? So this is what they had asked. So bottom line is, do SESTA-MIBI. But which one is better? SPECT SESTA-MIBI better than technetium SESTA-MIBI, right? So look at the options and answer. Fine. Then we look at Miami criteria, very old repeat question, that if the surgeon has removed the culprit parathyroid adenoma, in the OT itself, they will see that there's a 50% decline in the parathyroid hormone within 10 minutes, because the half-life of parathyroid is short, 10 minutes. So that is what is Miami criteria. You will know if you've removed the culprit adenoma or not. 50% decline, 10 minutes. Most common cause of hypercalcemia in hospitalized patients is malignancy. This was asked last year. So this is what is likely, asking about squamous cell carcinoma leading to parathyroid releasing peptides. So malignancy. Now let's talk about hyperplasia. What if there's hyperplasia of all four glands? Now what do I do? So this is where they remove 3.5 glands, very similar to your near total thyroidectomy. So I remove 3.5 glands. Where do I put this half gland? So this half gland is what is implanted in the brachioradialis muscle, in the hand, in the arm. Why am I doing that? I'm doing that because it's easier to explore. If ever now the patient has hyper PTH, I know exactly where superficially it is and it can be re-explored again, right? So that is what we are doing. But if by mistake the surgeon removed parathyroid glands during thyroid surgery, now where does he put it back if he realizes then itself? Do I have to put it in brachioradialis? Not really. Why are you giving it in brachioradialis now? The neck is open, put it there itself. So then they place it in the strap muscles. Okay, so this is very important, and this is what students mistake. They just say brachioradialis as a blanket statement. No, agar thyroid surgery hai, neck is open, put it there. Yeah, but where that half gland I may have to re-explore again, brachioradialis. All right, so that is what is important. Then indications of surgery in asymptomatic primary hyperparathyroidism. So this is directly a table from Bailey Love. Never been asked, but I feel this can be tested. So if you have somebody with a parathyroid adenoma, doesn't have symptoms of hypercalcemia, should I operate? Yes, if his calcium is more than 1 mg per dl above normal. So normal range is 8.5 to 10. Yeah, so above that. Osteoporosis is seen on DEXA scan, or there is a vertebral fracture, or it's affecting the kidney now. So the creatinine clearance is decreased, or the age is young, right? Young patient hai, remove it right now. So these are the indications. So they can ask you an all except question. I believe they can put this more than 50. So it's not more than 50, less than 50. All right. So this is about parathyroid. Now, let's talk about men syndromes. Okay, so we've talked about MTC, we've talked about parathyroid. So let's just finish all of these. Multiple endocrine neoplasia syndrome, super important for the exams. So, first of all men are dominant. Yes, alpha male. So, all men are autosomal dominant. So, that's one thing. Earlier, we used to study till men 2B, which was also called men 3. Now, there are two men which are proposed men. They are not real men. Okay, so these are men 4 and 5. So, I'm just telling you for a recent update here itself. Then, men 1, chromosome 1, 11. The gene is menin. This is Mer for men, okay, not Werner. Because what is Werner syndrome? Werner syndrome is progeria. It's a type of progeria, right? Early onset aging. So that's not Werner. Just remember it's Ver, Mer. Men 2A, men 2B are both RET mutations, chromosome 10. Yeah, so RET, TER, 10. That's how you can remember. Men 4 and 5. Now, men 4 is cyclin dependent kinase 1B on chromosome 12. So, that covers 10, 11, and 12. It's a max gene on chromosome 14. So, all of these are, around 10 to 14 range. So, 11, 10, 12, and 14. So, now we talk about what are the manifestations. So, men 1 is 3 P's. What are the 3 P's? So, this is what you will remember. Stay in the midline. Pituitary, parathyroid, pancreas, because you will mix it with few. So that is why remember midline. Okay. So we have a pituitary microadenoma. Most common pituitary microadenoma is prolactinoma. Same here. It is a prolactinoma. Then you have parathyroid adenoma and you have pancreatic neuroendocrine tumor. Let's talk about pancreatic neuroendocrine tumor. Now, overall, in general, not men, the most common pancreatic entity is a non-functional entity. Okay, but if I ask you what is most common functional entity, it is insulinoma. But in men one, it is gastrinoma. Okay, so now gastrinoma is super important. Let's talk about it. The investigation of choice for all neuroendocrine tumors, you can remember, very expected question is a Dotanoc scan. It's a gallium based PET scan. Okay, so it's a Dotanoc PET. This is what assesses the presence of somatostatin receptors, okay, which all of these tumors do have. So this is what is Dotanoc. Do remember this for any neuroendocrine tumor. Okay, so now let's pay attention to gastrinoma. Super important. Gastrin, you know what gastrin does? It is going to lead to a lot of acid production, right? So this is where you have refractory ulcers, gastric ulcers, duodenal ulcers, and this is how the patient presents. And because there is too much gastrin, yeah, can I say that this is where the parietal cells will undergo hypertrophy because they are making too much H+. So this syndrome is called as Zollinger-Ellison syndrome, where the stomach undergoes hypertrophy because of acid production. Okay. Where is this gastrinoma located? So this is located anywhere in this Passaro's triangle. Normally when I say pancreatic entity, you would assume it's in the pancreas, but not gastrinoma. It can be anywhere in the Passaro's triangle. In fact, the most common location is duodenum, second part of duodenum. So what are the boundaries of this triangle? Last year INICET question. This is common hepatic duct, cystic duct junction. Yes, this is the junction between duodenum ka second part and duodenum ka third part. This is head, neck, body. So this is at the junction of neck and body of pancreas. So everything 2-2. Common hepatic duct, cystic duct, D2, D3, neck and body of pancreas. So now, what is the clinical approach? So this is done, Passaro's triangle is done, boundaries are done. Let's say you have a patient with symptoms of Zollinger-Ellison syndrome. The first thing that you will do is measure their gastrin levels. If the gastrin levels are above 1000 picogram per ml, the diagnosis is confirmed. You need not do anything. But if this is not more than 1000, right? It's somewhere around 200 to 1000, but not more than 1000. Then I do my investigation of choice, which is called as secretin stimulation test. Okay, so what is secretin stimulation test? Normally we know when I give secretin, the H plus secretion decreases, but here because there's gastrinoma, it does not get decreased. So this is where despite given secretin, the gastrin levels remain high. So these are two things which make us diagnose a gastrinoma. Okay, so somatostatin scan or Dotanox scan is going to be useful for localization. So don't be confused that ma'am, you've written IOC in two places. This is to diagnose gastrinoma, this is to localize gastrinoma. So they'll mention these words. All right, so this is something very important. Now we go back. So more. Men 1 is done, pituitary, parathyroid, pancreas. Men 2A. So now you skip the first and third one, keep parathyroid. So this is where I have parathyroid. We can have hyperplasia or adenoma both. So hyperplasia more than adenoma. And then there are two things which are here, MTC and FIO, medullary thyroid and FIO. So now parathyroid has come twice. Let's leave it. So now in main 2B or 3, I have MTC and FIO, and along with that we have 4 M's. What are the 4 M's? We can have these mucosal lesions. What are these lesions? This is mucosal neuromas. We can have marfanoid habitus, tall patient. We can have megacolon, okay, and we can have medullated corneal fibers. Okay, so medullated corneal fibers. So these 4 M's, so there are these thickened nerves in the cornea, mucosal neuromas, megacolon, marfanoid. Like never been asked, just remember mucosal neuromas also, you are good to go. Okay, so this is about men 3. The 2 new men who have come into the market, men 4. Men 4, the highlight is GU tumors, alright. So this is where you have genitourinary tumors. Along with that, there are some endocrine tumors, pituitary, parathyroid. First 2, pituitary, parathyroid. Then what about men 5? Men 5 again has multiple P's, so keep pituitary, but now this is the place where pituitary meets FIO. So you have FIO and you have other paragangliomas. Okay, so this is what are the different mens. Now out of all of these, MTC is the one that we are scared of the most. So that is why I want to do prophylactic thyroidectomy in men 2. Men 2A and men 2B. If we know the patient is going to develop, why wait till it comes, right? So that is why we are going to do this. We want our patients to live till 51 years. That's good enough age, 51. So remember, 5 years pay in men 2A, 1 year pay in men 2B, you remove the thyroid, right? So this is all about this page on men syndromes, super important. So now we talk about breast cancer, all right? So here, the screening investigation that we do for breast is mammography. Okay, so in mammography, you want to remember that every female is going to get a mammography annually. So this is annual screening which is done for every female above 40 or 45 years. So some guidelines say 40, some say 45. So 40 is a good, year to remember. Younger you screen, better it is. All right. So annual screening mammography for every female 40 years or above. Now, mammography has radiation, but the radiation cost is around 0.1 to 0.2 centigrades, which is very low compared to the benefit that it offers. So mammography is something which is an investigation, screening investigation with maximum mortality benefit. Okay, so that is important. We have 2 views in mammography. What is this? This is CC view. CC view matlab craniocaudal view, and this is MLO view. MLO view matlab mediolateral oblique. So craniocaudal, mediolateral oblique. So which one do you think shows you more breast tissue? MLO, right? So MLO shows you more breast tissue, mediolateral oblique, and it also shows you the axilla. So it also shows axilla. So remember the 2 views that we take, CC, MLO, craniocaudal, MLO. Like every radiology, this is right, left, this is right, this is left. That's how we read mammograms. Okay. Now, if you look at the mammograms, can you see how white is the glandular tissue and black is the fat? Any cancer, when you see a cancer, what is it gonna become? It is gonna be a glandular. It's an adenocarcinoma, right? So that is what it will be, white like the gland. So that is why I start the screening after 40 years, because younger than 40 years, the female has so much fibroglandular tissue itself that picking up this mass is going to be difficult. So that is why when I have a female who is young, is mammography going to be useful? Not useful before 35 to 40 years at all. So that is why agar koi high risk hai, high risk for breast cancer because of the risk factors, because of a BRCA gene mutation, radiotherapy exposure, these females I'll have to screen them using MRI, not mammography. So I will do their annual MRI starting from 25 years. So this is what we do for screening high risk females. Again, any lump in a young or a lactating female, I don't want to do MRI because it's a any young female, I don't want to really do a mammography. So I start off with ultrasound. So any young female, my investigation of choice is going to be ultrasound, especially in a lactating female, because what are my two considerations? One, it is an abscess, right? A breast abscess. Second, it is galactosele, milk collection. So galactosele or abscess are both, cystic lesions, fluid lesions. And, ultrasound is the best investigation whenever I want to detect solid versus cystic, whenever I want to detect fluid, kala pani, right? So that is what I have to remember here. Just one point on a side note. Whenever I have a breast abscess, how do you want to treat this patient? So whenever you have a breast abscess, the first line is going to be antibiotics. Okay. If antibiotics don't work, my next line is going to be ultrasound guided aspiration. Okay. I will try this at least twice. If this also doesn't work, then I go for incision and drainage. Okay. So antibiotics, aspiration, incision and drainage. Then the quadrant in which we have CA breast most commonly is the upper outer quadrant. Let's do the genes. Most common gene in sporadic and triple negative. It's not BRCA, it's P53. Okay, this is the mistake students do. They think CA breast, they say BRCA, but in sporadic, it's P53. Most common gene in familial breast cancer is BRCA now. Which BRCA? BRCA1. So BRCA1 is linked with breast and ovarian cancers. These cancers tend to be more aggressive, all right, and they also turn out to be triple negative. But most common mutation in triple negative remains P53. So that's why I've written this separately. Okay, so P53 triple negative, but even BRCA associated cancers are triple negative aggressive cancers. Then you have CA breast in men. Very important question. Prostate, pancreas. So three cancers: prostate, pancreas, CA breast in men are BRCA2 related cancers. Okay, let's do the chromosomes. BRCA1 is chromosome 17. BRCA2 is chromosome 13. That also reminds us of something. What else is on 17? P53. Who is brother of P53? RB. So both of these, bigger brothers on 17, smaller brothers on 13. While we are thinking of this, NF1 is also on 17. And one more on 13 is ATP7B. Wilson's. So this is how you can actually remember 6 chromosomes without doing anything. Okay, so 17, 13. Then investigation of choice for breast implants is going to be MRI. All right. So look at this. This is breast implant. World War II, water is white on T2. Breast implants made up of silicone, right? So you can see how they appear white, and you can see this. Can you see something like a noodle? This is called linguine. Linguine is a type of pasta. So this is called as linguine sign, and it is indicative of intracapsular breast implant rupture. So this is intracapsular rupture, where this capsule is rupturing as noodles inside the implant. So this is one question which has not been asked so far. This is give party to ma'am kind of question. Okay. So this is done. Investigation of choice for post-op scar versus recurrence, again MR. Once there is a post-op, scar. Now mammography is not very useful because both of these will have speculated margins, even cancer and scar. So that's why I have to see enhancement, and that's what I can see on MRI. So if I can see enhancement, it's recurrence. Then most sensitive for ductal carcinoma, also MRI, but most sensitive for microcalcifications. See, MRI has the best contrast resolution. That is why it can pick up DCIS. But it can never pick up calcium, and that is why mammography can never be replaced, because mammography shows us microcalcifications. Cancers have two typical features. Let's see that first. There are two features. When I see that, I know it's cancer on a mammogram. One is a mass with what kind of margins? I said that earlier, spiculated margins. So a mass with spiculated margins, or what are these chota chota calcifications? This is what is clustered microcalcifications. So whenever I see clustered microcalcification or a spiculated mass, I am very sure it's cancer. We'll talk about BI-RADS in a bit, right? So this is what is the strength of mammography, to show microcal, and this is why it can never be replaced, right? Then there are three prognostic indices for breast. Before that, I just want you to see this. I have highlighted the lymph node. So the most important prognostic factor is lymph node. Thyroid mein kya tha? Age, right? Then what are these three indices? First one is a pathological index called as Bloom-Richardson index. So this is what incorporates mitosis, tubule formation, atypia. Completely pathological. Then more clinical, GAMS. This is Van News grading. Okay, so Van News grading predicts, what is the risk of recurrence in ductal carcinoma in situ. Okay, so recurrence in ductal carcinoma in situ, and that helps us plan management, grade, age, margin, size. Then this is overall a prognostic index called Nottingham's index. So this is lymph node, grade and size, like very general. Okay, so this is Nottingham, not important. Okay, then let's talk about risk factors. So what are the risk factors for CA breast? Look at these three and tell me what is the relation with estrogen. Can I say higher the estrogen exposure, more is the risk of CA breast? Yes, so nulliparity, more menstrual cycles, early menarche, late menopause. So this is what is the risk of CA breast. More the menstrual cycles, meaning more the estrogen exposure, more is the fibroglandular proliferation, more is the risk of CA breast. Occipitals now. Previously, it was considered that occipitals are a risk factor. Now, that's debatable. One thing is for sure, it is not protective. So, whether it is a risk factor or not, we don't know. But it is definitely not protective. Yeah. Smoking is a risk factor for CA breast. It is. Yeah. So, smoking is a risk factor for CA breast. And this was a question. It's a risk factor for all except. So, it's a risk factor for duct ectasia as well. Mondor's and Zuska's disease. The fourth option was fibroadenoma. So, not a risk factor for fibroadenoma. Okay. What is Mondor's disease? So, this is where the chest wall veins undergo thrombophlebitis. They become cord-like. So, this is chest wall thrombophlebitis. Zuska is a periductal mastitis. So, it's a type of idiopathic mastitis which is also linked with smoking. Right? So, this is about a few of the risk factors. The scary looking table here is something which is from Bailey Love, and I feel this can be tested. What are the indications of genetic testing, right? When should you offer genetic testing to a patient who has CA breast? If her cancer was diagnosed early, if triple negative was diagnosed before 60 years, any BRCA1 or 2 mutation in a blood relative, any breast cancer in one or more relatives who have either been diagnosed early or have BRCA associated cancer. Same thing, right? So, any family who has BRCA or young cancers. 2 or more affected relatives, right? If you have with breast cancer, you should get tested. Any male breast cancer must get tested. Suspected leaf-from-Annie, that's linked with CA breast. Cowden, which is your P10 mutation. So, leaf-from-Annie, is P53. Cowden is P10. We have studied BET, breast, endometrium, thyroid. E-cadherin. What is E-cadherin mutation going to lead to? So, E-cadherin is going to lead to lobular CA breast, and we will study in a bit diffuse type of gastric cancer. So, this is the one where you have signet ring appearance. So, lobular CA breast and diffuse gastric cancer. Peutz-Jeghers has breast cancer. That's also last year's question. So Peutz-Jeghers linked with breast cancer as well, right? So this is what we have to remember. So essentially the takeaway is anybody with less than 50 years CA breast, TNBC 60, any family history of BRCA related cancers or syndromic associations, right? So this is a factual page of CA breast, like pretty heavy in facts, but just get this done with. Now we talk about BIRADS. So as we discussed with TIRADS, is an objective scale that we have. Okay, so triple assessment, you must be knowing very basic. We do three things, right? First, you will have to do clinical examination. Then you will do radiological examination, and then you will do pathological examination. And this, if you do all three, you have 99.9% accuracy of diagnosing. Like what is left? Okay, still if you're missing that 0.01, that's something which is shocking. So this is what is triple assessment. What is BIRADS? As we discussed, breast imaging, reporting and data system, right? So you don't have to write that, you know that. So this is what is the scale. Here we will study this in a little bit more detail. The modalities in which I can give a BIRADS score is ultrasound, mammography and MRI. We never do a CT scan for breast, remember. All three other investigations I give a independent BIRADS score. What is the scoring like? As we said, 1 is normal. Before that, you can also remember 0 always means it's an incomplete assessment. Kya karna hai? Complete it, right? Whatever was incomplete, complete it. 1 is normal, continue screening. 2 is benign, continue screening. 0% risk of malignancy. 3 is probably benign. So this is where I'm not very sure of what is going on. There is just less than 2% risk of malignancy. So what can I do? It's too low to biopsy. So I just follow up the patients 6 months later. 4 and 5, this is a big one, 2 to 95. This is more than 95. I definitely go ahead with a biopsy. So the BIRADS 5 score, where I have more than 95% risk of malignancy, is usually on these two. Either I see micro calcifications or I see a speculated mass. Otherwise, I give a BIRADS 4. Fine. And if it is already biopsy proven, you just continue the management as planned. We give a score of BIRADS 6. Okay, so this is about BIRADS. The biopsy that we do is usually with this 14 gauge core biopsy needle. So as I said, in an FNSA, I put a needle and I take out cells. When I do a biopsy, this is like a gun. What we do is we put this inside the breast under ultrasound guidance wherever the mass is. So imagine this is the mass. Okay, so I've put this needle in the mass. I press this plunger. What comes out is this. There is a cylinder that comes out. So this breast tissue in the form of a cylinder, a core is taken out. So I get full tissue. Okay. So we take 2 to 3 samples like that. So this is what is the 14 gauge biopsy needle. Alright, then let's talk about a few more appearances, a few more masses. Right, so look at these images first and then I'll teach you the facts. So this is what is a spotter. Can you see something like a popcorn? So this is what is called as the popcorn sign, and this is what is a sign of fibroadenoma, and not just a simple fibroadenoma. This is what is an involuting fibroadenoma because it is showing calcification. So this is what is a completely benign pathology. This is where I give a score of BIRADS 2. I'm sure that this is benign. I don't want to do anything for this patient, right? So this is popcorn sign fibroadenoma. Then look at this. So here, just one more point. If the fibroadenoma is non-calcified, then I will give a score of BIRADS 3. Okay, so a score of 3 can be given if it is non-calcified. It's just a well-defined lesion, breast mouse. That's how they will describe it, right? That it's a very, very mobile, well-defined mass. So I have just less than 2% risk that, okay, is it an atypical malignancy? So I give a scope of, error, and I give BIRADS 3 so that I can follow it up. But if it is showing calcification, 2. ठीक है. Then look at this. The histopath is characteristic like a leaf. This is a mass which grows to large sizes, and you can see there are some black areas within, and that is what is suggestive of cystic spaces. So ultrasound shows large mass, cystic spaces. Pathology shows me this leaf like stroma. Leaf matlab phylloid. So this is phylloidous tumor. Okay, it has one good thing, one bad thing. The good thing is that it does not metastasize to lymph nodes. Means I don't really need to do axillary dissection here. The bad part is it recurs a lot, very high chance. Means I can't just do a wide local excision. So that is why the management here is a simple mastectomy. Do you agree that if I just remove the breast parenchyma, it will not recur? I don't need to do MRM because there are no lymph nodes, right? So this is what is phylloid tumor. This is another tumor which is looking like there is a breast within a breast, same tissue as the breast. So this is called as a breast within breast appearance, and this is what is seen in a hematoma, breast hematoma. Okay, so this is about 3 benign lesions and their appearances. Now let's correlate fur and fur, fibroadenoma and phylloids, and for that matter even fibroid of uterus. All three of these are united by a mutation called as MED12 mutation, and both fibroadenoma and phylloids arise from the intralobular stroma in the breast. So that's just something unique, so you can remember this together, never been asked. Then two things I want to talk about. HIFU. HIFU is high intensity focused ultrasound. So this is what is a new technique. Using ultrasound, I can, treat two lesions which are both here, fibroid of the uterus and fibroadenoma. So HIFU is a technique that I can use to ablate both of these fibrous lesions. Recent update, VAB. VAB is vacuum associated biopsy. So this is almost like an excisional biopsy, but without really giving an excision or an incision. So this is where I put a scope, and using vacuum we can actually suck out that complete fibroadenoma. Okay, so this is what is vacuum associated biopsy, which can be done for suspicious fibroadenomas. I'm not really sure. Let me just remove that complete thing using vacuum. So that is a method we use for fibroadenomas if there are multiple or there are suspicious fibroadenomas. So this is a minimally invasive counterpart of excisional biopsy, where you remove the complete lesion and just see what it was, right? So that's vacuum associated biopsy, useful for fibroadenoma. Then let's talk about approach to nipple discharge. You have to see how it is. Unilateral hai, blood hai, and multiple ducts hai. That's a red flag right there. This is where we have to rule out CA breast. Unilateral or bilateral, bloody, but now coming from single duct. When it comes from single duct, it is a good prognosis because this is likely to be an intraductal papilloma. Right? So intraductal papilloma. Before that, I want to tell you that CA breast, the unit that it arises from is called as terminal ductal lobular unit. So because there are multiple ducts involved in that terminal ductal lobular unit, it will be from multiple ducts, whereas this is within one duct. So I'm just going to write that terminal ductal lobular unit. Okay. Then, so this is from one duct. Look at this ultrasound. This is one duct, and can you see one mass within that duct? So all I have to do here is remove that duct, and that is called as microdocectomy. This is what students make a mistake. Many times they call this Hadfield procedure. Not this. This is microdocectomy. But when I have multicolor discharge, like they say green discharge, yellow discharge from a single duct, this is where the duct is dilated. This is duct ectasia, ectatic duct hai, dilated duct hai, and here I'll have to remove this complete cone. So this is what is Hadfield procedure, where you remove this complete cone out. Okay, so this is approach to nipple discharge. Then we talk about granulomatous mastitis. Unless mentioned otherwise, it is TB. So if they say the patient has fever, think of TB. But if they say patient has no fever, no other signs of tuberculosis anywhere, then the cause can be this Corynebacterium cropin steady. Which exam do you think would have asked this? So this was a question on INICT just this year, May 2025. So this is Corynebacterium croppenstedi, which was the case was given as granulomatous mastitis without fever, without signs of TB. So the answer was this bacteria. All right. So such questions, I mean, you obviously will not know, but you can at least rule out and reach the answer. So the answer a lot of times would be something which you've never heard of, and that's a possibility, and you should be having the courage to mark that answer. So that's the skill we have to develop, is to have the courage to back your instinct when you have ruled out other options, right? So that's something which we will learn as we go along. Then we talk about staging. Every exam since I've started teaching literally has gotten a question on staging of CA breast, and every time different question. Very good question, very scoring question. So let's do everything here. T1. So T1, T2, T3 is based on size. Less than 2, 2 to 5, more than 5. Okay. Even in T, there are 3 different parts. That's it. That's your choice. If you want to see 5 mm, 5 to 10, more than 10. So less than 2, 2 to 5, more than 5 centimeter. This is T1, T2, T3. Now, before we go to T1, there is TIS, carcinoma in situ. Carcinoma in situ in breast includes ductal carcinoma in situ, and it includes Paget's disease of breast. It does not include lobular carcinoma in situ. It has now been removed. Okay, so it's not carcinoma in situ. Paget's disease of breast is where the patient will complain of itching. It looks like eczema, right? How is it different from eczema? Eczema is going to be bilateral, right? There's going to be much more itching. Whereas in Paget's, there won't be a lot of itching and it would be unilateral. Okay. So that's how you can distinguish. You will have to do a biopsy, and this usually represents an underlying ductal carcinoma in situ, and you will see these enlarged cells which are called as pagetoid cells. Okay, so this is carcinoma in situ. Then we talk about T4 staging. So T4A is chest wall involvement, all right? So what do we include in chest wall involvement? So here we include the intercostal muscles, the ribs, and serratus. Or you can remember better what is not included. So pectoralis muscle, not included. Both major and minor, not included. Meaning, if there is a breast mass involving pectoralis, you will not upstage it to T4A. उसको size के हिसाब से stage करेंगे. We'll stage it according to the size. Okay, that's one thing. T4B is skin involvement. This is the most commonly asked question. What is included in skin involvement is pus. What is pus? Very, very important. So this is pure orange. Okay, orange like appearance of the breast. And why does this happen? It happens because of involvement of superficial subdermal lymphatics. Okay, so that means it's going down into the skin. So pure orange, this is the spitting that happens, subdermal lymphatics. U for ulceration. So any ulceration is upstaged as skin involvement and presence of satellite nodules. So pus is included in skin involvement, pure orange, ulceration, satellite nodules. What is not included is even more important. So what will you not upstage to skin involvement? 1. What are you seeing here? Can you see how it looks like the skin is dimpling down? You will think that, okay, skin is involved, but it's not skin. It's the underlying ligament of Cooper which are tethering and pulling the skin inwards. So this is not skin involvement. So this is called as dimpling, also called as puckering of the skin. And this represents the underlying involvement of ligament of Cooper. And this has been asked many a times, okay? Or you can see here there is nipple retraction. The nipple retraction, again, you must think it's skin, but it's not skin. It's the underlying lactiferous ducts which are involved. So both of these things we will not include in skin involvement. Super important. Then T4C is both skin involvement and chest wall involvement. Then comes the worst prognosis. So T4D has the absolute worst prognosis. This is where you can see this red skin like it's inflamed. So this is what is the inflammatory CA breast. For inflammatory CA breast, we need at least 1/3 of the skin to have lymphovascular space invasion. So at least 1/3 of the skin must look red and inflamed. So this is called as inflammatory CA breast. Just a side note, if they mention that more than 1/3 of the skin shows pure orange, even that can be called as T4D. But just if they show you image, you don't see whether it's 1/3 or not. Then you say it's skin involvement. But if they write categorically that more than 1/3 of the breast skin shows pure orange, that means they're leading you towards inflammatory. Then you call it inflammatory CA breast. Okay, so this is what we need to know from the T staging. Now we go to the N staging. Before I go to the N staging, you have to know the classification of axillary lymph nodes. So we have level 1, 2, 3. Here I remember LPM. Okay. This is with respect to pectoralis minor muscle. This is lateral to P minor, this is posterior to P minor, and this is medial to P minor. So just imagine the pectoralis, usse lateral, usse posterior, usse medial, right? So this is LPM, level 1, 2, 3. Okay, level 1. So this is what is the surgical classification. There's also an anatomical classification. So let's merge the two. So level 1 includes 3 groups. APL. Okay, so you can remember APL or you can remember IPL and make it APL. Okay, so this is anterior group, posterior group, lateral group. Okay, so APL, IPL group, level 1. Okay, so that fits also, na? IPL. Okay, anterior, posterior, lateral. Level 2 is what includes the central group of lymph nodes, and most important, what are rotor lymph nodes? Rotor lymph nodes are interpectoral lymph nodes between P minor and P major. So even the rotor group of lymph nodes come in level 2, and level 3 is the apex. So this is what is the apical group of lymph nodes. Fine. So one more time, 1, 2, 3 LPM. 1 में क्या था? IPL we made it as APL. 2 was central interpectoral, 3 was apical. So this is about the lymph nodal classification. Now let's do the staging. So N1 is free axillary lymph nodes. Here what am I counting as axillary? Level 1 and level 2 lymph nodes. Okay, so when I say N1, it's level 1 and 2. So these are freely mobile axillary lymph nodes. N2 those have become fixed. N2B, whenever I write B, it is internal mammary group of lymph nodes, okay? So these are internal mammary only, N2B. So N3B, B matlab internal mammary would be there. So N3B is axillary also plus internal mammary also. Okay? So whenever I see B, I think internal mammary must be there, okay? So that's there. Then N3A, vowels stick together. So A is infraclavicular. This is where I include my level 3, apical lymph node. Infraclavicular. So is Sa. N3C is supraclavicular. Alright. So now, if I tell you that there's a patient who has pure orange, who has contralateral supraclavicular lymph node, can you tell me the stage? So it'll be like, sure, ma'am. This must be skin involvement, so T4B. Supraclavicular, so must be N3C. Wrong. The moment there is contralateral lymph nodes, it becomes N1. So the staging will be T4B, N0. No ipsilateral node. M1. So the learning point is the moment it becomes contralateral lymph node, it becomes metastatic. So N stage is for ipsilateral lymph node, right? The most common distant metastasis in CA breast is bone, where you have lytic more than blastic, but this is one cancer which has both lytic and blastic, and you know they spread via the Bateson's plexus. Okay, so vascular venous plexus, Bateson's plexus, they reach the spine. Okay, so bone, spine is the most common site. Fine. Then there are some prefixes that we use for staging. So C is clinical stage, P is pathological stage, R is not radiological. Radiological comes under clinical itself. This is recurrent masses. This was asked, why is neoadjuvant? So you have given neoadjuvant chemotherapy. M is multiple masses. Multiple masses could be 2. Multifocal means one quadrant multiple. Multicentric, sir is sir. Sir matlab multi-quadrant. That's how I remember sir and cur go together. Multiple quadrants, that's multicentric. A is a staging that's done on autopsy. Alright, so these are the prefixes that we use. As we discussed, lobular carcinoma in situ, right? So lobular carcinoma in situ, because it was E-cadherin mutation, the cells distribute. So this was associated with one E-cadherin mutation. Second, because the cells distribute, this is called as Indian file pattern. And these cancers, because they distribute, tend to be more multifocal, multicentric, right? So they are more likely to be multifocal and multicentric. So this is lobular carcinoma in situ. Okay. So now we talk about molecular classification. Very, very important. So we are integrating path now. It's based on immunohistochemistry. So this is where we are trying to study a few markers, all right? Before that, one thing, which was a question, what is the stain used for immunohistochemistry? So that's called DAB, diaminobenzidine stain. But you will not remember full form. They will remember. You remember DAB. What if there's a stain? You dab on it with a tissue. So DAB. Okay. So that is diaminobenzidine. Okay. So now let's see the markers. So first is ERPR, estrogen and progesterone receptors. So you can see how they are nuclear receptors. You know, in endocrine also we have studied that the steroids are intranuclear receptors. So these are nuclear markers. You can see that the nuclei is getting stained. So ERPR positivity, this is what is luminal type, and we give a scoring called Allerard scoring. Here there are two. You remember Ki67 is a proliferation index. So if that is less than 14%, we call it low. If it is more than 14%, we call it high. So obviously lower the proliferation index, better is the prognosis. So when it is ERPR positive, HER2 negative, Ki67 low, this is what is luminal A type. But if Ki67 is high and HER2 can be negative or positive, means this could also be the triple positive type. What am I talking about? I am talking about luminal B type. Okay, so luminal A, luminal B, ERPR positive. Luminal A, can I say, is most common, best prognosis, just like papillary thyroid, right? So most common, best prognosis. 3 histopath subtypes come under luminal A. PTM. You know how when we were children, most of us were good students, right? I was a very good student in school at least. So my parent-teacher meetings are always a dream, okay? So that is where my prognosis was always best. I knew that. So PTM. So PTM, what are these? There is papillary, tubular, and M is the one is important, that's mucinous. Because there are 2 more M. Metaplastic and medullary, and we will see they come in the worst subtype. So in triple negative, we will study that I have medullary and metaplastic subtypes which have the worst prognosis. Okay, so medullary, metaplastic. So PTM, papillary, tubular, mucinous. All right, out of these, it is tubular which has best prognosis. So overall, if they ask you which histopath subtype has the best prognosis, it's tubular part. Okay, so that's PTM. Then if I see HER2 positivity, HER2 receptor is now located on the cell surface, right? So this is what is a cell surface receptor. So you can see it's not within the nucleus, it's outside. So if HER2 positivity is there, usually Ki67 is high. Now here, depending on the result, the pathologist can write the immunohistochemistry as 1 plus, 2 plus, 3 plus, and there's also PYQ. If they write it as 1 plus, we consider it negative. If they write it as 3 plus, you consider it positive. If they write it as 2 plus, this is what is the next step was asked. So here the next step is going to be to do FISH. Okay, you will do FISH to see the amplification of HER2. Remember FISH from biochemistry, we check 3 things: MAT, microdeletion, amplification, translocation. So here I want to see amplification. If FISH is positive, I treat it, otherwise I treat it as negative. Okay, so the next step is FISH. So, if I get ER/PR positive or HER2 positive, I have targeted treatment. We will go to it. But if I don't, that automatically gives a bad prognosis because I don't have targeted treatment. So, that is triple negative breast cancer, which has the worst prognosis because there's no targeted treatment. But whoever has worse prognosis will have some glimmer of hope. Here, that happens to be pathological response. So, out of everything, this has the best pathological response, meaning when I give chemotherapy to these patients, they have a very good response. Another thing, they usually happen in younger females, right? So, TNBCs tend to happen in younger females. This is where all three are negative. The cytokeratin markers, the basal keratin markers are positive, EGFR can be positive. So this is where basal keratin receptors become positive. That's what is important. So there are two types. One is called as the basal type, where you will see all of these being positive, and the other one where these are not there is Claudin low. So basal and Claudin low are variants of triple negative, and you can see Ki67 is high. Okay, so these are the three types. Now let's talk about how to treat if one is hormonal receptor positive. The first line treatment for any premenopausal female is going to be tamoxifen. You know, tamoxifen is a SERM. It's going to inhibit the estrogen receptors on the breast. The side effect though is endometrial hyperplasia. It tends to cause cystic endometrial hyperplasia. All right, so that is one side effect apart from DVT, which is a side effect of every SERM, selective estrogen receptor modulator. Postmenopausal female, I use letrozole. What is letrozole? It's an aromatase inhibitor, right? Because it inhibits the estrogen. Testosterone to estrogen conversion it inhibits. There's also going to be bone mineral density decrease. So it leads to osteoporosis. Okay, so in premenopausal, we use tamoxifen. In postmenopausal, we use letrozole, and this is continued for almost 10 years. Okay, so that's for ER/PR positive. But if one is ER/PR positive, meaning hormonal receptor positive, but it's advanced cancer, then I have few more options. So we have these cyclin dependent 4/6 inhibitors which are being used. Mainly we use palbociclib with either letrozole or fulvestrant. Who is fulvestrant? It's a selective estrogen receptor degrader. All right, so these are given, and this is a trial, Paloma 3 trial, which can be asked, where they have tried this combination of palbociclib with letrozole or fulvestrant, and it's shown very good results. Apart from that, other drugs which have been approved are everolimus mTOR inhibitor, which we've also studied in tuberous sclerosis. There is this drug buparlisib, which is PI3 kinase inhibitor, and there is one more sortib, which is AKT inhibitor. So I have no idea how you are going to remember the last two, but you'll figure it out. I know. I can just tell you vowels stick together. Okay, so this is what are your hormonal receptor positive treatment. If one is HER2 new positive, we have a HER2 new blocker. So that is trastuzumab, right? So then the treatment of choice is trastuzumab. It has a side effect of cardiotoxicity. And there's one more question, that if one is resistant to trastuzumab, we can try lapatinib. So that is also a PYQ. Right, so this is as far as the targeted treatment is concerned. What about overall treatment? So now let's talk about a few more points as far as overall CA breast staging and management are concerned. So how we divide CA breast is going to be early and locally advanced. Okay, so LABC. LABC is given stage 3. So this is the AJCC staging which has also been asked. So locally advanced, if we study, I study almost everything else, right? So if I know LABC stage 3, you know everything else. So let's do this first. So what is included in locally aggressive? T3N1 means more than 5 centimeter with lymph node. Any T4, chest wall, skin, both inflammatory, or any N2, N3. So any T3N1, T4, N2, N3 is stage 3. Anything which is not that is early. Yeah. And anything, can I say, which has distant metastasis must be stage 4. So that's how you can actually incorporate the AJCC staging by just this one line. Okay. So How is the management? So when one is locally aggressive breast cancer, I will have to first give a neoadjuvant chemotherapy. After that, we do MRM, modified radical mastectomy, and then you give adjuvant radiotherapy. So we utilize everything to treat these patients. Okay, but if it is early cancer, then what can I do? Now I have two choices. Either we can do breast conservation surgery, or we can do modified radical mastectomy plus minus lymph nodes, right? So lymph nodes will depend. If they're enlarged, we remove. If they're not enlarged, we don't remove. So here I have two options. So now what is breast conservation surgery? So breast conservation surgery means I'm doing a wide local excision with margins, right? And I'm giving adjuvant radiotherapy. That is not optional. Now if I am doing something less here, now this can't be optional, hai na? So wide local excision plus adjuvant radiotherapy. So this was one of the PYQ that in BCS RT is optional. No, it's not optional. Every patient will receive it. Okay. So what are the contraindications to doing breast conservation surgery? Can I say anything where RT is contraindicated? So pregnancy, I can't do. Prior radiotherapy to chest wall, collagen vascular disease radiotherapy will be harmful. Then locally aggressive, obviously. Why lobular? Because lobular tends to be multicentric or multifocal. So that is why if I do breast conservation, there are going to be multiple focals. What is the point? So everything is so logical here, isn't it? So all of these are the contraindications where you would want to go ahead with MRM. Now let's talk about lymph node management. See, here I'm only concerned about early, okay? Because here I'm anyways doing MRM and axillary lymph node dissection will be done here. But when I'm doing breast conservation surgery, lymph node dissection is not always done. It will depend on whether they are there. If they are clinically palpable or FNA proven, you have to dissect it. But if it is not clinically palpable, right? So clinically non-palpable lymph nodes. Now I have to prove that there is no metastasis into the lymph nodes. So that is where this comes in. What am I showing you? Sentinel lymph node biopsy. So this is where you use a dye such as indocyanine green, or you can use technetium, tagged albumin, and you see whether that reaches the sentinel lymph node or not. If it reaches, if the sentinel lymph node is involved, you will do axillary lymph node dissection. So this is for clinically non-palpable lymph node only when you are planning breast conservation surgery. Because do you get it? When I say MRM, it automatically means I'm doing axillary lymph node dissection. So the only role of SLNB is you want to do BCS, clinically non-palpable lymph nodes, right? Any MRM, I'll anyways explore. Any clinically palpable, you anyways explore, right? So that one line will solve everything. Then we talk about mastectomy. So previously we had Halstead's radical mastectomy where you removed everything, but modified radical mastectomy, we are trying to preserve a few things. Okay, so MRM, we give an incision called as Stewart's incision. Just a one-liner. You preserve ABCD structures. What are ABCD structures? Axillary vein, Bell's nerve. What is Bell's nerve? Long thoracic nerve of Bell, which supplies serratus. Cephalic vein and dorsal thoracodorsal nerve. Okay, so thoracodorsal, I've just written it as dorsal. So this is what supplies latissimus dorsi. So just remember ABCD. Most common complication of MRM is seroma formation. Now, in MRM, we don't always remove the P minor. So what are we going to do to P minor? There are three variants, okay? So Auchincloss, Scanlon, Patty. In Auchincloss, you'll remember RIR, okay? So here I just retract the P minor muscle. I don't remove it. Here I just incise it and here I remove. So you can remember what happens in a divorce. You remove your pati. So this is where you're gonna remove pati. Okay. So patty is removed. So just remember RIR, remove patty. Okay. So this is what you do for P minor in these three modifications of MRM. Fine. Then let's talk about this complication of axillary lymph node dissection. This is lymphedema. Okay, so this is just swelling which happens following weeks of axillary lymph node dissection. But if this is left untreated for years, Then you may have lymphangiosarcoma. If you remember, I'd shown you this image in Dermat, okay? And that syndrome is called as Stewart-Treves syndrome. But very, very important, that develops over years, okay? So the immediate complication is lymphedema. For breast reconstruction, we have flaps. So they're given this image-based question. You are removing a flap from the inferior part of epigastric. So this is DAP flap. So the figure shows DAP, which is a flap based around the deep inferior epigastric artery. This is considered to be the best flap for breast reconstruction. TRAP is transversus abdominis muscle flap, which is based around the superior epigastric artery, but this has a side effect of more abdominal wall morbidity, so that is why it's not really preferred. Or we can also use a latissimus dorsi flap, which is based around the thoracodorsal artery, right? Same nerve. So thoracodorsal artery. So these are three flaps that can be used for breast reconstruction. Then last thing, molecular tests. So there are a few molecular tests or PCRs that we do where we are doing a genetic assessment in good prognostic tumors. T1, T2 hai, no lymph nodes, luminal A hai. So this is where we are trying to see, do they have a higher chance of recurrence or not? So we are trying to predict the recurrence or their prognosis using these genetic testings. All right, so this is what we do using PCR. All right, so we assess a PCR and we assess multiple genes. How many gene assays? So there are these different numbers. Oncotype DX is 21 genes. MammaPrint is where you are assessing 70 genes. EndoPredict 12. So 21 ka ulta 12, PAM 50 is 50. So these are where I'm assessing these genes to see whether they need chemotherapy, they have a long-term recurrence risk or not. And CAN assist is what we have made in India. It is not really a genetic assay, it's more immunohistochemistry based, on the markers that we just studied. So that is for India, which is an IHC based risk model. Okay, so these are the molecular testings. So now we'll talk about vascular surgery. So first I'll talk about a few arterial diseases, then we'll talk about venous and lymphatic disorders. All right, so peripheral arterial disease, we divide it into two things. One is an acute occlusion and the second is the more common one, which is chronic peripheral arterial disease, where because of atherosclerosis, you are going to have progressively increasing narrowing of the vessels. So let's start with the more commoner one first, that is chronic occlusion, which we commonly refer to as peripheral arterial disease, right? The most common factor here is going to be atherosclerosis. Okay, so here, how is the patient going to present to you first of all? So you know that there is going to be intermittent claudication initially. That is the hallmark. And intermittent claudication, the predominant finding that you're going to get here is that the patient will say, I start to have pain after walking a fixed distance. In fact, they can tell you in meters also that after walking these many meters, I'll start to have pain. Okay, so that tells you the capacity of the vessels, that the vessels can supply till here, now it's gone, right? So that is what is the hallmark. Now, wherever you have that pain, the vessel can be known through that. So whatever part is paining, you have to assume that the vessel that is narrowed is one segment proximal. Means if there is aortoiliac narrowing, aorta is in the abdomen, abdomen ke niche buttocks. So when aorta is narrowed, the pain is going to be in the buttocks. So this is what we call as buttock claudication. And because there is internal iliac artery also getting narrowed, there is also going to be impotence. And what is this syndrome called? It is called as Lerich syndrome. So Lerich syndrome is buttock claudication with impotence. All right. So that is something which has been tested in the past. Lerich syndrome. Iliac narrowing, when it will happen, the claudication now is going to be in the thighs. When there's femoral artery narrowing, which is running in the thigh, now the pain is going to be in the calf. And you know why? Normally, when I said intermittent claudication, you're thinking calf pain, right? So that is because most common artery that's blocked is femoral artery. Okay, and if there is popliteal artery which is running in the calf narrowing, you're gonna have heel pain or foot pain. Okay, so this is about the pain. The next thing that you're going to do in an OPD is measure the ankle brachial index. I measure the maximum systolic blood pressure of the ankle upon the brachial artery. So brachial artery here is the reference, right? Can I say the lower the reading of ankle systolic blood pressure, more is the narrowing? Yeah, so that is what I am referring to. As the blood decreases, the ABI decreases. So normal ABI is somewhere where both of them are symmetrical, both are normal. Okay, but when it decreases 0.5 to 0.9, that is where I'm going to have intermittent pain, intermittent claudication. As it decreases more, I'm going to have rest pain, right? And once it goes below 0.3, this is what is called as critical limb ischemia, because this is where now the patient is predisposed to gangrene. It's a severe narrowing. Now this is interesting. When the ABI is more, how is it more than brachial artery? So that is something which is also not normal, and that suggests that the vessels are heavily calcified. Something that you see in diabetic patients, something that you see in CKD patients, right? So that is what suggests calcified vessels. There I can do something next, which is TBI, toe brachial index. Now the toe vessels are relatively spared. They're too small to be calcified. So there I can measure toe brachial index to get a better idea of what's going on, right? Now, let's say the ABI that I found is abnormal. Okay, what is the next step? So in any vascular disease, the first investigation is going to be a Doppler ultrasound. I'm going to do an arterial Doppler ultrasound. And you remember from radiology, this is what is the normal peripheral arterial flow. This is what is called as triphasic flow, where I have a systolic peak, diastolic downstroke, and then there is one more because of the elasticity of the vessels. So these are three peaks that I get, which is normal. As the artery becomes narrow, I will start to get biphasic flow and then eventually monophasic flow. And that is something which is abnormal. So we will remember triphasic is normal. So let's say I did the Doppler, it was biphasic or monophasic. What next? So now I want to see what is the part which is narrowed. So I will do a CT angiography next. I give contrast and visualize. So CT angiography best. What is the next step to treat something that is diagnostic and therapeutic? Again would be DSA. I do a digital subtraction angiography. I puncture femoral artery, put contrast, and I see this, that this is the part which is atherosclerotic. I inflate a balloon. This is what is called as balloon angioplasty. So I can either do balloon angioplasty. If it is recurring, I can also put a stent, plus minus stent. Okay, now this is balloon angioplasty or stenting, which is useful when the narrowing is short. Okay, so relatively short segment. The moment it becomes very extensive, for example, let's say complete femoral is something which is blocked, now angioplasty is not going to be of much help. So there I will do a bypass. Then I'll have to take a graft and I'll have to bypass the iliac artery directly to the popliteal artery. Whatever is the narrow segment, I will have to do a bypass. So they will not ask you so many details, but you just want to remember first line, is balloon angioplasty stenting? If not amenable, if very long segment, right? In that case, now I will have to do surgical bypass. So this is what is the treatment and management of peripheral arterial disease. If it is an acute occlusion, usually this is going to be from the heart, right? There is likely going to be history of AFib where there's an embolus which has been showered from the heart and that has landed up in the superficial femoral artery, right? So that's the most common site. The symptoms are going to be the 6 P's, no need to memorize: pain, pulselessness, pallor, paralysis, poikilothermia, paresthesias. Just ignore that. But obviously you can suggest that paralysis is something which is a late sign, right? So these are acute P's that you're gonna get. Here the first thing that you're going to do is a low molecular weight heparin. Just start to anticoagulant so that it doesn't worsen, and then you are going to have to do a surgical or endovascular embolectomy. Okay, so we are going to have to go inside that vessel and take out that clot. Okay, if a surgeon is doing that, they're going to use this catheter called as Fogarty's catheter. So you can imagine this is the vessel, this is the clot. Okay, so using this catheter, first I go through the clot. Now I inflate this balloon. So as I inflate this balloon, now I can tether and pull out the clot. Okay, so this is what we do here. Same thing I can do endovascularly. So that's DSA based. Okay, so this is where we have to act fast. So this is about arterial disease. I have a few more one-liners now. So this is what is the Boyd staging of intermittent claudication. So this has been asked in the past. Grade 1 is when if the patient keeps on walking, the pain gets relieved. That's great. Grade 2 is he continues to walk in pain. It's not relieved, but it's tolerable enough. 3 is where it's severe enough that he has to take rest. This was asked. And 4 is rest pain. So this is Boyd's grading of intermittent claudication. Then what is this condition? This is what is called as cricoid aneurysm. Okay, now cricoid aneurysm is a misnomer. It's not an aneurysm. You know, aneurysm is outpouching. This is not outpouching. This is actually an AV malformation, okay, of superficial temporal artery. What is AV malformation? This is where the artery and vein are connected by the set of dysplastic vessels that we call as nidus. So all of these are these nidus and the veins which are enlarged because too much of arterial flow is coming into them. So this is actually an AV malformation, not an aneurysm. Okay. Another sign of AV fistula, you know, imagine we've made a AV fistula for dialysis. Okay. That's called hemodialysis. Okay. So there, if you compress on the arterial side of AV fistula, if you compress AV fistula, you know, proximal side or the arterial side, the fistula gets blocked, right? What is AV fistula? First of all, it's a direct communication of artery with vein. Unlike AV malformation, there is no nidus. It's a direct communication, okay? Usually formed post-trauma or iatrogenically. So this is where if I compress on the artery, there's no more blood which is going, and that is what results in bradycardia. So as the heart rate decreases, this is called as Nicolandi-Brandman sign. No need to remember. Just remember big name hai, Brahmani, big name. So that is where I'm compressing on the artery, and that's diagnostic of an AV fistula. All right. So this is all about arterial stuff. Now we go to venous stuff. So we have done DVT already, deep venous thrombosis in radio itself. Now we focus on varicose veins here. But one thing we had learned is no matter what the venous disease, my one-stop shop is Doppler ultrasound. That's all that I have to do. No CT, nothing. For venous pathologies, venous Doppler is going to do the trick. Okay. So what do we do in varicose veins? Now, what are varicose veins? So, you know, we have a saphenofemoral junction. I have the great saphenous vein, superficial saphenous vein, both of which drain into the femoral artery and give it the venous supply. What is going to happen if the blood flows opposite? Do you agree these small veins, superficial veins, become dilated? So that is what is varicose veins. So on ultrasound, look at this. This is what is my superficial vein, and you can see it is dilated. So when this superficial vein becomes more than 2 mm, that is what I call as a varicose vein, and you can see it looks like an eye. So this is what we have given the name. As radiologists, we give great names. This is one more example. This is called as an Egyptian eye sign. And this represents the dilatation of the great saphenous vein within the fascia. Okay, so this is the dilatation. I always want to know the cause of that. So we always check this saphenofemoral junction, and you guys know this looks like a Mickey Mouse. Even my 4-year-old daughter can tell you that this is Mickey Mouse sign. So what do you know more? You know more that this is where I know the moment I said you know more, what comes to my mind automatically is Lolo more. Okay, but anyways, so this is where you have saphenofemoral junction, and this is the valve. So normally I want that the blood should flow in this direction from GSV to common femoral vein. If the blood starts to go in opposite direction, that's SFJ incompetence, right? So that is what is incompetent, and that's what I want to see. Remember color Doppler, where I said that if blood is coming towards the probe, this is my probe, this is my probe here. If blood comes towards the probe, it should be red color. If it goes away from the probe, it should be blue color. So can I say that if the color is blue, if it is going away, meaning this direction, that's normal. But if it is red, means it is coming towards GSV, and that is abnormal. That is varicose veins. Alright, so that's how using color Doppler I know towards the probe matlab red color, and that is incompetent valve. Yeah, so that's what I'm checking here. Now let's look at the tests. So we have Tredelenburg, Morrissey and Schwartz. All three of these are clinical tests to check for SFJ incompetence. FIGANS is a test for perforator incompetence, and Pratt and Perthes are for DVT. So they've asked these multiple times, just need to know what each one of them is doing. Now we go to the staging. So we have the CEAP staging, which is C for clinical. That's what we will focus on. E also talks about etiology, whether it is reflux, it's obstruction. A is anatomy, where we talk about what vein is dilated, and P is pathophysiology, right? So this is what we are seeing in CEAP staging. So now we talk about the C part of things. So here, how to remember? C1, one looks like telangiectasias. So one is telangiectasias. 2. How many veins did we have? GSV, SSV. 2 veins? 2. Anywhere I write R, that's recurrent. Then you remember 3 is E. 3 ko ulta karenge E. So 3 is E, edema. 4 is big names. As you keep going down, the name size increases. So 4 is simple. Pigmentation, eczema. Tolerable hai. 4B, big name. Lipodermatosclerosis, atrophy blanche. C for corona. Yeah, so this is all of these changes, venous changes tend to happen around medial malleolus, Gator's area. So this is what is lipodermatosclerosis. So can I say this is what is C4B, lipodermatosclerosis? Look at this, there is this network, a circle. This is corona. 4C. Then you have 5, which is a healed ulcer, 6, which is active ulcer. So active ulcer will look something like this. There will be a constant pus slough material coming out. So that's active ulcer. Alright, so that's how we remember. Let's revise. 1, telangiectasias. 2, varicose veins. 3, edema. 4A, pigmentation eczema. 4B, lipodermatosclerosis, atrophy blanche. 4C, corona, healed, active. Yeah, so this we have done. Now how to treat it? So for SFG incompetence, I'll have to go inside the vein and ablate the entire GSV. If there's no GSV, there's no dilatation. So that's the principle. So what we do is endovenous laser ablation. Interventional radiologists do this. We go inside the vein and we ablate the complete GSV. Or we can do radiofrequency ablation. That's the treatment of choice. We don't do surgical stripping anymore. Previously, there you would open and then strip the vein, but that would lead to nerve injuries. So while stripping GSV, the nerve that's injured is saphenous nerve. So this is where they ask that what part sensation will go. So that's the medial leg sensation which will go. Whereas SSV, the sural nerve gets injured, and that's where the lateral leg sensation goes away. If there is perforator incompetence, what are perforators? So if this is the deep vein and this is the GSV, there are various perforators which connect them. Can I say if they are incompetent, again the blood can go into GSV? So what are the perforators? First of all, so Hunterian, these are just names, never been asked. But just to cover the anatomy. So Hunterian perforator is present in the thigh. Dodd is above knee perforator. Boyd, B for below knee perforator. So 2 4-letter words, knee 4-letter words. So that's how you can figure this out. Cocket is around the medial malleolus, and this is in the heel. Okay, so I think just remember Dodd and Boyd and B is below. That would solve everything. Okay. So this is about the perforators. So now they are incompetent. I don't have to strip the vein and all. It's a minor issue. Let me just under ultrasound guidance go into the perforator and ablate that. So that is what is called as sclerotherapy. So I put this sclerosant which is called as cetrol. Okay. So I take this cetrol compound, mix it with a little bit of air, and that technique of mixing is called as Tessari's technique, and I inject it under ultrasound guidance into the perforator, and the perforator just obliterates. Yeah, problem solved. So this is what is about varicose veins management and treatment. Let's do a few things with lymphedema. So lymphedema, this is what is called as the Brunner's grading has been asked. Pitting edema, non-pitting edema, skin changes. Non-pitting edema is what is called as the Stemmer's sign. Also been asked. Okay. Then we have a procedure which is called as Charles limb reduction procedure. Just remember the name. So this is for refractory cases, right, where there's too much edema, so you are just removing tissues and putting skin grafts. So that's called Charles limb reduction procedure. And then we have something called as congenital lymphedema, and that is called as Milroy's disease. So you can remember, a baby is gonna cry, rota hai. So this is a child who is gonna have lymphedema since birth. It's a genetic disorder. The mutation here is FLT4 gene. Alright, so that's congenital lymphedema. Just remember the name. Then we go on to ulcers. Very, very important, right? Very underrated. So how do we approach different ulcers? As we discussed, first of all, let's finish off venous ulcers first. So you know they are more in the medial area, gaiters area, and they tend to have sloping edges. So we saw the picture, sloping edges, gaiters area. There is a Bisgard's regimen which has been proposed for venous ulcers, which is, you know, just the name is fancy, everything else is very basic. You elevate the limb, you use compression stockings. So all of that you already know. Arterial ulcers are going to be present at tip of toes, lateral malleolus, and there'll be thin, shiny skin because of arterial insufficiency. So that's arterial ulcer. The buzzword for pressure ulcers or bed sore is going to be what? It's more common in the ischium, followed by greater trochanter, sacrum, heel. So that's the order. It requires a pressure around 30 mm or more. Alright, where else did we study this? We also studied this pressure in compartments. You can remember compartment pressure more than 30, pressure sore more than 30. Yeah, so this is where you have this staging. There are 4 grades, and you can remember this exactly like burns. What was burns? Epidermis, grade 1, just erythema. Grade 2, partial dermis. Grade 3, full dermis, and then muscle and bone. So it's exactly the same grading: erythema, partial, full, and bone exposed. Right? So what to do for pressure ulcer? This is where you want too hourly position change. So you advise the patient too hourly position change, right? So this is usually in bedridden patients. Plantar aspect of foot, loss of sensation diya hai. So this is what is your trophic ulcer, also called as neuropathic ulcer. So trophic or neuropathic ulcer, this will be present at the plantar aspect. You may have history of diabetes commonly. You may have history of leprosy commonly, right? So these are a few neuropathy changes that they would give you, and there will be loss of sensation. Here they ask you what to do next. That's a PYQ. So you have to see that if it is a clean base, right, all I can do is just advise patient foot care. Nothing to do right now. But if the patient has infected wound, right, if you can see inflammation, in that case we would have to do debridement and give antibiotics. So if it is exactly like this, the base is clean, all you have to do is advise foot care, give them comfortable rubber slippers. That's also part of leprosy program, right? So that is what you have to do here. Very, very important. If they give you history of a post-burn scar, an ulcer which is growing on an inflammatory wound, what is that? Very important. This is called as Marjolin's ulcer, right? So Marjolin's ulcer is actually a squamous cell carcinoma which is happening on the background of a chronic wound, and this is what it looks like. So this is a spotter. This is what is Marjolin's ulcer. Something that we can do to treat these ulcers or any, wound for that matter is vacuum assisted dressing, something that they love to ask, especially in INICT. There have been 2-3 questions from this alone. So vacuum assisted dressing is where this number has been asked. We use a pressure of minus 125 mm Hg, and you want to remember that this is going to accelerate the wound healing, and they had asked a multiple correct option, and surprisingly it also decreases the bacterial load. That is a true statement according to Bailey Love, directly taken from Bailey Love. So this is vacuum assisted dressing. Figure has been asked, pressure has been asked, advantages have been asked. Okay. This is a extra edge question. If this comes, I will take party. So this is where you see one-sided limb hypertrophy. Okay, then you see that there is a lot of veins, right? There are varicose veins, and there is this aberrant lateral marginal vein. There is a vein which is extra, doesn't happen in all people. So what is this syndrome where you have multiple venous malformations? You may have AV malformations, limb hypertrophy, lateral marginal vein. This is called as Klippel, not Klippel field, that was ortho. Klippel Trenoni syndrome. Okay, so Klippel Trenoni syndrome. Just remember Klippel, not Feel syndrome. Klippel Feel or short neck wala syndrome in ortho we'll study. Okay, so this is about ulcers and vascular stuff. On similar lines, now let's talk about wound healing and skin grafts. Again, very underrated but very important. So, what is the timeline for wound healing? So, 10% of the wound healing happens in around 1 week. 80% wound healing happens in around 3 months. 100% healing? Never. So, you can think of this like a breakup. 10% healing happens in 1 week, right? You are ready to tell people in 1 week's time that we've broken up. 80% healing by 3 months, you're ready to move on in life. 100%? Never, right? So just like a breakup, same change happens in collagen also. So initially we have collagen 3. You have dreams, hum do hamare ek collagen 3. And then you are one alone. So same happens with collagen 3 to collagen 1. So that's what we study. Early wound repair 3, late wound repair collagen 1. Eventually, this ratio of collagen 1 to 3 becomes 4:1. All right, and that is what is the normal ratio. Okay, so the normal ratio is 1:3 ka 4:1. Right, so 4 times higher. 1 is not 1. That's how you can remember. Okay, then this was also a repeat question. Intention of wound healing. So basically, what is a primary intention? Healing by primary intention. It means that you closed it. So as soon as there was, let's say, a cut, I sutured it, right? So closed immediately, most likely using sutures or staplers or whatever. So it was closed immediately. Secondary wound healing is it was left open and it healed on its own through granulation tissue epithelialization. Tertiary is left open initially and then it was sutured or closed. So this is the one that was asked. Okay, so open initially and then closed. What kind of wounds would you do this to? Yes, so this is where a wound is contaminated or infected. So you don't want to, suture it that time. You let the contamination and infection clear and then you suture it. So that's healing by tertiary intention. Then we talk about two abnormally healing wounds where too much collagen has come. So the first one is hypertrophic scar. Can you see the hallmark here? The hallmark is that the collagen is excessive. But where is it? It is along the margins, right? It never grows away from the margin. So it remains along the margins of the original wound. So hypertrophic scar, as the name suggests, is just too much collagen. It is normally arranged. So collagen is more in amount, but the arrangement of the collagen is normal. All right. So what do you do here? You can just wait and watch and you can apply some dressings like a silicone dressing. On the other hand, look at this. This is where there is too much collagen, yes, but the collagen is arranged very haphazardly, and that is what we call as the helter-skelter arrangement, something that we have also learnt in HOCM, right? Helter-skelter arrangement of myocardium. So this is where that is happening, and what's the diagnosis? Yes, this is a keloid formation. Hypertrophic scar is something that forms in the first 4 to 6 weeks, but a keloid is something that always forms after 3 months. It can come, in years' time also. This is what is, more common in Africans, so it does have a racial predisposition, right? And we cannot just leave this alone. What do you have to do here for the treatment? You will have to put intralesional steroids. So intralesional triamcinolone is the treatment of choice, and this has been asked like so many times. All right, so this is something which is important, and keloid also as a genetic basis to it. It is actually inherited in an autosomal dominant fashion. So many questions come from keloid at least, right? And the difference between the two. Now we go into graft versus flaps. First of all, what is a graft? A graft is where I'm not giving vascularity. A flap is where we are giving a piece of skin plus minus muscle along with a vascular pedicle. So I have two kinds of grafts. Split thickness skin graft, where all we are giving is partial dermis, and we have full thickness where we are giving complete dermis. Yeah, splitter, also called as thierche, fuller, also called as wolf. Okay, so part is basically epidermis plus partial dermis, whereas this is epidermis plus complete dermis. Site from which we take split thickness is commonly the thigh. So we can harvest large parts through it, and we also make it undergo meshing so that you get more surface area. Full or wolf is usually taken from sites where a little bit of wrinkling from the donor site is normal. So we take it from supraclavicular aspect. You can take it from behind the ear. So that is the site of donor grafts. Contracture. This is the one question that they only ask. Sir is sir. Split thickness graft undergoes secondary contracture. It will contract slowly, as it undergoes fibrosis. Full thickness undergoes primary contracture, means it has the myofibroblast within the graft. So if it has to contract, it will contract immediately. So that's primary. Cosmesis obviously is better in full thickness graft because there's complete dermis, right? So that is about the two grafts. This knife is Humbee's knife, and this is what is used to harvest a split thickness skin graft. This has also been asked, what are the stages of graft take? Basically, graft take means when the graft takes onto the recipient site, it is absorbed and taken up by the recipient site, it's accepted, right? So for the first 48 hours, it derives its nutrients through imbibition. There is no vascular connection, it's just absorbing, imbibing. How you are imbibing knowledge right now, imbibition. 48 to 72 hours was the NEET 24 question, where now we have inosculation. So inosculation means now the vascular connections are forming, and after 72 hours is where you have revascularization or neovascularization begins. One of the contraindications of graft is beta hemolytic strep, okay, because beta hemolytic strep, that is S. pyogenes, can make hyaluronidase, and that does not allow the graft, to get taken. Okay, so that's a contraindication. A little bit about cleft lip and cleft palate, like very controversial numbers, but this is the consensus. So cleft lip alone, you can operate at 5 months. They had asked what's the earliest. So the earliest it can be operated is 3 months. Okay, the procedure is called Millard. Cleft palate, if it is soft palate, you can operate it at 6 months. Hard will be operated around 15 to 18 months. So can I say that one procedure, if somebody has everything, I can repair cleft lip and soft palate at 5 months and hard palate at 15. So that's the 2-stage procedure. Rule of 10 is Millard's rule of 10. Again, same Millard as cleft lip. He said that to operate a cleft lip, there are 3 things which must be fulfilled. Hemoglobin must be more than 10. Then the child must be more than 10 weeks old. So that also, tells us that 3 months must be there. And the weight of the child should be more than 10 pounds. Okay. So this is what is Millard's rule of 10 here. Then we go into flaps. So as I suggested, flaps are where we are bringing a vascular pedicle along. Okay. Now there are various flaps. So what I've done is I've gathered like the most important images from Bailey Love, from PYQs, whatever I feel can be tested. So, they can give you one of these images and they can ask you what's going on. Okay. So first let's look at all the head and neck flaps. A lot of these are head and neck. So this one is used for lip reconstruction. Let's say there is a lip mass. So I remove this part and I harvest this flap from here and I rotate it onto this part. So this is what is Abbey Estlander flap. Okay, very potential question. If there is a larger area of lip resection, pura nikalna hai, in that case we use this big flap. Naam bhi big hai, Carapanzic flap. Don't even bother, big name. Okay, something that sounds like Karan is all we can remember. Then you have this flap of eyelid. This is from Bailey Love, which is a bipedical flap. So it is like a bucket handle, bipedicle. You are taking it and pushing it down, bipedicle flap. Then two more for head and neck reconstruction. So this one is P major, pectoralis major myocutaneous flap, also called as PMMC flap, where you've harvested a flap from pectoralis major used for head and neck reconstruction. This is called as DPFC. Deltoid has been harvested, pectoralis has been harvested, right? So deltopectoral fasciocutaneous flap. So this is what is not myocutaneous, fasciocutaneous, more superficial. So both of these are for head and neck reconstructions. Okay. Then look at this for head and neck. This is where we are creating a bilobed flap. This is what is called as a bilobed. You are creating a figure of 3. So let's say this is the part I want to excise. So, I create a 3 around it and move the tissue. So this is bilobed flap. Then let's talk about two methods here. This one is where, let's say there was an amputated digit. How do I close this skin here? So I take a V cut here and I suture it. So I take a V, push the skin here and seal it. So can I say I have done a V to Y procedure? So initially it was a V cut and now I have made a Y around it. Pulled the skin to cover it, right? You can almost imagine what they have done. So this is V to Y. On the other hand, what is this? This is the one where I have given, let's say there is a scar here, which is a contracture. Okay, so what am I doing here? I have made Y cuts here and converted into V. So that's the opposite, Y to V. Don't memorize, just see an answer, right? So this is Y to V, and this is again one more contracture that we want to release. I'm giving a Z plasty. So this was asked last year. So Z plasty and Y to V, both are techniques for release of contractures. Okay, so this is release of contractures. Then we have flaps for pilonidal sinus. So that brings us to pilonidal sinus. Let's cover this topic only right here, right now. So this is where the history will mention somebody who has a lot of hair on their back and their profession involves sitting for a long time. Okay, and this is something. So if this is the natal cleft, this is going to be above the natal cleft. So what happens here essentially is that hair gets trapped. There is a sinus tract basically deep into the skin, and there is a fluid collection with hair trapped inside. So what the surgeon has to do is remove this complete tract here. So this is the kind of wound which has happened, and then we basically take a flap and we rotate it here. So this shape, this image has been asked. This is what is called as a rhomboid flap, and this technique is also called as transposition flap. So if you have to choose one, you choose rhomboid flap. The names of this flap you can remember as Kim Kardashian is basking in the sun in her limo. Everything else examiner will remember. Kim Kardashian basking in the sun in her limo. Okay, so this is pilonidal sinus. This has nothing to do with a flap, but this image was asked. This is what is called as dog ear. So whenever you are taking, suture, sometimes this extra skin is found. What do I do with it? So this technique of, dealing with this extra bit of skin is called as dog ear. All right. So it's not a flap. It's just a suturing error that results. So now we talk about mediastinal masses, right? A bit about thoracic surgery here. So this is a question that they ask, very routinely. So let's talk about this. So this is CT, right? So you can see on CT, there is a mass here in the interior mediastinum in both of these images. Both of these were asked in NEET 24. Okay. So this is the first one, which is the most common anterior mediastinal mass. What is this mass? So this is a thymoma. All right. So thymoma is the most common anterior mediastinal mass. It's just a soft tissue mass with nothing specific. But this is the one which has very specific appearance. So can you see how there is this black area here, which is just like the fat, right? So there is presence of subcutaneous fat. They had mentioned in the exam that there is -10 to -100 HU. Fat has a negative Hounsfield unit. In radio, we have studied this. And there is calcification. So when there is a mass which has fat and calcification within it, this is a teratoma. So you have a mature your teratoma. Just like in the ovary, this is in the mediastinum. Okay, so there are 4 anterior mediastinal masses usually. We call it 4 T's. Teratoma, thymoma, retrosternal extension of goiter, so thyroid, and fourth is actually lymphoma, but we had to do 4 T's, so we called it terrible lymphoma. Okay, so these are the 4 T's, technically 3 T's and lymphoma, which are anterior mediastinal masses, out of which most common is thymoma. 2-3 points about thymoma now I want to tell you. First, the staging that we use is called as Masaoka-Koga staging. That's just the invasion, degree of invasion. Then it has 3 paraneoplastic syndromes, 2 of which have been asked very commonly. The first one is myasthenia gravis. It can lead to myasthenia gravis. Very, very important. So we must always image the chest of a patient who has myasthenia gravis. If they have thymic enlargement, we will reject it. Then pure red cell aplasia. This was asked 2 years back in AIMS. And third, will most likely never be asked because very rare, is Good syndrome, also called as hypogammaglobulinemia. Okay, so these are the paraneoplastic syndromes associated with a thymoma. So that's about thymoma, teratoma. The most common mediastinal mass in children. One is it's the most common mediastinal mass in a child, and second, it is the most common posterior mediastinal mass. What comprises of the posterior mediastinum is the spinal canal, right? So when there is this lesion which is going inside the spinal canal. So can you see, get the orientation here? So we are at the posterior mediastinum. This here is the vertebrae, okay? And this is the posterior element. This is the spinal cord. Here is a mass which is entering the neural foramina like a dumbbell. Okay, so this is a neural foraminal tumor. It's a neural tumor, neurogenic tumor. So this is what is the dumbbell orientation of a neurogenic tumor, which could be a neurofibroma or a schwannoma. Both of them can come. So neurogenic tumor happens to be the most common posterior mediastinal mass. And obviously anything nerve. Do you remember what's the investigation of choice? MRI. So for anterior mediastinal mass, I am going to do CECT. But for posterior mediastinal mass, because I want to suspect a neurogenic tumor, I am going to do an MRI. Then this is thoracoscore. So they had asked all our components except. I would rather remember except here, yeah. So complication of surgery, not a part of it. Don't see the others. You won't remember anyways. Okay. Then we go into urology. So now we have finished small bits. Now major chunks left. So we have uro, we have GI, we have hepatobiliary, and then transplant to close it off. All right. So that's the order that we're going to do now. Almost 1/3 of surgery remaining. All right. So let's begin. So when we talk about stones, we need to assess the crystals in the urine, right? So this is a path, uro, correlation. So this is the first one, which is rhomboid shaped crystal. So rhomboid shaped crystal is what we are going to see in uric acid, right? So this is uric acid crystal. Very important, uric acid crystals form in acidic pH. So that is why to treat uric acid stones, we give citrate, okay, which is going to alkalinize the urine. So citrate is going to alkalinize the pH, and that's why it's used in the treatment of uric acid stones. It is also something which is linked with tumor lysis syndrome. So you have hyperuricemia with tumor lysis. Okay, so that's rhomboid shaped crystals, uric acid stones. Then you have this which looks like an envelope. So what are these envelope shaped crystals? This is calcium oxalate. Monohydrate or dihydrate? Dihydrate. And this is what is the most common stone in the urine. Then you have this dumbbell shaped crystal. So dumbbell shaped, remember Mona is dumb. Very insensitive mnemonic, but useful one. So calcium oxalate monohydrate. Mona is dumb. But Mona is very strong because Mona is lifting dumbbells, right? So calcium oxalate monohydrate is a very strong stone. Doesn't break easily on lithotripsy. So that's dumbbell. Okay. Then we have this stone which is coffin lid. Looks like a coffin lid. So this one is what is true white stones. What is true white? It's triple phosphate. What is triple phosphate? So you have magnesium, you have ammonium. So this is 2 plus, this is 1 plus. Phosphate is 3 minus. So ammonium, magnesium, phosphate, triple phosphate stones, true white stones. Now these are stones that form an alkaline pH, right? So this is what is associated with an infection, that is Proteus. You know, Proteus is urease positive, so it makes the pH alkaline. All right. And these true white stones can become bigger and form these stones called as staghorn calculi. We have studied this in radio as well. They occupy the complete collecting system. Okay, so that's true white stones. Then you have hexagon. Hexagon has 6 sides. 6 se kar do 16. Cystine. So this is cystine stones. This is seen in a condition called as cystinuria. In cystinuria, we have 4 amino acids that are not reabsorbed from the urine. They are passed in the urine. Cola. So obviously cystine. O is ornithine, lysine and arginine. Okay, so very self-explanatory. Cola. So you remember collatin. This is not cysteine. That is going to be in homocystinuria. This is cystine, collatin. Okay. Then we have lamellae, Lerse lamella, Lerse leucine crystals. And this is the one which looks like a thorn apple appearance. This is what is ammonium biurate crystals. Okay, so these are ammonium biurate crystals, and just one buzzword, they are linked with laxative abuse. Okay, so these are the different urine crystals and their shapes, so they can ask you an image based question. Let's talk about investigation of stones now. So the initial investigation, any patient who comes with colicky pain, loin to groin, you can do an X-ray or you can do an ultrasound. So X-ray is a better answer than ultrasound. So the concept here is, if the stone is in the kidney, I'll be able to visualize on ultrasound. Same thing as gallstones, I'll see shadowing. But if it is in the ureter, because it's retroperitoneal, I may not pick it up on ultrasound. So for that, ureteric stones, X-ray is better. Most likely when you have loin to groin pain, colic, it's in the ureter. Nephrolithiasis, renal stones rarely cause, colicky pain. So that is why X-ray would be a better answer if the patient has colicky pain. Best investigation though has been asked twice now is NCCT, right? Non-contrast CT scan, not ureteroscopy. A lot of students mark ureteroscopy, but ureteroscopy is only for distal ureter. It can remove the stones. How will you confirm the diagnosis with that? What if it's not in the lower ureter, right? So